Meeting will be starting at 8 a.m.
Good morning, everyone. How are we feeling? Good? Are we awake? Partial, maybe a little bit. Yeah. We're going to get started in about 10 minutes. I would ask that if you have not yet taken a seat, that you please work towards finding one. But we also are expecting a pretty full house today. So if you can conserve as many seats as you can by moving close to your neighbor, we would also appreciate that. So thank you so much for being here. We're grateful that you took the time to come out.
Good morning, everyone. We'd like to welcome you this morning. We're going to get started in about 5 minutes. So please begin to find your seats. Thank you.
Okay, good morning, everyone. Shall we get started? So thank you for coming. I'm Dacre Knight. I'm the medical director of the UVA EDS and Hypermobility Disorder Center. I'm joined by my associate director, Ina Stevens. If you want to give a wave. And we are very, very grateful for you all for being here. So we can't thank you enough. It's really kind of far exceeded our expectations. So what we're doing is we are ultimately bringing together researchers, clinicians, all of you here, patient voices, to be engaged over the next 2 days to learn from each other as we do in the clinic, in the research labs, and we have much to learn, as we know. So we do have a lot to get to today. So before we begin, I want to share Jessica's going to share a few housekeeping things with you just to make sure things move along smoothly.
Thank you, Dr. Knight. So my name's Jessica. I'm the nurse coordinator here in the EDS clinic, and I've been with Dr. Knight for a long time. So they're sending the nurse in to kind of get you guys straight here. Thank you. All right. Next year, I told them they need to clear out Scott Stadium and get that figured out so we can have a bigger venue. So I'm going to just quickly go over a few housekeeping things for us for the day. We ask that you move towards the center of the aisle so that it's easy for folks to come in and actually grab a seat as they're coming in for the symposium. And a friendly reminder to please silence your phones so that we don't hear those interesting ringtones going off. Feel free to come and go as you need based on the schedule. And at any time, you can actually view the digital program or join Zoom live stream. So that's always going to be available to you. You just need to scan the QR codes at the registration table and around the room. So you've got access 2 different ways. And all the sessions are being recorded, and you're going to be able to view them afterwards. So they will share the viewing after the event. Restrooms are located on the first floor near the registration table, and we have 2 overflow rooms. So we're expecting a lot of people today, and we didn't want to limit people from attending. So we've got 2 overflow rooms that will guide people to if this room should reach capacity. And the rooms are G1, which is directly across from the door, and right over here, and on the ground level in meeting room 1, which is on level 1, the same level that the registration table is on. We built time in for a couple questions after each session. And I know Dr. Knight will field these questions from the audience in this room. So we won't be using microphones in here. So if you have a question, be sure to raise your hand and speak loud and clearly so that we can hear and repeat your question as well. So we make sure we get our virtual audience able to hear it too. So we know that there are going to be a lot of questions today, and we know we won't be able to get all of them answered today. So we encourage you to reach out directly to the speakers during or after the event, and each speaker's contact information can be found on the digital program. So you've got access beyond that. Network with speakers. We're allowing time to be able to converse back and forth with you during the breaks and at lunch times. And speakers will have special name tags. You'll be able to identify them. They've got the gold banner underneath their name tag. If you need anything throughout the day, you can find staff members around at the registration table who will be able to help you. Okay, so we are in line. Okay, Dr. Knight, you're back up. Thank you.
All right. Thank you, Jessica. So now that we've covered those details, let's get started. To officially welcome us, I'd like to introduce Lori McMahon. Lori serves as Vice President for Research at the University of Virginia, as a role she assumed in June of 2024. She previously served as Vice President of Research and Professor of Neuroscience at the Medical University of South Carolina. She spent more than 2 decades at the University of Alabama at Birmingham in a number of senior leadership roles, including Dean of the Graduate School. Lori is a professor of neuroscience at UVA. Her work focuses on brain circuits involving in learning, memory, aging, and neurodegenerative disease. She brings deep experience in research leadership, mentorship, and interdisciplinary collaboration across the academic enterprise. Lori is really, I think we'd have to give her the most credit for us being here today. It was really her creative brainchild to have a group of researchers, as she typically does across the university, and specifically bring some of her colleagues from MUSC. And we're, of course, very welcome to it. It's remarkable to think that we've been able to achieve this less than a year starting the UVA EDS Center. But we really give it up to Lori for her vision of putting this on. So I thank you directly, Lori, and I know everyone here would thank you as well. So we're grateful of that. This cross-disciplinary collaboration, though, is something that I'm specifically grateful for being at University of Virginia. I have all the different academic institute enterprises and specialties and schools at the university. It's really remarkable joining of learning. So, and we recognize as we go through the day that there's so many different specialties that EDS crossover it goes into. So having this academic institution to be backing it up is really for the benefit of those clinicians and researchers and patients who are involved. So please join me in welcoming Lori McMahon.
Good morning, everyone. So thank you for those nice compliments, but you were way too generous, but thank you. So I am have the honor of welcoming all of you here. So all of the researchers, all of the clinical care providers, and most importantly, the patients. We are here for you. You are what inspire us and who are driving us to find better treatments, better diagnosis, and cures for EDS. So I'm so delighted to be here. I need to thank Ina. So Ina, thank you. I need to thank Dakri, thank you. And particularly Catherine West in the Office of the Vice President for Research for organizing this together with your teams and the large team that we have of 4 people in the Office of the Vice President for Research who put on this symposium today. And it's thrilling. It's thrilling for me. I think it's thrilling for everyone in this room that we are here today. And I will tell you, I feel starstruck. We have the best people, the biggest experts in EDS in this room today. And I thank all of you, all of the speakers who have traveled here. The best of the best are in this room, and we're going to learn from them today. So welcome. Thank you for being here. And I'm going to take a few minutes to tell you why I am so passionate about EDS. And it started at MUSC, and I'm going to call out Dr. Chip Norris. Chip, I see you in the back row. He is here from Medical University of South Carolina, and Sunil Patel, who's chair of neurosurgery at Medical University of South Carolina. When I arrived there as VPR in the summer of 21, about a week after I got there, I learned of this fundraising event, and the topic was EDS, and I did not know what EDS was. And I asked around, what is EDS? And that's the first time I heard about EDS. This was in the summer of 21. And Chip Norris's lab was the floor above my lab in the basic science building at MUSC. And I got to know Chip and his students and the patients who come to his lab every summer to work at the lab bench. And I'm not going to say more about that, Chip, because I think you'll probably tell us about that. But that's how I learned about EDS. And I immediately became a huge advocate and passionate about helping us, the research community and the clinical providers, make a difference. And we worked together, and I worked with the leadership at MUSC with help from Chip and Sunil to engage with the leadership at MUSC. And we made progress. And one piece of progress that I want to share with you is we convinced leadership to put a paragraph in the federal agenda book for MUSC to tell the lawmakers in Washington about the importance of EDS. And that year, so this was in 2022, that year, the Senate and the House, the Labor H bill, the bill that funds the NIH, there was our language in those bills asking NIH to fund research in EDS. So that was a big win for all of us. And then the NIH listened and invited Sunil and Chip to a 2-hour webinar. All 27 institutes at NIH wanted to hear from them about this problem, this clinical issue that NIH was really unaware of. And I know many of you, and Dr. Francomano, I know you've been leading this crusade, and Laura Bloom, you've been leading this crusade, and Matlin, wherever you are, you've been leading this crusade, and we are here today to join together all of these experts to push forward in this research, discovery, clinical care for the patients. It's all about the patients. And so we are thrilled to have you here today. We are thrilled to learn from each other today. And I will say this is the first of many more of these events to come. And we are going to continue to push the frontier and to educate all, to educate medical students and nursing students and physical therapy students and all the clinical care providers, and to educate our decision makers who make decisions about how the NIH is going to fund research, to put this at the forefront because we know, and the patients who are here in this room and online, we know you need us, and we are here to help. And there's so many of you. At our event today, we have over 2,500 people registered. Over 1,500 are online. So all of you who are online, we welcome you too. So this, I think, tells us the magnitude of what is needed. So I thank Chip and Sunil for enlightening me. And I thank all of the clinical leaders who are here. We're so glad. Ina, you started this clinic here at UVA, and I think it was a week after I got here that you and I engaged, and we talked about a symposium. And so thank you for all of what you have done for the patients and for research. And Dakri, we are so happy that you're here. So I will stop with my remarks, but I just want to say welcome, and I want to thank every one of you who's here. Thank you.
All right. Thank you so much, Dr. McMahon. And I'd like to add a few words. I know we've got a lot of speakers today chomping at the bit, but I do want to just carry on what Lori's message is and talk a little bit about what our vision is for this center. And I think that the vision for all of us is that there will be more of these centers across the country. There's really no reason that every academic institution shouldn't have something that's available for patients. So yes, thank you. Thank you all for being here, for those of you in Charlottesville. And there are many, many more online across the country and around the world. And what these reflects, I mean, certainly these are large numbers. 2,500 registrants is incredible. But what this represents is that there is a shared recognition that the current model for EDS care is not enough. And more importantly, that it can be better. So we've already been discussing what is kind of the care that we want to deliver, but I think it is important for us to share what is that discussion with you all, because it gives an idea of what we're thinking, and what we're thinking is, it determines what we see. And we want to be able to see patients for who they are and treat them for who they are. So I know we all love the list versions now of articles, the TLDR. So I'll give you just 5 pillars, and we're going to just swing right through these. So these are precision and curiosity, human-centered care, partnership, and systems. And among those 5 things, we have already started, got the groundswell for this huge unmet need, that we're rising to meet that need ourselves. So for precision and curiosity, let me begin with a simple yet uncomfortable truth. And that is that we simply do not know everything there is to know in medicine. Now, that seems like a oversimplified platitude, I understand. But when we first embrace that, only then can we move forward, when we can advance our understanding. And it's often, I see, unfortunately, in cases where clinicians, I mean, we go through lots of school, we go through lots of tests. We don't want to be told that we're wrong. We don't want to be told that there's more to learn. We've already spent how many years of learning? How much more could we possibly do, right? But the truth be told is that there is so much research going on. There is so much that we have to keep up with. And when we keep up with it, it's for the betterment of our patients. So we have to meet the patients with that curiosity. And we reject the idea, what we have to embrace humility is what we really ultimately have to do. We have to be humble. We can't allow our degrees to bring this hubris that we have known and we already know that everything there is to know. And we also, we have to approach it with precision, because what we're learning in the labs, our own clinical insight, our own clinical experience guides us. to see the patient in front of us. And it's not just the average patient. We know these patients do not fit into a checkbox. It does not meet a simple algorithm. So when it comes to precision, precision really in itself is not enough if we define success too narrowly. We have to think about the humanity and the humility that we bring to it. So the human-centered aspect of this care is important. The learning goes both ways. And it's often that patients become experts in these conditions, not by choice, but by necessity. So we reject this one direction approach of care. And I have learned personally, and I know many others who have been in this field have learned so much from patients. And that is really is an act of courage that patients come to us seeking help, especially if they've gone so long without getting the right help. So to come again, to seek help again, to trust again, that is not a sign of weakness. That is a sign of strength. And we need to meet that strength and that courage with patients where they are. So this comes to that pillar of partnership and embracing that what we're not trying to do is just make a diagnosis. We are building a relationship together, and we are on a path of discovery together between clinicians and patients. So this brings me to the final pillar. So from precision, curiosity, to human-centered care, to systems. We know that these conditions do not sit in isolation. We know that, as we will learn through our talks today, that there is a lot of biology going on, but these conditions are also shaped by the systems that patients come from. So whether it's the health systems, the medical systems, the cultural narratives of pain and suffering. And we know that if we invest early into the care of patients, then not only are we helping the individual in front of us, but we are strengthening the system itself. And that is what we need to move forward with and into advancing the care of patients with EDS and HSD. So of the systems, what we know is that there is the role of humanity. We are measured by how we care for our most vulnerable as human beings. And healthcare, at its best, is an example of that value. But we certainly have to do our best to bring that. So what are we doing here? What is our aim with this program? Well, yes, we are aiming to treat and to advance care, but it's something I'd say maybe even more ambitious and maybe even older, what the Greeks would describe as eudaimonia, which is living with purpose and value. And here at just a couple of buildings down, the Contemplative Sciences Center, which I encourage you to visit if you have time while you're in Charlottesville. It's a beautiful building. They're doing excellent work. But the director, Kelly Crace, studies flourishing. And that's what we want for our patients, for our program, our system. We want to be flourishing because it comes with purposeful living, it's enjoyment, it's fulfillment. And it's all of those things. We talk about quality of life for our patients, but not very often do we define it as it should be. So to you all, I know this is what we're all here for. And we're doing as much as we can here. We've got a symposium already. We've got a volunteer group who have already committed to helping patients like themselves. We've got medical education, we've got medical students, we've got residents. We've already met with the dean of the medical school, building in curricula so that medical students can be the next generation of doctors coming forward with this knowledge already in hand. And that's the way I think that it's going to advance, not only with medical students, but also residents. We have residency program that we're gifted to have here at the University of Virginia. But again, I would love to see that this is something that's going to be brought at any academic institution across the country. So we're charging forward to be that example, ultimately to be more precise, to be more human, and to be more collaborative in what we do. So to you all here, I know we've got quite a mix. We've got researchers, we've got clinicians, we've got volunteers, we've got family members, We've got patients, we've got caregivers, we got friends, we got partners, we got administrators. To all of you, thank you for being here because you are part of that change, truly. And we are just beginning. Thank you. So let's get started with some talks. I know they're just burning in their seats, so we don't need to delay any further. Our first speaker, I'm honored to say, is a friend of mine and a colleague, Dr. Caitlin Bruno. She is an assistant professor of cardiovascular medicine at the University of Florida. She has affiliated appointments in physiology and aging and pharmacology and therapeutics. She also has a research collaborator appointment at Mayo Clinic, and she serves as deputy director of the Center for Regenerative Medicine. Dr. Bruno received her PhD from Johns Hopkins Bloomberg School of Public Health and completed her postdoctoral training at Mayo Clinic. Her research spans translational science, cardiology, immunology, and sex differences in disease. Please join me in welcoming Dr. Bruno.
Thank you. Thank you for having me here today. So today, as kind of the first talk, what I'm going to talk about is the creation of our EDS clinic at Mayo, which Dr. Knight ran for a long time, and we are very sad to not have him there anymore. But what I'm really going to talk about is how we formed the clinic in focusing on integration of clinical care, of research, and patient involvement, and what that's led to. Thank you. That's helpful. At Mayo Clinic. So as stated, so I'm now at University of Florida and I'm a professor there, but I am still the co-director of research with Dr. Fairweather, who will be speaking later at Mayo Clinic. And so what's really important about this is with our integration, when we started this clinic, it started with patients. So I actually have hypermobile Ehlers-Danlos, and this clinic started, and they wanted to bring the clinical care in. They integrated us from the very beginning. So they came to me as a patient who was doing research with my providers and was a researcher, and we built this clinic around patients, around research, and around helping patients in clinical care. And so I'm going to talk about some of our experiences. Oh, maybe this doesn't work. We'll just use this. Okay. I have nothing to disclose. So we're going to talk about our Ehlers-Danlos clinic at Mayo. Some of our findings in comorbidities that we see in patients comparing hypermobile Ehlers-Danlos and HSD, and examine some of our clinic outcomes and patient feedback. Everyone here and on this call is going to have this, know this information. What we're really talking about here is hypermobile Ehlers-Danlos and hypermobility spectrum disorder, being the most common form of Ehlers-Danlos, affecting 255 million people, having a sex difference, and being a collagen disorder that causes a number of comorbidities, but no known genetic mutation. And it's really a clinical diagnosis. So when we wanted to help clinical care, when we were building this clinic, everything was focused on helping patients. So we started our clinic in November 2019. And from that very beginning, we started, yeah, that does work. Okay. We built an intake questionnaire that had research integrated into it. So patients would get this email before their appointment that Jessica would send out when she was there. And they would take this questionnaire that was over 400 questions. It would take over an hour to complete. And it contained a number of different questionnaires that helped us know what was going on with patients before they got into clinic. Because patients with Ehlers-Danlos every body system is affected. So then you need to collect a lot of information, and there isn't enough time in the day to collect everything about an EDS patient. And so we built this form with research in mind, but really with collecting the data that the clinicians needed in advance, so that when they sat down with that patient, they could really focus on what that patient needed next. And they already had the information about who that patient was and what they were experiencing. The other thing that we started from the very first patient is a biobank. So collecting sera, plasma, PBMCs, as well as blood for RNA analysis down the line. And so we started this from that very beginning. So we had the clinical data, we had the self-reported data, and we had our biobank. So this is an overview. This is how we the very beginning of our clinic, how we started it. And so this was the first paper we published after starting the clinic about our workflow. So patients could come in to the clinic by self-referral, referral at Mayo, or external referrals. Before the visit, there was a triage, the medical intake questionnaire. They're actually consented for research. They receive an email to say, are they interested in research even before they come to that clinic, and get some family history. At the clinic, they have a very comprehensive appointment, genetic testing if indicated, blood work, and then they actually have their research blood draw if they decided to consent. And then they're done with the research side of the study. After, they have some standard and optional tests that they can have. And then they get referrals based on what we find in this intake questionnaire, based on what's found in that medical consultation. They could have referrals to any area within Mayo Clinic or externally. But they all, at that very first appointment, get referrals for physical therapy and occupational therapy, just to help educate them and help those patients. And then at the time we were doing, I'm not sure if they're still doing the follow-up video visits. Sorry. Yeah. So there's the video visit to discuss any results from testing. So, say they had any autonomic reflux screening, and then now they need to get a referral into the POTS clinic or things along those lines. So there's some follow-up there, and then a plan for where they're going to go. So this is the clinic that, this is how we built this clinic to help patients. But when we talked about that intake questionnaire and this hundreds and hundreds of questions and this hours of time that would take a nurse to collect when they first meet the patient, what we did is every question that was on that questionnaire, we were able to build into an Epic note. And so when that patient put their name in, when that patient put their age in, when that patient put where they live, when they said how long that they've had symptoms, when they talked about if they had easy bruising, if they had an echo, if they had any kind of symptoms related to potentially POTS. These questions says, the question would be, do you have dizziness from when you go from lying to standing? And they would say yes or no. And so Dr. Knight or Jessica wouldn't have to read through those hundreds of questions. They told us what questions do they really need to know the answer to before they even see that patient. And so what we did is we built this so that they could read this couple of paragraphs, these couple of results from some standard questionnaires, and have that information before the patient even walked into the room, and then copy paste this straight into an Epic note to save time so that they could focus on the patient one-on-one rather than the documentation. And so this is what was really important to us, is really to support the clinic so that everything could move smoothly. And everything then was also being able to be used for research. And we also collected follow-up and quality improvement data through these questionnaires. So what is our clinic? What is our clinic right now? So I pulled these numbers last week. So we've had over almost 6,000 patients have scheduled an appointment with the Mayo Ehlers-Danlos Clinic since 2019. Almost 5,000 have attended those appointments and completed that intake appointment. 95% have finished that intake questionnaire. They're sent reminders, but patients are busy and sometimes that doesn't happen, which then they still can come to that appointment, and it's just a little bit more work for the nurse to collect that information that's needed. But 94% collect that extensive information that we're able to then use for a retrospective chart review and for research. And then 43% consent to our research blood draw for our biobank. And that's not done. That's all in advance. So they read the things they can call, they can consent at the appointment as well. But this is a limited amount of work for our clinicians to do because we send it out in advance, but we can then do research down the line. So what do our patients at Mayo look like with diagnosis? So here, what we have is the different possible diagnoses that the clinicians in the Ehlers-Danlos Clinic at Mayo give. About 25% of patients coming into the clinic, so this is of this almost 5,000, get diagnosed with hypermobile Ehlers-Danlos. 50% get diagnosed with hypermobility spectrum disorder. About 5% get diagnosed with the localized hypermobility spectrum disorder. 6% with the historical HSD. 12% get diagnosed with possible other connective tissue disorders. And then we have this, and let me say this is based, the HSD, EDS, and the other possible, we are using the 2017 criteria for diagnosing at Mayo. This control, this 1% control, so this is about 500 patients, these controls. These are not healthy controls. These are patients who think they have EDS. They are coming to the Ehlers-Danlos Clinic to try to get answers, but they do not meet the criteria for any of these other conditions. And so we kind of have an internal control within our clinic of patients who are not hypermobile. They may have pain, they have other comorbidities, but that gives us a very easy way to try to understand what makes these patients unique and how can we help those patients specifically. Just some more demographics of our kind of patients. Our patients at our clinic are almost 90% white, 90% female, and 85% not Hispanic. So this is when I show you some of this research. And today you're going to hear talks from Dr. Fairweather and Shulpa. I'm really giving a big introduction, the big picture of the patients they're going to the data and the stuff they're going to talk about later. So this gives you an idea of who these patients are that we're seeing. So research, I'm a PhD scientist. I'm a basic scientist. My main research is in inflammation and cardiovascular disease. But as I mentioned, as a patient, I was having to do my own research. I was doing research, retrospective chart reviews with my clinicians, with my physical therapist, with my neurologist. And so when the leadership came to us, when they first came up with the idea of this clinic, they wanted to integrate research, and because they knew we were doing research as patients, me and Dr. Fairweather, they asked us to get involved from the beginning. And so we were able to start research, as I mentioned, from the very beginning. So I'm just going to highlight a couple of our big picture findings here, and then I know that you'll see more of our research later. This is a paper we published in 2024 where we were looking at similarities and differences between EDS and HSD. And so these are self-reported. This is that intake questionnaire that they take before that first appointment. This has everything from, as I said, demographics to self-reported symptoms and comorbidities to standardized questions like the fibromyalgia questionnaire, chronic fatigue questionnaires, work impact questionnaires. So all of this is integrated that we're able to do research on. So this paper really focused on 115 symptoms and comorbidities that could be reported. We had about 2,000 patients in this study. 93% were female. The average age was 34 years old. And this paper specifically focused on HEDS and HSD diagnosis. And so what you'll see here is comparing those symptoms and comorbidities. Patients with EDS had, there was about 8% of those 115 that they had that were more prevalent than the HSD patients. And these really focused around, the big ones were dislocations, hernias, and prolapse. Our HSD patients, they had 37% of those 115 that were significantly more prevalent than the EDS. And these were related to joint and muscle symptoms, neurological symptoms, and gastrointestinal dysfunction. And then the conditions that were really overlapping that both of these patients really had no difference and were really high were allergy and atopy and headaches and migraines. So these are some of our big picture findings. But in this paper, you can see all those 115, that data from every single condition, every question that we asked, and the differences. So these are some of those conditions of that 37% that were increased in HSD patients. So what you see first is blue being our HSD patients, gray being our EDS patients. And these are grouped by kind of condition types. So you've got joint and muscle, allergy, neurological, gastrointestinal, sleep, and psychological conditions. And this, you can look at all the list of all of them, but what you're finding here is in this slide, these conditions were significantly more prevalent in our HSD patients compared to our EDS patients. And then the conditions, that 8% that were increased in, this is just a snapshot of that, in our EDS patients here with the gray having a more reporting of this, include like we said, the dislocations, prolapse, hernias, and things like that. So these are just, we want to start understanding who the patients are, what they're presenting with, so that we know how to help every patient on an individualized basis. So another study that we just published in 2015 took this a step further. So originally, when we first started the clinic, we grouped patients with localized hypermobile spectrum or hypermobility spectrum disorder or historical HSD in with the controls, because they did not meet criteria by the 2017 criteria for EDS, and they did not meet criteria for HSD or other connective tissue disorder. So they got lumped into a control category. But Dr. Knight and the team at Mayo Clinic were making notes in these patients' charts, say if they had localized, so they have a joint area that may not focus on be part of the Beighton score and things along those lines, or they would have tested positive by the 2017 criteria historically, so or they had a historical diagnosis. And so we then pulled out of this control group these patients. We pulled them out into their own group to say, okay, these patients, they may not have EDS or HSD, but they have some hypermobility, or they had it in the past. And what we interestingly found is the gray bar here is your controls. This pink salmon bar is your EDS patients, yellow, orange being HSD, and then the localized or historical being the red. And this is some of those conditions that the comorbidities that we looked at that were actually increased, yes, in EDS and HSD were higher than control, but these patients that we had, the localized or historical, actually were presenting with all of the same patients, the same conditions the EDS or HSD patients were presenting with, but actually even higher for a lot of comorbidities, for wheezing, joint pain, ADHD, constipation. And so we just, this is very much a big push at Mayo, or something that's really important at Mayo, is individualized medicine. And this just shows us that it's not just individualized medicine in a EDS as a whole family. We really need to pay attention to who that patient is and what they need support on. So then, the third pillar of Mayo and of our clinic is patients, and not just getting patients integrated from the start. You can build something with patient feedback, but if you don't continue to take that patient feedback throughout the process and grow and change for those patients, then your clinic is not supporting the patients properly. And so that was something that was really important in starting our clinic. So from that very first appointment, or before that very first appointment, we formed a patient advocacy or advisory group and had workshops where we asked the patients what was important, where we had sticky notes all over the walls with ideas or what the problems were and things like that, that we want, that they wanted us to address. And so we really wanted to integrate that from the start, but we still have those meetings monthly. So we have these patient advocacy meetings with a small group of patients on Zoom that gets feedback from their clinical experiences or other clinic experiences. We ask advice on clinical questions, not my clinical, everyone's clinical questions, but we ask advice on, the questionnaire that they take. Is there anything that needs changed? Is there something that, you were uncomfortable with? Is there something we need to change? Is there something that's missing that you really think is important that we need to understand about patients? And also, if there's something that we have interest in research-wise or clinical research-wise that we want to add to this questionnaire, we would send it to this group and say, hey, does this make sense? and they may help us reword. They may say, this question doesn't make sense, or hey, you didn't have this answer option. And so we have really used the advice of this group of patients to really keep improving and keep affecting the clinic. And then also we use this to help educate on new resources and support aids. And then they educate us on new, oh, I found out about, everyone knows about silver ring splints, but maybe there's something new, and so they may know because they're seeing it from their big, huge communities, that can help us then educate the patients. And then we also kind of give them updates on data and papers and things like that. And then we also at Mayo have this Ehlers-Danlos syndrome blog where patients as well clinicians and researchers can make posts to continue to educate each other. So what is the feedback that we've gotten from the clinic as well as from patients? So we don't want to just take that feedback to inform our clinic. We want to make that public. We want people to know, we wrote a paper about forming the clinic. We need to give, the community who may be starting new clinics the feedback that we are getting. We need to make that public too. And so this was a study that we recently published looking at patient feedback based on Ehlers-Danlos clinic follow-up. So they get a questionnaire sent to them after they have completed all of their referrals, they've had their follow-up, and we wanted to know what referrals are the most helpful. Where are we not supporting you properly? And so this top two graphs here are patients with EDS. Bottom two are HSD. This column here are pain-related referrals, and then these are other referrals. So what you'll see here, and they're rated by the most, what patients felt were the most helpful. They helped them improve the most after this referral. So acupuncture, both in HSD and EDS, sorry, I've switched those, but they reported the most improvement after those referrals. The least improvement was the pain rehabilitation clinic at Mayo, which is a long-term program there. So they actually had the least improvement and actually felt like they got worse after these appointments. And then our other kind of conditions, we had optometry had the best feedback. They had the best feedback, and the worst feedback, or the patients felt they got worse after them, was allergy and immunology. And so we take this information and then we go and say, okay, well, can we reach out to allergy and immunology? Can we find a provider within that who cares and wants to help support and be involved with patients? Because if a patient gets a referral, if we send them a referral to allergy and immunology and they get there and they don't feel seen, if they feel, like they're not listened to, then we're not supporting them properly. So we actually reach out to, and now we have an advocate within allergy and immunology at Mayo who can help support our patients, who wants to do research, who wants to help these patients clinically, who wants to learn. And so we are going to help these, 50%, 75% of these patients who had a bad experience, who felt that they got worse. We're trying to reverse that. So we're taking that feedback in our clinical care and our research. And then we also have a program at Mayo that's an EDS virtual education program. So after they get a diagnosis, they are invited to attend this program, which Jessica ran. And this is kind of a highlight of our feedback from that program. So this program focuses on group discussion, demonstration, explanation, examples, handouts, working together. And there's talks from physical therapy and OT, but then there talks from, pelvic health, women's health. There's going to be talks from all different areas that these patients could be experiencing. And so we collected some feedback on that and how they thought this clinic worked. And so we asked, did it help them feel like they had a better understanding? And this is grayscale, so it's hard. So I'll just, we saw that most of the patients, the majority of the patients in this gray and black, felt like it helped their understanding. It had them feel hope for improving. It made them feel like they had the tools, that they could address their needs specifically, and that they would recommend this program. So almost every patient, only one patient didn't agree, that this program could help them and help other patients. And so we've taken this feedback, we use this to then improve the education program as well as the clinic overall. So what are our kind of future directions at our clinic? We have over 2,000 biobanked specimens at our clinic that are being analyzed for studies. Dr. Fairweather is going to talk about some of those results, but we're constantly still researching, coming up with new research questions and using this to do that. We are seeing or collecting about 30 patient samples a week and seeing more clinical data than that a week, but we see about 30 samples are being processed in Dr. Fairweather's lab every week. And we really are focused, you know, there's different labs focused on different things, different researchers. There's labs focused on genetics, there's labs focused on other things, but we really focused on the gene and protein pathways that are involved to try to understand the mechanism of disease to then help patients. So we're going to continue to investigate that self-reported intake questionnaire data that we get from these patients. We have over 4,000 patients, so we have lots of potential research questions we can answer with those patient populations, as well as helping them clinically. And then we are also able to pull information out of Epic, out of the medical record, to confirm self-reported findings. So if someone's reporting that they have POTS, then we can go look at their autonomic testing. We can look at their actual evaluations. We can look at their diagnoses and confirm those findings. We can go look at the MRIs and look and see if they have you know, nutcracker that is undiagnosed or things like that. So we're able to go in and use Epic to answer research questions that may have started with a patient or may have started with this intake questionnaire. So in summary, we have found, and I know Dr. Knight is bringing this here as well, and we hope other clinics across the US and world will really focus on this as well, as really integrating that clinical care. You're going to help that patient clinically, integrate the research, because that's going to, patients are going to educate you in your research, and you're going to hopefully help move things forward in the clinic with research, and then have patient involvement at every step of the way. And so we have clinical staff and research working side by side to really accelerate discovery and accelerate patient care. Formation of biobanks and databases from the very beginning, or as soon as you can, are so important, because you may have a research question that you come up with in 2 years and you're like, man, I really wish I'd asked that question, or I really wish I had some blood to find this biomarker or to do something here. And so doing that from the very beginning is just so important, because when I have that question in 2 years, I have 4,000 people who've already answered that question. I have 2,000 blood samples that I can test. Advocacy groups and feedback from patients is huge. You have to make adjustments. You can't just get the feedback. You can't just publish a paper about the feedback. You've got to do something about that feedback. So you've got to go to allergy and immunology and find somebody for these patients that will have a good experience. You'll have to change the questionnaire. You have to take questions out. You add questions in. You use those adjustments. You don't just ask for feedback. You use that feedback. And then, you know, a little plug here, basic scientists are awesome. You know, so, you know, we can bring very unique perspectives to clinical projects, and working together, you know, what a drug that's used in clinics started in a lab, you know, that we make a difference from bench to bedside and then bedside to bench. And that's really what we are trying to do here. Ooh. So I just wanted to acknowledge, of course, my co-research director, Dr. Fairweather, and our former medical director, Dr. Knight, because all of this data I presented and really all the work we've done since 2019, we've done together and with Jessica. And of course, you can't list everyone. This slide would be tiny, but Dr. Fairweather's lab processes, you know, these 2,000 patient samples, processes these every day. Francis is here, one of the people who really helps keep our program going. And as well as Shulpa's here, the rest of our EDS clinic staff, clinicians, nurses, support. I am, like I said, I'm now at University of Florida, so I have my little lab now, and so I got to thank them for supporting me and our funding that really allows us to do this research and to really help patients in the long run. So thank you.
We do have time for a couple questions, if there are questions from the audience.
Yeah. So the question was, can patients who aren't patients at Mayo or maybe aren't at UVA, can they be involved in maybe providing feedback, taking the questionnaire, doing a blood draw? So it depends on your the institution. At Mayo, the way our program works is the only patients who are enrolled are patients who are being seen by the EDS clinic. So I've had a diagnosis for a very long time, but I wanted to be involved in the research as well. So I actually went and saw Dr. Knight and had, because it's not just a diagnosis clinic at Mayo, and it's also if you need referrals, and things like that. So I used it for that side of things. But yeah, our clinic specifically, you have to be a patient at Mayo. There are different institutions that have different, so some of my other research at University of Florida, I can have patients come in and they can make them a medical record and they can come do blood draws and be involved. But our clinic at Mayo is you have to be a patient. But that could be something that is thought about here. Yeah, but there is studies, of course the people here aren't the only ones doing, there's research people who are doing remote blood draws or remote surveys. And I think a lot of that's listed on the Ehlers-Danlos website. So there are abilities to do remote studies and things like that. So I would direct you to the society. Oh, and, yeah.
You've mentioned the number of patients.
Yeah.
I'm wondering how many patients have been lost by both clinics. For example, I've known my entire life that I've had hypermobility of some sort. I came across the term Ehlers-Danlos kind of randomly in 1996. Seems like it's pretty close to what I'm dealing with. I was living in Minneapolis, St. Paul before the pandemic, and my doctor referred me to Mayo Clinic. I did the big intake with your triage. I did multi-hour form, and what I got, I had no idea that you had the EDS clinic.
Yeah.
But the feedback that I got was, we can't help you. You know as much as we do about your situation. Go away. I had my doctor restart that, and she got exactly the same feedback. Then I moved to Virginia in 2021. I signed up for UVA genetic clinic in 2022, and I only found out about the EDS clinic here by a random Google search of something else that apparently I have been lost in the system also at UVA. So how many other patients are you guys losing and not including in your studies or anything else too? And how many people are getting frustrated because they've been dropped by both?
Kind of paraphrase our question.
Yeah. Of course. The question was how many patients are getting lost because she had an experience where she was lost from the EDS clinic where they said they couldn't help her specifically at Mayo. And UVA. Yeah. So I will speak to the time when we first started this clinic, the initial thought was the clinic was only going to be for diagnosis. And we really fought that as people, because you need that clinical, someone may have a diagnosis, but they don't have the support. They don't have the referrals they need outside. And so we tried to make that improvement. I think when you were talking, that's when that happened. The other side of things, we do lose patients at Mayo because there is insurance issues. Mayo Clinic doesn't take Medicare, and so that affects that affects patients for sure, and we lose patients that way where we're not able to support them, unfortunately. And then the other thing about our clinic is it is very much you get either the diagnosis or you get the referrals, and then you are expected to then your primary care is expected to manage you. It's not a management clinic, it's a diagnosis and coordinated care clinic. So we are gonna, you're gonna lose people, because of that. So, we all wish that we could help every single patient, and we know that we lose people and that we aren't supporting people the way that we should every time. But we are trying. So we made that improvement. We knew that there was an issue, that it's, these patients don't just need diagnosis, they need that support. You may have a diagnosis and have never seen a neurologist, and you have daily migraines because you never got that referral, and we want to help that side of patients. But we can't, unfortunately, help everyone, and I wish we could, but hopefully between the different ones, people who may have been lost can get found.
We have time for just one more question. I think it was one over here.
I have 3 kids, all with and my wife research probably 50 doctors, probably had hundreds, all kinds of abnormalities that are relevant. And I think what you miss is a lot of sort of looking for the patient feedback that I think parents are
Yeah.
kids. On any given day, you can talk to them and say, "Cough, doesn't cough." Well, they have participated yesterday, say that cough or any other number of things, and they sit in front of you on a questionnaire and they say, "No, I'm fine."
My mom does that too. Yeah, of course. Yeah. The question was about making sure to, or statement more, suggestion is to make sure you include the patients or the parents of patients, whether they're very young or even in college, in the collection of information clinically and for research. Our clinic at Mayo can only see patients 16 and up, and they have to consent or assent, and the parents have to consent, and they are involved. And can't speak clinically, but I am sure, Dr. Knight, I can speak for the fact that my mom has Ehlers-Danlos, and I made her come to the clinic. My sister came, and I was in that room, and mom be like, I get a headache once a month. I was like, no, you get a headache every day, So, it goes both ways. We take care, they take care of you, and then you take care of them. And so I know for a fact that Dr. Knight and the EDS clinic at Mayo listens to the parents and children, to make sure that they get the whole story, that they can support everything that patient needs. So thank you. I'm here all week.
Okay, thank you so much, Dr. Bruno. There's a lot that's been going on and a lot more to do, as we know. So our next speaker, I'd like to introduce Dr. Stephen Smith, and another speaker I'm glad to also call my friend and colleague and collaborator on research studies. Dr. Smith is a physician specializing in vascular and interventional radiology. He has clinical expertise in complex venous and circulatory disorders. His work has explored connections between pelvic venous disease, autonomic dysfunction, and Ehlers-Danlos syndromes, bringing together important clinical insights to this area. Please join me in welcoming Dr. Smith.
How does this thing work? Okay. This goes forward. Okay. Hi, everybody. I'm a private practice interventional radiologist. I'm retired. I'm just here because I got caught into a bunch of strange patients and kept going, and I don't fish, so anyway. So get out your phone and see if this works. This should take you to a library of PDF articles, and the ones that are about what you all know about are probably kindergarten or something, but hopefully there'll be something good. So that's a picture of the wall of my apartment in Chicago, and I was like trying to figure out what was wrong with my patients. So I hope this works. If it doesn't, maybe I can fix it later. Okay. All right. So don't, do copyright things. So this is just a picture of the people that helped me over the last 10 years of being an outsider. And so I'm here really as an outsider. Let's see. The guy sitting there in the t-shirt is Mike Sicklum. He's been my partner for many years. He wrote a paper on pelvic congestion syndrome as a fellow at Northwestern in, I don't know, 94. And then sitting over in the corner is Brenda Chen. She was a medical assistant in our office. Now she's graduating from medical school next month. There's Dr. Knight. And next to him is Ann Roberts, who's an author on the Ormiston paper. And she was chief and still is an interventional radiologist at UCSD. Below her with the red is Grace Knutson, and you Mayo Clinic people get to know her because she's the most knowledgeable person in your system about this stuff. Next is the kindly looking guy with the glasses. That's Peter Rowe, who has been an author on a lot of, pelvic congestion syndrome articles at Johns Hopkins going way back into the 90s. Then the woman giving you the piercing look is our statistics person, my sister. She's an anthropologist. She's looking at me saying, "Can't you understand this, man?" No. And then Dr. Brooke Spencer is in the upper corner there, and she's done more of these cases by now than anyone. So here's the problem. As somebody coming into your world, basically, this is what's supposed to figure out everything. The general guy is supposed to be able to recognize stuff and then send you to the other specialist who is totally bored with everything that isn't in his little bailiwick. And so the Mayo Clinic, I guess, works with a lot more of these people. Okay, but the idea is you can recognize everything and send everybody to the right person. Okay. But so I can tell you from the pelvic pain, world, doctors who are experts in pelvic pain don't understand pelvic pain. They really don't. And we give things names, and there are some of those there, but the ones that are sort of in orange, by the way, everything in orange you should pay attention to, and the rest you don't have to. So vulvodynia is a good example. I'll tell you right now, there's no such thing as vulvodynia as defined, okay? And we want to classify things. Patients want to know what's wrong with them. And so William of Ockham here would say, no, don't do that. That just by classifying things, putting people in a category, you've changed your relationship with the truth, okay? So let's talk about chronic pelvic pain of venous origin, or pelvic congestion, or we call it pelvic venous disorder now. Chronic, 6 months at least, pelvic pain in women, non-cyclic, but worse around ovulation or menses. Non-cyclic because it can occur at other times. So something's wrong with the pelvic veins, creating flow, congestion, aching pain, and that may be related to substance P and CGRP generation. It occurs when you're upright, not laying down. It's progressive during the day, and I'll tell you that the one real clue is it's never present upon awakening. And of course, narrowing of the left renal vein or iliac veins can shunt blood around, and it's associated with varicose veins elsewhere, and people have known about it for a long time. Other causes of pain, and these are the causes of pain that could get figured out by, having patients shunted off to, I don't know, gynecologists or whatever. So how common is this condition I'm talking to you about? So one way to think of it is 30% of women with chronic pelvic pain have it's caused by their veins, okay, not all the other stuff. So maybe you could say 5% of women have this condition in the US. Wow. But why isn't this in every headline, Billions are spent 10 million women, according to the literature of the gynecologists, have vulvodynia. Wow, that's a lot. So where do I get that? How can I say that? Because you could talk to somebody else who would tell you something completely different. So really the only study was done by this guy, Soysal, who wanted to see, he wanted to test a drug that he thought would help women who had pelvic congestion syndrome, but which patients have pelvic congestion syndrome. So he did venography and he did surgery and he looked for every single cause. And what he came up with is this: 31% of the women who had chronic pelvic pain had pelvic congestion. Only 12% had the veins, but had some other pathology. And the next commonest was endometriosis at 39%. So we could say, based on this, and I don't think there's any other study that did this, 30 to 43% of chronic pelvic pain is caused by pelvic veins. And yet, believe me, women with pelvic pains, no one's checking their veins. So endometriosis is the big deal in your world, and it's on like the big pot study or something. It's like, it's in there as one of the things. Oh yeah, some of the women have pelvic pains and must be endometriosis. It ain't. Well, it is. It can be, but endometriosis can be terrible. I'm not saying that if somebody has endometriosis, they really don't have endometriosis. Endometriosis is its own thing, but it's all that in your world. It's all you've had. So it's time to start, looking for what's causing stuff. So this is just a look at the chart. You can see there are these stringy blue things. Those are the ovarian veins. They're supposed to be small. Remember, blood flow in veins is always going up toward the heart, never going down or away from the heart. And this is a venogram, and it just shows a giant hose-like left ovarian vein. And when you inject in the renal vein, the stuff goes down. And then over here, you see that there are huge veins there. Now, what are we looking at? There's like a donut in the middle. That's where the uterus is. And these veins are going through the wall of the uterus. They're huge, and blood is going down and flowing through there and across. Once veins or arteries get big enough, the law of Laplace starts to have an effect, which says that for the same pressure inside, the tension of the wall increases as the radius increases. And there's Laplace. It's also called the law of aneurysms. Okay, so everybody has heard about this. This is, we call it May-Thurner anatomy. And over here it shows there's a red artery sort of crossing some blue things, including the left common iliac vein. And in cross-section diagram, you can see how there's a vein that's sort of squashed against the bone. And then right below that is the CT scan, which is the same picture, okay? May-Thurner anatomy. That's not May-Thurner syndrome, which is a painful vein compression syndrome, but it's interestingly, look at this. Prevalent in young middle-aged women, risk factors are immobilization, dehydration, surgery, hormones, and genetic factors. Gee, what else do you see what I'm saying? Are you picking it up? So, but just a pinched vein isn't that. And this is just a patient who came into her doctor's office with pain in her leg. She didn't have DVT in her leg, and she had just a dusky looking foot, and her doctor diagnosed May-Thurner syndrome correctly. But so, is it hard to detect these? Why are we having, why is everybody not making the diagnosis? So if you set out to evaluate pelvic veins with Doppler ultrasound, works pretty well. MRV is the best, and it has the highest sensitivity. I think CTA is good. Computed tomography is good. And we used to do ovarian venography, but I would never do it for diagnosis. So if we go in to look, we're going to fix something. I mean, we go in with intent to treat. Intravascular ultrasound, if you look at the bottom middle, you see this thing looks like, there's a little catheter, it looks like airport radar. And what it can do is it can take an area you know, and then a narrowed area, and then it can compare them, so it can compare the narrowed area with a normal area. And then if you look over on the right, this is an actual venogram. Down at the bottom, there's a little catheter. So it's injecting, and the stuff is trying to come up the iliacs on the left, and it's just cut off. It looks like you laid your finger on it. Everybody can see that. And the contrast has to take side roads and try and get up. And I'm not going to talk about nutcracker and stuff like that too much, but you can see. So somebody comes in, they got pelvic pain, they get a big workup for endometriosis, but they have this, but you can't see this from the outside. So laparoscopy finds endometriosis. So if you look here on the left, you see there's the uterus. It has little kind of glistening little spots on it. Everybody see that? That's endometriosis, okay? But if you look above the uterus, you see these snaky blue things. Everybody see that? So remember in laparoscopy, patients Trendelenburg, and they're pressurizing the abdomen, a lot of stuff to collapse veins. So what I'm saying is that this doesn't get diagnosed on laparoscopy. And that's another reason that you send your patient with pelvic pain to a gynecologist. Many gynecologists, they're not going to make the diagnosis. If you look over here on the right, this Grace Knutinen of Mayo Clinic Scottsdale and some of the gynecologists out there just presented this and won some kind of a prize, but the purpose of this is to clue in the people to make the diagnosis, you know, who do laparoscopy. So this is bad, and I can say it, I'm retired, I'm going to just tell you the truth. So no, this is terrible. So here's an article from JAMA, and it's written by some people who are on the board of the International Pelvic Pain Society. And I got a call from Peter Rowe. He goes, have you seen this? This giant article on chronic pelvic pain. He says the word vein is not in this article. Really, you know, and so I've been fighting with this for a long time. So I'm like, what? So the people who are the experts in chronic pelvic pain for women admit they don't know the cause for 60% of chronic pelvic pain, but it must not be veins because the word vein ain't there, okay? No, I mean, so what is this? You know, if you're an expert, you're not stupid. I mean, you're not ignorant. You're an expert, you put yourself forward. But so I don't know, you can figure it out yourself. Vulvodynia. So vulvodynia is pain in the vagina or the vulva with no organic cause. All right, there's a National Vulvodynia Association. What causes vulvodynia? A bunch of stuff. But it's not anything that you know. It's not a skin disease or infection, right? Because then it would be known. But vulvodynia is no organic cause. But 1 out of 8 women have this. 1 out of 8 women are walking around with this mysterious thing. And the doctors who are responsible for this, this much area can't figure it out. Okay. No, I mean, this is bad. It's bad. And so they raise money and they do all this stuff. This article, State of the Science, man, they're injecting a lot of, everything, of course. Nothing works, but they're on the case. They're very dedicated. They'll even do a vestibulectomy, which is where they cut off your vestibule, which sounds like a home rehab project. But no, I mean, it's serious. Okay, so this is, terrible. But here's the point. The patients who have what I'm trying to tell you about are hidden behind this wall, okay, of published material and God knows what. So here's a case. This is a real case. I get this newlywed couple in my office. She's sobbing, and she has terrible sex pain and vagina pain. So she went to, an expert in that, and he told her, they did a biopsy, couldn't find anything. He told her that, in front of her husband, told her that the pain she's having is probably from VD she picked up in college. Yeah. So somehow somebody she knew referred her to me. And look at this, okay? So this, you see there's a Foley catheter with a sort of dark thing, that's a bladder. There's some little fuzzy stuff over to the right. Those are veins I've already treated, or on the left, I'll say. And then you see this catheter come down and it's injecting into the uterine veins. And you just see a huge network of veins extending down the vagina. Okay. Those were invisible. They couldn't see them. Why? The patient's lying down, God knows what. So we just injected stuff into them, boom, cured. Okay. Cured, but absent this little part of it, she would have gone into the named slot of vulvodynia and, you know, so that's just one case, but can we really fix people with sex pain and vulvodynia? So I presented this at CIRSE a couple of years ago. If you look at a bunch of symptoms that our patients had, from the commonest to the less common, over on the left in white here, pelvic pain, pain with intercourse, vaginal pain pressure, lasting pain with intercourse, burning pain after sex. But if you look over here, it's a degree of improvement after treatment. Pain with intercourse improves 86% when you fix those veins. Next, vaginal pain pressure, burning pain after sex, 83% better. Lasting pain after intercourse, 80% better. This, hey, here's the mystery of all this stuff that they can't find, you know? So to me, this pain in the vulva and sex pain is just goes along with the pelvic pain caused by veins, all right? So, but now there's no paper that says that we can fix vulvodynia because this is own. Is everybody following me here? But that's terrible. So what happens to these patients if you can't diagnose it? I mean, could you diagnose it at the Mayo Clinic with your, you know, all the different little categories that, you know, people could get sent to? I hope so. But what happens in the real world is they get bounced around to different, you know, urologists, gynecologists, pain management. Everybody gets put on gabapentin, and or they go to these what I consider really semi-fraudulent pelvic pain centers where they have counseling and therapists and they hold your hand. But that whole system misses 60% of chronic pelvic pain. And then you end up with physical therapists and they do long, you know, massage sessions, physical therapy for pelvic floor problems and myofascial pain. Of course, if you have Ehlers-Danlos, you could have a lot of pelvic floor problems, but myofascial pain is another wastebasket. Why does your myofascia hurt? Maybe you have some inflammatory condition. Maybe there's a good reason, but it really is a symptom. And I always say that's like calling the polio virus weakness. You know what I mean? Myofascial pain is a complaint or something, I guess, if you. So they go into purgatory, and so that's a problem. So if, as I'm starting to think, these patients could have all this other stuff, they're kept away from the investigation. I don't know if this is going to work. Yeah. Okay. So look, here's an MRAV. This is a normal patient. Look, you can see the stuff flashing into the arteries. You can see the uterus sort of light up and it sort of goes everywhere else. It's coming out the renal vein. And now you see it coming up these two little nice normal ovarian veins. And you can see it traveling up the iliacs. Everybody see that? Okay. So a patient comes in with a complaint. You can either look inside or, you know, shunt the patient around to a bunch of different appointments. Here's another patient. This is an abnormal one who has pelvic venous pain. So same thing, it's going to flash into the arteries. Everybody see that? Say yes. Okay, so now look, you see a big hose-like thing flash down on the left. You see it? And then it fills all these big sort of varicose veins. It tries to go up the left iliac vein, but it's just cut off. So this person, there's flow down and then it can't get out. So where does it go? It's got to go over to the other side. Everybody see that? So that's a revelation in somebody with pelvic pain. So how do you fix it? Well, over here on this side, you can see how we're working up the iliac veins. or we can embolize varicose veins in the pelvis. And so that shows like a catheter coming down with a balloon on it, and then it's injecting some gray stuff, which is sort of flowing out. And that stuff is sclerosing agent. It's going to just dry up everything. And we mix it with some other sticky stuff. And then may put a few coils in just to make sure nothing travels around, for the short term. So, stents. We just put our patients on aspirin, but everyone's different. So, what's the effectiveness? Is this I don't want to point it at you. Oh well, anyway. So this is an oh hell slide. One of many. So stenting is sort of starting to win out over embolization. This is just a bunch of stuff. Anything here is in this thing I sent you, so that you should be able to look at these things. Now there's a randomized controlled trial of embolization by Hanzarani, and even with a sham procedure, so it's like single blind, and it works. And we know that embolization is, safe for fertility. And so everything is pretty safe. And it's effective. So
I was asked, did you need a laser pointer? I have here.
Oh yeah, cool. All right. Thank you. All right. Okay. All right. So who do we not do? Who would we be afraid to do? And this is a 15-year-old patient. So recently, Brooke Spencer did a series 16 to 25 patients. So this patient is horribly sick, not with pelvic pain, but with all this other stuff, chronic fatigue, passes out at school, wets her pants. Now she won't go back to school. And truant officers came to her, parents to their house. But I just couldn't bring myself to do her case because she was 15, and I didn't have any bunch of other people who were doing 15-year-olds, and I was feeling very lonesome. But of course, all these problems with dysautonomia and stuff start occurring around then. So there's a borderland there. The other thing I'll say is that the one trick about Ehlers-Danlos syndrome is that I've seen some patients who their veins are just flabby. They ain't got no collagen in their veins seemingly. And so you got to be careful with stenting, but they've made stents better. So Ehlers-Danlos syndrome. So here you see like a little pussy thing on the neck, and that's from putting the catheter in the jugular vein and taking it out. You just put a Steri-Strip on it. This never happens. I never saw this in 40 years. So with Ehlers-Danlos syndrome, people don't heal. And this is pathognomonic, where you see the two white lines that were the skin edge that fell apart, and then it had to heal. And then this is a patient who, that's a vein filled up with the sclerosing stuff. And for some reason, the skins got irritated. It wasn't infected, but we had to drain that out. So a lot of, skin things. So this is important. It's not like, oh, I want to rush out and get imaging, and it's not a cookbook thing. You have to see or talk to an expert in this, and somebody who can put everything together. But pelvic venous disorder is not a diagnosis of exclusion, like I showed you, where the patients bounce around and get a million things and go, well, we just don't know, so why don't we send them to the interventional radiologist? And if a patient has a gynecologist and has at least been following up, I don't make them, get any, further tests, because this is vascular disease. If they haven't seen a gynecologist, then no, they got to go. So here's a case. This is 10 years ago. Polish gal comes in, severe pelvic and vagina pain. The gynecologist tells her that pelvic congestion doesn't exist, doesn't know why she has pain, puts her on gabapentin. And she has crushing chest pain, normal coronaries, and gets put on Xanax. So now she's a mom. She's driving around and she's miserable and angry. And so somehow she got sent to us and she had a lot wrong. We ended up putting some stents in both iliacs and then injecting this kind of granular looking stuff just is going to wipe that vein out. And, you know, she did well and she came back, no pain in her pelvis or chest. But I didn't stop to think why she had chest pain. So here's another patient, this is 10 years ago, who had a bunch of stuff going on, but she only told us about her, you know, pain with sex. Why? These patients don't want to seem crazy, so they hide some of their stuff. They don't want to tell you everything because then they just sound like they're nuts. You know, so many things aren't wrong with them. And she came back and her pelvic pain was gone, okay. But she had had interstitial cystitis, gone to the University of Chicago for many years, getting all these painful treatments, really messed up. And she was cured, instantly cured after that. So there's a text exchange I had with her like a few weeks ago. Yeah, 10 years later, she's totally cured from interstitial cystitis, a mysterious disease with no cure. So here's another oh hell slide, but it just says that interstitial cystitis is related to everything else. Okay, vulvodynia, IBS, lupus, you know, on and on. But, you know, I don't know if the Mayo Clinic, if you would go to urology, if you had this, maybe they know about this. But so, and here you see a CT scan with these are big, huge veins wrapping around there. So weird, but this is cool. So this guy in Siberia, Dr. Nymark, did this study, and here's the study. He had controls, then he had pre-treatment women who had interstitial cystitis with complete urodynamics and had varicose veins in their pelvis. And then he treated the veins by just injecting them with the stuff like I showed you. Okay. So what did he find? He found that compared with normals before treatment, the patients had very slow flow in their pelvic veins, which were enlarged. Their urodynamics were bad. But he did another thing. He measured microcirculation in the wall of the bladder using a little laser device. And so after you treated the veins, everything became pretty normal, 85% improvement. But look at this microcirculation thing. So this may be the key to what's going on. So normals had 28.5 units. Before treatment, these patients, it was 9.5. So they lost 60% of their circulation to the wall of their bladder. Wow. So interstitial cystitis, you know, even urologists will tell you it's not inflammatory. But so I think what it is, it's more like the skin on the ankles of those people who have chronic venous disease, where the tissue is ischemic, not because there's not enough artery flow, get it? So, but look, it's reversible. It went back up to normal. These are young women. So what if you had a bunch of older women who had interstitial cystitis and their bladders were all scarred down? Would this work this dramatically? It might not. But no one's going to make that diagnosis except Dr. Nymark in Siberia. Right. So POTS and IC. So this is me. I'm an outsider. I don't know any of this stuff. Just look it up, and it as you know overlaps with all this stuff. So pelvic vein pain is orthostatic. This is orthostatic. So it's very confusing. And if I say stupid, I mean ignorant stuff, I am an outsider. So this guy, this guy's brilliant. Howard Taylor. So in 1948, he presents, you know, a whole bunch of cases of what he called pelvic congestion fibrosis syndrome. And these patients, excuse me, had low back pain, vulvodynia, sex pain, pelvic tenderness, but they had all this other stuff, which he dutifully, carefully noted. Severe invalid-like fatigue. Remember, these are just patients who have chronic pelvic pain, and he's going in there to see what he could find, and he finds patients who have this syndrome. nervous breakdown, anxiety, blushing, chest pain, tachycardia, their gut problems, headaches, allergy problems, low blood pressure, vein congestion, congestion of the bladder, trigone. He comes up with this. He goes, oh, he thinks they have sympathetic activity, and then he didn't know if it was psychosomatic or connective tissue problem. He presents this. No one ever in gynecology, including him, spoke about this again. Okay. They never spoke about it again because nobody else was tuned in. And so, but this is the whole picture, right? I mean, I love this guy. So, no, I really do. So now jump. So that was an attempt. Hey, we discovered it. No, boom. Now, no, I know. I'm going to go over. And so then 50 years later, yeah, I know. 50 years later, there's a paper tying pelvic congestion and chronic fatigue syndrome. And then in 2012, somebody embolized pelvic veins, saw that they were improving stuff. I got to go fast now. So we did a study where we took pelvic vein pain patients on the internet who had been diagnosed by a doctor and were on a specific site and asked them all these questions to see if they were Howard Taylor patients. And this is what came out. So all these white symptoms are the typical ones that I told you about, but all the other symptoms are symptoms of other syndromes. So that was shocking. And so on that site, all the patients were talking to each other about all this other stuff. Okay. So we started to check for hypermobility because some patients had that. And if so our patients did have muscle and joint pain. And if our patients 56 had at least HSD, we think this is the typical link of how everything is related to that. But we didn't fix that. We didn't fix their collagen. So we made a big questionnaire, and it had the OHQ, it had Rome 3, and a lot of other stuff. But if you look at the orthostatic hypertension quality of life score in red, if you use 6, you could use a lower one, but then half of our patients had clinically significant orthostatic intolerance, and afterwards only 13% had. And if you look over here at interstitial cystitis, 64% qualified, down to 35%. And then, I don't know, there's a lot of other stuff you can read about it in the articles. This is interesting. So if you look at our pelvic pain patients and you look at the OHQ and you look at the individual scores, and then down below this, there's severe POTS patients who went to a POTS Mecca and got treated with saline infusions. They looked the same. They were just about as sick as each other, but our patients weren't severe POTS patients. So, but they are behaving like them after a treatment to boost volume. Migraine headaches got better, way better. Okay. This guy Rosenberg also checked migraines, 77% resolved. So, why does that happen? I'll skip over this, but maybe Dr. Fairweather can talk about it. Brain fog got way better, pre-COVID brain fog. Anxiety attacks got way better. I mean, just what you would figure out. I'm on kind of funny ground here. I don't know much about all this stuff. All this stuff got about 50% better. Okay, irritable bowel syndrome, bloating 47% better, constipation 51%, diarrhea 70% better, hip pain. This is a special kind of hip pain caused by veins actually almost touching the acetabulum, causing pain, and it gets perceived as hip pain. And we had 33 people that had this and it got better. How are you going to figure this out? Only 5 of our patients didn't have this other stuff. So, and about the blood being trapped. So this just shows if you inject contrast in the veins and you go out for a cigarette and come back, it's still there. Okay, so there really is stasis of blood flow. Do you see? That's the whole thing, right? Why are we getting stagnant blood flow? It's stagnant. So to me, I think it's pretty much fight or flight. That's what I think. You know, gut shuts down and I know I'm oversimplifying stuff, but okay, this is the last thing. I'm almost done. So we did a prospective multi-center trial, and I didn't do any of the cases. And so we took PUF, that's interstitial cystitis, Rome is IBS, OHQ, the International Pelvic Pain Society score, and the PCS score, which is just stuff that should go with that. And at 12 months, everything is still better, right? I mean, it's durable. Here's the OHQ, and at 12 months durable. Now, if you throw in PEM, or prolonged recovery from exercise, on there, you get this, okay? Whatever that means. All right, this is the final one. So the International Pelvic Pain Society has an inventory of pelvic pain problems, and they don't believe in veins. They don't even mention veins. But if you give their inventory to our patients, everything gets better. Okay? All right, that's it. I'm done. Sorry, I went over.
Thank you so much, Dr. Smith. It's always a joy to hear Dr. Smith talk. And I know there are going to be questions. So in the interest of just keeping everyone on track with the break, please come to Dr. Smith with your questions. I want to take a 15-minute break now. So 15 minutes, and we'll join back at, let's say, 5 minutes before the hour. Hey. So you ready for the hot? Oh, really? Well, you need to kind of sit down and push. Yeah, totally. I think that we see the same thing with ortho surgery, other surgery, and yeah, the obvious best thing is not patient. And those are the most dangerous. I agree. Maybe 45 minutes. But I think we have to kind of yeah, we can stuff. Yeah. Doesn't feel like yes. Yeah. No, I agree 100%. And then if we tie in some of the research to it, evidence and things like that. How's it going? Oh, you guys, yeah. And actually, you got stuff happening. Yeah, that's good. Zip, did you get a chance to chat with him? I mean, obviously he's the man of the hour now. But yeah, I mean, we need to get that in place, and then have the research and evidence that we can learn what outcomes like that trials or whatever. Right? Yeah. Well, so I know you're on the so I think our meeting getting together again, right? That was the plan. You just know it all in and then you're like, all right, let's.
Yeah, what I thought as a start. That's what I think.
How are you? Yeah, thanks for coming. You look well, yeah.
Interesting.
Yeah,
I am.
okay, yeah, if we'll think it'll be. Okay.
Yes.
Yeah. Yeah, yeah. Oh, right. Oh, that's what we talk about diagnostic. Yeah. Coming soon.
It's like they let me do this. All right.
I thought England fielded that very well. Yeah. Yeah. I was like, looking over my dad's Maria was driving me to York this morning. Maria's like, just go, whatever. Driving my car today. Fine, nothing here all day. Yeah. So, well, we're a little bit behind schedule, but I don't think that's a problem. And we just, going through the next set of speakers, and then you take over from me from lunch, right? Okay. Till 11:30. Right. Okay, that's true. That's true. Yeah. And Steve texted me yesterday. He's like, I got a 45-minute talk ready to go. I'm like, no. No, he's like, oh shoot. Okay, well I'll go. I'm like, yeah, thanks. Yeah. No, it was good. Yeah. I'm glad that they're having a discussion now. Yeah. Yeah.
All right, the floor is all yours.
All right. So we can continue on this roll that we started. Dr. Smith is off to the airport to get to another conference in Venice. So I am just so appreciative of people like Dr. Smith and our other speakers, Dr. Bruno, that have been practice changing for me. And I know many other clinicians who share in that the research that they do directly translates to the improvement of care and what we do in our exam room and our clinical visits. So we're going to talk a little bit now about mast cells. I know that should be of interest to some of you all, but we've got a couple very good sessions to discuss mast cell activation disorders and some cutting edge research related to mast cell activation disorders. That's a whole conference on its own, but we do know that EDS and mast cell disorders are interlinked, and we want to understand them as in those conditions as best as we can. So for our next speaker is Dr. Delisa Fairweather. She has been my mentor, director of research at Mayo Clinic. She was pivotal to starting the EDS clinic at Mayo Clinic in 2019, which we just heard from Dr. Bruno all about. And her research is going into the understanding better of mast cells and mast cell activity. Dr. Fairweather is a professor of medicine at Mayo Clinic, and she's a leading researcher in immune-mediated and inflammatory disease. Her work focuses on the role of the immune system in chronic conditions, including autoimmune disease and Ehlers-Danlos syndromes, and of course, mast cell disorders. So I know that it will be also practice changing, the research that Dr. Fairweather is doing, and I'm very grateful to welcome her to the stage. Dr. Fairweather.
It's so exciting to be here. And I just want to follow up with the last talk for a second, because I want to make what I think is a really important point, and it makes a good example. So I'm a patient also and had pelvic congestion issues. So I've had 20 plus, who knows how many symptoms, like every symptom you could have probably in that area. And really it took several different departments and specialists before I got a breakthrough. And so, just as an example, very quickly, is that one thing I had was a chronic urinary tract infection over 2 years, longer than that, I think. And it took open doctors and infectious disease, because everything about it was atypical, to finally get me on like permanent antibiotics. One part. The other thing is my tailbone was completely out. It took pelvic floor to put it back in and teach me how to keep it in. And then I had like more pelvic congestion where my left renal vein was compressed with fibrosis partially, and just led to enormous numbers of symptoms. It took openness there, because that wasn't even any of the typical things we're looking at, and we're doing advances at Mayo in that area. And they're like, well, what is this, you know? So one of the things that we're really trying to do at Mayo Clinic is build experts in all of our referrals that become familiar with all. One, they have to be open, right? Physicians or other caregivers, and to look, because everything weird, unusual, atypical is the standard for EDS patients. And so they have to be open, and then also to become experts. And one of the driving ways we're doing this is including research and making them evidence-based research experts, because one of our challenges is the unopened doctors, right? The regular people who are unfamiliar with this. And as we produce high quality publications, we can hopefully then start to change the landscape and have it so that people will then be able to accept what's really going on, right? So that's a major goal of what we're trying to do. So my background in my whole career is in virus-induced myocarditis. And what was really interesting there in that whole field is that I realized mast cells were important in every stage of the disease, innate, acute, chronic. But I'm the only person in the myocarditis field worldwide looking at mast cells. And one of the odd flukes about mast cells is we are taught kind of the IgE classical role that mast cells play in all of our education as a basic research, and I think as clinicians. But mast cells do enormous. I mean, I kind of say, you know, they're like Superman of the immune cells and they do everything. And so when I was studying myocarditis, everything I was looking at, their roles were atypical. And so I feel like everything I learned there was just, you know, a preview to helping me work with EDS when that happened. So that was very exciting. So here, the building in Florida is actually not pink, but this is at sunset on white tiles. So I just love the picture. So you saw this picture already, and I really just want to point out from this paper, when we were looking at what was similar and what was different, the thing that always comes out really clearly is allergy or anything like classic mast cell symptoms are common and they're extremely prevalent. I'm not going to get the number accurate off the top of my head. You know, probably at least 80 or 90% of our patients, whether they're HEDS or HSD, complain of all kinds of allergy symptoms. So that's something that we don't see any differences in. And of course, what we see is that many people have also reported in the literature about how important mast cell issues are in EDS. So here we're going to hear just shortly from Dr. Maitland with studies related to that. We have other studies, right? And so we see that many people have seen that there are issues and they report on that. And here is like a very recent paper also associating with a number of other EDS type symptoms in mast cells. So I'm just going to go over a little bit about mast cell activation syndrome and the diagnoses for that and what kind of issues we have. So Dr. Bruno mentioned how we have, you know, enormous problems when we refer our patients to clinical immunology at Mayo Clinic, because basically the immunologists there say, we don't see any mast cell issues going on, and they don't want to treat them, and they don't see mast cell activation syndrome evidence either. And really they're basing it on these studies by Akin and Metcalf. And for those who know, Dean Metcalf is really, you know, legendary mast cell immunologist at NIH, so very well respected. Okay, so what we have here is the classification of disease associated with mast cell activation in table 1 on the left. And you can have primary, secondary, or idiopathic. And then in table 1, it lists co-occurring symptoms that can be associated with that. And so you can see a whole list here. And I'm going to use this table when I show some of our data as we go on, because the mast cell experts say, you know, all these kinds of specific symptoms, if you look at flushing, rashes, itching, you know, anaphylaxis is a classic, wheezing, even things like bone and muscle pain. Interesting. So they're saying these all could be associated with mast cell activation syndrome. And so that paper was like a prelude to them coming out with an actual diagnostic criteria well, this is still 2010. So what they proposed in 2010 was episodic symptoms consistent with mast cell mediator release in 2 or more organ systems. And so they listed some organ systems here. And then they said a decrease in frequency of those symptoms if you give mast cell medications, and then evidence of increased mast cell activation. And if you look at different biomarkers, and they didn't really specifically focus on tryptase in this original report. And then they came out in 2011 with then a more formal classification. And so this has been referred to as Consensus 1. But from clinical immunologists, you think of Mayo Clinic or other places, this is really the diagnostic criteria that they say this is, you know, what we need to go by. And so here it's just refined a little more from the paper that we saw before. So you can say table 2 here. You have typical symptoms, which they say see table 3. So here they say they have, with all the experts, and there were many more authors on this paper, they said they have great confidence, depending on these percentages, that these kinds of symptoms are really it would be associated with mast cell activation syndrome. And of course, they're occurring in sort of different organ systems. You need then an increase in serum total tryptase, at least 20% above baseline, and within 4 hours of having an acute event. And you need to respond to some kind of mast cell blocking treatment. And you have to have all three of those in order to have a diagnosis of mast cell activation syndrome. And so, in reality, this is very difficult to actually accomplish. So, one, when we have our intake time, where the person comes for their diet, their diagnosis at the EDS clinic. And so you saw from the workflow, we collect both clinical blood draw on that day and we do our research blood draw on that day. So the chances someone is having an acute event, right, is going to be random and probably not very many people. So we just call that a random draw. And so it's very difficult, to have someone come in. And I'd say at Mayo Clinic, it is almost impossible. With a doctor's order, you would probably, 1 to 4 hours, you would like very unlikely to ever be able to get in and get your blood on time. So it's just impossible. And it might vary at other institutions, but that is a major problem with ever getting a diagnosis here. And you have to work at what is the baseline tryptase to really understand this. Okay, so then we had, because I think, I'm not sure the history of this. I don't think I know any of the people on here because this is not specific for EDS per se, but clearly became a problem. I don't know if EDS patients stimulated this or not, or if it came from a different history, but this has been called consensus 2. And there's a very large number of immunology mast cell experts on this paper. And they say, well, the other list, we're not the only experts. We're experts also, and we have a different opinion about this. And um, so, they realize the problems, the innate problems I just mentioned about trying to get a diagnosis with consensus 1, and that there's a lot of problems, and they think that there's maybe something else going on. So what they basically did is they relaxed the requirement for the trypsin value in consensus 2, and they relaxed the need to show that the medication reversed the symptoms. So what are you left with? Well, they provide a very long, you can't read it here, but basically this is, every organ system, and what fell off the end here is immunology. And lots of symptoms listed here. And, you saw this paper from Dr. Bruno earlier. We looked at, I think, 120, and this one, 130. We have more symptoms and comorbidities than that in our questionnaire. And many other people sitting here, and I know looking on remotely, have done these same types of survey questions, right? And you have a huge number of symptoms in every organ system that are affected in EDS patients. And so basically, I'm like, well, I know we're thinking about renaming maybe the condition. And it's like, well, these are so remarkably similar. They may not be identical questions in both, but maybe we should just rename it mast cell activation disease, which I didn't go into great detail here. It has its own definitions as well. But because it's so remarkably similar, I think, the real problem is that we as patients and we as practitioners look at these patients and go, I see all kinds of things that could be due to mast cell activation going on. And yet our clinical immunology colleagues say, I see nothing is going on. And we're like, wait a minute, right? This is a huge problem in the field. So I consider my training as a PhD was an immunologist. And then, there's this strange quirk I kind of mentioned that's completely arbitrary, that there are immunologists and then there are mast cell biologists. I don't know how this happened. And if you read almost any immunology paper about any topic, they will never mention mast cells. They are omitted completely. And then you go to the mast cell literature and they're hyper focused on mast cells to the exclusion of almost all the rest of the immunology. And so, there's a problem in actually the immunology field that's completely arbitrary, that's also compounding our problem here. Um, and part also is what I see in the textbooks and what I'm assuming is going to be similar in medical education. Every doctor I've talked to has said we got almost no immunology. Everyone's afraid of immunology, and then it's turned out that like almost every disease, every chronic disease we're looking at involves immunology. So we have a vacuum there also of real expertise. So none of these are purposeful, but that's an area that we really need advancements in. And another area that's a huge gap then is any understanding that if we're not even getting good education in like classical IgE mediated, mast cell behavior, and then mast cells are doing 20 million other things, which are not, then we really have a big problem in understanding all the capacity of what could happen. And a huge gap that I see is we don't have any good ways to quantify widespread mast cell issues, which is at the heart of what we think we're seeing right in EDS patients. So, issues with diagnosis, consensus one, the real problem is probably underdiagnosis, right? There's really a focus on that we're just looking for anaphylactic responses. And I think that absolutely is part of the patient experience with EDS patients. But we have so much more that is all these other areas of mast cell behavior rather than that. And again, I mentioned the almost impossibility of actually getting measurements that they require for consensus one at most institutions. And then we have now what has developed a whole philosophy or something that the clinical immunologists are just completely convinced that they're upset about consensus two. They're upset that in the EDS world we seem to be saying everyone has mast cell problems and they're just upset. And consensus two then is a problem with overdiagnosis because we have this great list of almost everything in the body could be due to mast cells, but we don't have anything quantifiable. We need something quantifiable. We need something we can say yes or no or degrees of severity so that we can do evidence-based research and that we can say, oh, if we're going to give a treatment, I mean, there's lots of right clinically available mast cell treatments. How well do they work, aside from anything new we might come up with? And if we don't have any way to quantify how severe people are, if they get better, how do we know if anything's working? So this is a major gap. And this is not just for EDS. I see this a gap in immunology in our healthcare system for many chronic inflammatory diseases. I believe mast cells are central to what is going on. And, we need a way to really know what's going on. So I would just point out, so this is what Dr. Bruno showed earlier, right? And we have our immunology and allergy here, 70% bad experience. And I can just say personally, with a person with EDS going to immunology, even as a, expert in the field, I was met with hostility, complete closed door. It was a very, very bad experience. And so this is immunologists at Mayo Clinic, clinical immunologists. And I don't know if you saw this paper. They recently did a systematic review of the literature and concluded that they couldn't find any evidence of a relationship with mast cell activation syndrome and EDS, right? And so this is part of this very negative. So they feel like they have evidence, but of course, not finding anything isn't evidence of it not being there. But that's an important point. So I think this is just typical of the problem. So I have very, very good news in that I had a previous student when Dr. Gonzalez left, they hired this person. He was my previous student. He's very open to research. I've met with him and he is completely on board and wants to change the atmosphere of the immunology. So I'm incredibly excited to say I think we have someone that is really going to change the atmosphere there and wants to work together to sort of revolutionize what we're doing. And so I'm going to describe the mast cell score that I've developed to try to fill this gap, and really want to collaborate with everyone. I'm right on the verge of publishing. It's not published yet. And then, hopefully this will be useful for everyone in the field. It's very simple and easy. We can quantify what's going on. And he has looked at everything, and he is very excited and thinks that it's a really good thing to move forward. So we heard all about the intake questionnaire. At the moment, we have like 1,700 questions. So we had a patient here say, it does take quite a while to do the questionnaire, yet we've had incredibly good feedback about it, that patients really feel validated when they do it. Maybe for the first time, they look through all these questions and they're like, oh my gosh, they must know what's wrong with me because all those things are listed here. So I really based this on my symptoms. So, what we needed is, you saw the list of symptoms like nausea, headaches, migraines, so many things. We can't base it on any of those because they can be caused by 10 different conditions, right? So we needed something that is definitely caused by mast cells and well known to be caused by those. So I picked things like that. It is a little IgE heavy, as it would be, because that's where all the research is. So I picked 11 categories of mast cell issues. This is self-reported. So the patient says, do they have environmental allergies, asthma, atmy, was asthma as a child or adult, venom, stinging insect allergies, food allergies or tolerances, drug or chemical allergies, allergic rhinitis, dermatitis. Have they been told they have mast cell activation syndrome, or have they been, told they have the tryptase mutation? So I based it really, if you've ever heard of the ACE score, the Adverse Childhood Experiences score, they ask you, did you have abuse as a child or a parent that was incarcerated, and it's all self-reported. And then for every yes, you get 1 point. And so they came up with a score. And there's just, I don't know, I think hundreds of publications about how well that score has shown the role of adverse childhood events in disease. And so I thought, well, that is a great mechanism. So we did the same thing. So there's 11 questions here. Each yes is 1. So you can have a mast cell score from 0 out of 11 to 11 out of 11. And what you see in the diagram here is when we were looking at 3,500 patients, that what their answers were to the score with each diagnosis, with HEDS in gray and HSD in blue. And they're almost identical, basically. And you can see that most people are in the middle somewhere. We have some that say none. Doesn't mean it's self-reported, so it might not be accurate. But what we're looking for is widespread and not accuracy per se. Because if you have widespread problems in all these areas, I mean, you must have something going on, right? And we didn't really get any had everything. So here's show some of our initial data. So this is just showing the data, and we wanted to say, if we compare people with low mast cell versus high mast cell, what does that show us? What do the people with high mast cell issues look like, and how well is the score reflecting these kinds of issues? So you can just see here, we took out the scores from 2 to 4, and so what we did is, 0 would have been best, but what we wanted to do in statistics, if you can compare equal numbers, it's much better, especially when you have such a large N. A large N will give you statistical significance almost because of how big it is. And so we picked 0 and 1 as low, and 5 or greater, and they were almost equal numbers. And so you can see that right here. So we had about 600 in each group. And so then this is just showing odds ratios, looking at elements of the score. It's not all 11 because some of them had crazy confidence intervals, but it just shows that if you have a high mast cell score in any individual self-reported component of the mast cell score, you had really high relationship. And then we looked, I picked symptoms that came from the table from Akin in 2010 and Valent in 2012. And they, some of them are the same. But it basically then, we had those experts saying these are mast cell activation syndrome symptoms that you can have, right? And we see that we get quite good, if you have a high mast cell score, you get quite good odds ratios of that being increased. And for Valen also, the list that he gave, not everything's on there again, but. So here just shows you, I wanted to highlight, because if you've done these kind of studies, or even if you look at some of our previous papers and we show percentages between groups, so we have a bunch of mast cell associated, many of them the non-specific kind of symptoms here. And these two columns are the EDS, low versus high, and the HSD, low versus high, and we're just doing pairwise comparisons. And so what we see is they're all significant, but almost all. But what you see is some of these are really quite high increases. So if you look at nasal congestion, you'd expect that with high mast cells, but it goes from 32 to 85 and 35 to 90. So you're really getting big increases. If you do these other things, you might have 70 to 85 or something percentages, it can be significant, but these are really big differences. And something like what throat swelling, 10 to 60%, 11 to 42%. And what's this one? Hard for me to read up here. Urticaria, 13 to 60%. So we're really getting, it's just sort of internally validating. This makes a lot of sense that these are increasing like this. Okay, so now let's get to some of the clinical measures we do routinely at Mayo Clinic, trying to say, do these patients have, do they have mast cell problems by looking at blood? So again, these are all random. These are not during an event because they come in when the patient has their initial appointment. And so on all of these, you'll see if you can make out those little red lines that go across above or below, those are what are the clinical normal levels. And then, and in each of these, we had about, it says at the top 50 per group. So we just randomly picked people that had low mast cell scores and high mast cell scores from this to get a group of patients. And so the overwhelming thing you see is that there's no significant differences between low and high, and almost nobody is above the background normal. Now, of course, for tryptase, this is not what is the patient's baseline. Is it 20% of baseline? We don't have any of that data. But this is what the clinical immunologists at Mayo Clinic have been using to say, is there a problem? And they see no problems. So we actually looked up, the few that we have in each diagnosis here. So on the left of each group, of course, is HEDS, and on the right is HSD. And we looked up the individual ones that were right on the line or above, and 50% of those patients got a diagnosis of mast cell activation syndrome. And so you see from just the sampling, we're not getting very many diagnoses at all, and this doesn't match the mast cell score. Is there something wrong with the mast cell score? Let's see. Okay. The other thing that we collect is a random urinary sample to look at downstream mast cell activation markers. So we have methylhistamine, right, and PGF, and leukotrienes, and so the top row, again, is what the values are. And what we're showing on the bottom is because people drink different amounts of water, and these are, proteins, so we have to adjust for that volume. And we do that by measuring their creatinine level in the urine and normalize to that. So these top row are all normalized. And what you see is none of them are significant with the high mast cell score, and almost nobody is above normal levels. And when we look at creatinine on the bottom, what was really remarkable is that we found only for HEDS patients, and we need to look at more patients and see about this, but we found that the high mast cell group was significantly changed for EDS in each of these. What that means is it was lower, significantly lower for HEDS patients, the creatinine levels. That means you can't use creatinine to normalize and that the values are inaccurate. So we need to look at more of these and see, could this be happening with HSD? Is it truly only happening with HEDS? Not clear why that would be, but most importantly, it's inaccurate. And this is what we've been basing our values on clinically. So then when we look, so now we have our random blood samples that we banked, and we wanted to look at mast cell markers to see if they would go with the mast cell score. And this we did in our lab with ELISAs. And so, because everything else was done right with the Mayo clinical labs. And what we found then is that these markers match the mast cell score. So most importantly, IgE, which is the most associated marker I think you can have for mast cells, and classical mast cell activation is increased with the mast cell score. Of course, most of the things that we have in our mast cell score have been shown to have an IgE relationship. So that's not a surprise for that, but it's like the kind of gold standard of a marker. And so they went up in both diagnoses with the high mast cells. Also, our tryptase by ELISA, we saw that go up in HEDS patients. And then we saw this is major basic protein, which is a major product from eosinophils. Eosinophils have to have mast cells to activate them. So they're a different immune cell that is activated. If you have eosinophils anywhere, it's a bad diagnosis. That is not a good thing to have happen. And this is a product, and we saw in this case that the HSD had that. And actually, we've looked at lots of different markers, which will probably come out in a different paper where we see associations with lots of different mast cell markers. So this then is like, well, even with a random sample, we can definitely get a relationship here. It just looks like the ones and the way we happen to be doing it clinically at the moment. I don't know what it works for them, like other conditions. It must work. I haven't done an extensive lit review to try to work out where they're getting positives, but it's not working with our EDS patients to show what's going on. Okay, so then and we'll show in the paper, we looked at all the areas. We have symptoms. We look a lot of symptoms, symptom tables for every area that in the body, and that I'm not taking the time to show you. But one area that was really fascinating and we think is really important, and this had to do with psychological issues. And so, we know that there's quite a lot of anxiety in EDS and depression. And so depression was like an internal control. So a high mast cell score, nothing to do with it. We do not expect mast cells to have anything to do with driving depression, although it very much could have to do with anxiety, because many of the mediators that release, if you many people have experienced hay fever, and you start sneezing and everything, and you often feel irritable, right? And that's just a perfect example of how immune cells release mediators that affect nerves and the nervous system. And so you can really have anxiety affected. What really stood out is like we really had almost no significant relationship with any type of psychological issue except for abuse and PTSD. And those were very dramatic. So if you look at those numbers, we go from like 30 to almost 60. You almost have a doubling percentage of people self-reporting abuse. And if you look at the bottom, you see the types of abuse, right? So emotional abuse is really the largest, physical abuse, and sexual abuse, and then PTSD. So I brought in the A score. So we have the A score in our questionnaire. And so this really tells us if they had childhood abuse or bad conditions, and we see significant increases with that. And here, we're almost finished. We have looking at these just to see the odds ratios for all of those categories. And this is a distribution of our A score, which, as we would expect, these are 10 questions that are asked, and they self-report again, similar on all these categories. So most people didn't have it. And then you see it going down. We had some that had many, many issues in their childhood. And here you see the A score for each diagnosis with this large increase. And so we know that many people have written about how important stress is. Like mast cells are at the center of the stress response. So they respond, of course, with the neurological system, the immune system. They're completely different by sex. That's an area that I've always been researching. They also sit right in the middle of all the stress hormones. And this is just showing how you can have cortisol released, and you have these other, you have cortical releasing hormone, neurotensin substance P. But what happens is this can drive inflammation. And this cortisol is often anti inflammatory, but in stress conditions, it may, in this case, not really be promoted. And then there's studies that have really, with other models, have shown how um, stress can really affect, you have each type, behavioral changes, acute stress, chronic stress, and all kinds of different changes that can happen related to that. So in summary, consensus 1 is likely going to give us an underdiagnosis, consensus 2 an overdiagnosis. Blood and urine markers, just in our experience, they are not helpful. The MASL score, I hope, can be helpful. It's just 10 easy questions. I think that, a little questionnaire could happen. You could send out before they have an appointment, or even when they're in the waiting room ready to come into and then you have the score, and you know how widespread a problem someone has. We found almost 20% of all of our patients had a high MASL score. It associates with these widespread mast cell related symptoms, and also with blood markers that we've looked at. And so in the future, we want to define the middle group, because it's probably also very significant things going on there. Validate with blood and urine markers in larger numbers, validate at other sites. We have sequencing data that we're doing, and hopefully something we're going to publish soon. And we're also doing large language models and AI, and use the MASL score to examine EMR data on a large scale to try to see what patterns could be there. And we also are exploring the effect of abuse and PTSD on the symptoms and comorbidities. Sadly, the United States has some of the largest abuse percentages of Western countries. And, it's often just a very overlooked area. So I want to thank all the people in my lab. Frances Wilson is here. She runs the daily management and research for our EDS group. And then you can see Caitlin and one of her students right here, because we are tied at the hip. And of course, with Dr. Knight, we're working in close collaboration. Even though he moved away, now we have like joint research ventures, which is very exciting. And of course, many lab members. And I thank you for your time, and if there's any time for questions.
We do have time for a couple quick questions. Yeah.
Yeah, so I'll repeat the question. So she asked if mast cell activation syndrome can be involved with delayed type hypersensitivity response. So I personally have experienced everything, and I see it fully involved, even though they're separated. I think basically from all the research I've done in myocarditis and the literature and my own personal experience as a patient, I see every type of activity that mast cells are capable of doing being involved in EDS. So we need a very widespread description rather than a narrow one for what is going on. And I would not be surprised, we have to do the research and prove it, that mast cells are actually involved in most of the problems that we're having. Not all. I mean, we talked about congestive, pelvic congestion, right? So are they involved in that? Well, they might be. You have a loose and floppy vessels. Well, if collagen isn't actually missing, maybe the mast cells, because they break down matrix and they build matrix, right? In one person, they may break it down and they have a floppy vein. In my case, with mine, I had fibrosis and it was built up. They might be responsible for everything, or it might be physical, and we have to prove what's going on. But I think they could quite possibly have a role in a majority of the symptoms and comorbidities we have. Yeah. Yay! Yeah. 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 Exactly. Yeah. Yeah. There's a big challenge. Oh, sorry. So to repeat the question, we have so a mast cell biologist in training or already in training, and so he's asking. Normally we do blood biomarkers. They're the easiest. It's the least invasive to get a lot of our information. And um, will we have to move away for that, or what role will that play? And so there's a huge problem with mast cells. So if we think of the other immune cells, so for example, my corollary is T regulatory cells. They're in tiny, tiny amounts. Mast cells are in tiny, tiny amounts, but they control everything. They're master regulators of what the outcome's going to be. And so people understand that, but they don't understand it when it comes to mast cells. Mast cells control everything, and they're very few. The biggest problem we have is that what is in the blood are basophils, and they do not behave like tissue mast cells. And so those two, that's a big obstacle we need to overcome. So we really need to get tissues if we can. So any more later?
Yeah, I think we have time for one
Yeah.
last question. Yeah, go ahead.
Say a little bit about what therapeutic diagnostic approaches you take, not just antihistamines, but mast cell stabilizers or other things to interfere, and that would both confirm your hypothesis of causality as well as is it part of the therapeutic paradigm that you're working on?
Thank you. So the question was, what is kind of, I guess, our clinical next steps and how we can prove this paradigm and what we could do with the current medications. So what I'm working on, I am concerned that if we, and why consensus 2 relaxed probably whether the medications work, is I have the concept that we have to remove our baseline. I think we have mast cells being activated all over our body. It creates this high baseline of reactivity, and we need to get that down. And so something that I think is a central issue has to do with our diet and our interaction with our environment, as the highest number of mast cells in our body are in our mouth and our throat, every mammal. And their primary role is to monitor the environment and send all the alarm messages for that. And their number one thing was toxins. So that's like venom toxins, snake toxins, all those enzymes they release. They're I think the only immune cell that can break those toxins. And our world, especially in the United States, our food and our water and everything is full of toxins. And so what I'm working on is a mast cell centered diet to bring that down. And I think with the mast cell score, and if we can get the baseline down, we're going to start to see much more effectiveness with our current medications. In my personal experience with this, I brought my baseline down, and then suddenly all the mast cell medications started working, and they never worked before. Because if you've got all this going on, how can they stop it? Like that's not going to be possible. So you have to get it calmed down first. So that is our approach at the moment to this. And then of course to do clinical trials with currently available things, and then see if we need innovative things, right? Because we're out of the box how mast cells may be causing some of these symptoms, not just classical view. And with that, we may be able to come up with new, more effective drugs might target mast cell activation and, if it's one area, POTS, or specific nerve symptoms, or, maybe we'll even in more precision than just a histamine blocker. Okay. Mhm.
Thank you, Dr. Fairweather.
Yep.
Okay, so fear not, we will still continue discussing mast cells. The next group of sessions, though, I'd like to give a special welcome to our colleagues at Medical University of South Carolina. And we have Dr. Ann Maitland, Molly Griggs, and then just after lunch, we'll have our keynote speaker, Dr. Chip Norris. So again, thanks to Lori McMahon to making that connection and bridging that work that she had started at MUSC now to University of Virginia. So we're very grateful to them for being here. So yes, as I mentioned, we will continue the discussion of mast cells. Our next speaker is another very good friend and close colleague of mine, Dr. Ann Maitland, who is the medical director of the new EDS Institute at the Medical University of South Carolina. So I've had a lot of personal interaction to learn how she's blazing trails down there as we're doing the same thing at University of Virginia. And Dr. Maitland is a specialist in allergy and immunology. She's one of the good ones. Don't worry. Dr. Maitland's work focuses on mast cell activation and complex connective tissue disorders. So she is bridging clinical care and research and making that in great strides. So please join me in welcoming Dr. Maitland.
I actually thinking about they are listening. No, I'm sorry. Well, first of all, I want to thank you, Dr. and also Dr. in the invitation to come. And I think the timing of this meeting, especially following Easter, is very meaningful to me. There was a Nobel Prize winner in the 1950s that felt that science advances one death at a time. And as you can see, there's a lot of things regarding to the diagnosis of a lot of the issues that we're dealing with and talking to today has to die. Not the people, but the thoughts. And I'm hoping to repurpose what mast cells are doing. And I have to feel, and as a person in New Yorker who hates profiling, I think mast cells are being misprofiled. I think they're doing their job. They just don't have any better ideas of how to do their job better. So my talk is entitled, Got MCAS? Maybe. Let's see. There we go. Fabulous, huh?
So forward, reverse, laser, hit this one by mistake, goes blank, hit forward again.
Appreciate you. My Southern roots now. Anyway, as you can see, in my opinion, there are three organ systems that can be responsible for an array of issues that a lot of people in this auditorium are dealing with. So you have the connective tissue, and embedded in the connective tissue are elements of the nervous system and elements of the immune system. And up front are the somatosensory nerves that talk directly to the mast cells at all times. The purpose of the epithelium is to let us know we're encountering an environment that may have a danger. That signal goes to the nerves. The nerves then tell the mast cells there's a problem. Mast cells then have receptors to try to figure out what kind of problem is it. These are my disclosures. And what we're going to be talking about, and this looks like the older talk, but we're going to be talking about nerves and mast cells in the connective tissue. We're going to be talking about the different clinical phenotypes and endotypes of mast cell disease. I don't think the question is whether or not your mast cells are activating. The question is, are they activating to help you, or are they activating to harm you? That's the difference here. So it's really important to understand why your mast cells are misbehaving, not whether or not they are activating or not. And then I want to talk about what I think is a growing body of data linking mast cell dysfunction as a secondary issue leading to musculoskeletal hypermobility that we are now calling hypermobile Ehlers-Danlos syndrome and hypermobile spectrum disorder. So mast cells are old, like really old. They were first identified in the 1860s in tadpoles. They were found in lots of different organisms, chickens, sharks, birds, and mammals. And in the 1870s, a gentleman named Ehrlich, who named the mast cells Madzellen because they thought they used well-fed cells, felt that these cells were found in every part of the human body. So they're literally acting as the guard to every part of your body that's exposed to the environment. And we all have about 70 to 75 square feet of territory, whether we're talking the skin or the linings of the gastrointestinal tract, the respiratory tract, and the urogenital tract that has to deal with incoming at all times. But interestingly enough, it took 100 years for the mast cells to finally get a job. 100 years. And, you know, nothing like a first impression is in the setting of disease. And that's what most allergy immunology colleagues have been taught. If you are having runny noses, if you're having gastrointestinal upset from a food, if you're having a change in mood such that you have this impending sense of doom, if you're rashing up, everyone assigns it to mast cells, and that's not right. Interestingly enough, this is a modern epidemic. I would have to say that the burden of disease has completely changed in less than 100 years. And just like Dr. Fairweather just mentioned, this is an environmental epigenetic issue. Well, if mast cells have been around upon millennia, why are they such a problem now? And I have to tell you, we've had a huge increase in both immediate and delayed hypersensitivity disorders. Right now, 1 out of 2 Americans, actually, I'm gonna go global, nearly half of the human population is dealing with an immune-mediated disorder. And in this country, when I started in fellowship, anaphylaxis was considered rare, mostly in the hospital with a medication. Now, the latest data shows that 1 out of 50 Americans have been treated for anaphylaxis. 40% of us have nose and sinus issues. And interestingly enough, autoimmune diseases are also on the rise. Nearly over 50 million Americans have autoimmune disease. And interestingly enough, this study in the Journal of Clinical Investigation left out the most common autoimmune disorder. And that actually is autoimmune mast cell disease. You actually develop antibodies against the mast cells that leads to spontaneous urticaria. And what's really concerning about this study is that if you have chronic urticaria, you're at increased risk for all-out morbidity and mortality, period. That's a huge red flag. So this is my kind of like career in medicine. So I up and down I-95 until this past year. Well, actually just further down I-95. So, I grew up in New York where in the 60s, believe it or not, they were still delivering milk in glass cartons to our back door. Clothing was cotton, cotton, cotton until silk, right? There was no polyester, there was no plastic. The television went off at 12 o'clock. So, and kids were outside until the lights came on, right? That completely changed. But this is what I was taught when I was in fellowship at Brigham and Women's, that if you have reactions, I have to skin test you. Like I'm looking for IgE to mast cells. And I would refer to Dr. Stephen Galley, who's been doing mast cell research for like 30 years. He's like, do you really think all of us have mast cells so we can eat peanuts and die? That makes no sense. So ever since that time, mast cells, and this is what this looked like to Dr. Ehrlich in the 1880s. He took dye that made the Burgermeister's clothes nice blue. He threw it onto connective tissue and mast cells lit up. So he equated that to a Burgermeister's home, right? Where he's living off the land, as opposed to the mast cells are actually trying to help maintain the integrity of the connective tissue. That's this job. But I was taught, kill them. They're the most reviled cells in the body. Their meddling ways cause our skin to itch, eyes to swell, nose to stream. Cells provoke suffocating asthma attacks, kill thousands of people every year. Their villains are responsible for so much suffering that some researchers have proposed eradicating them. Good luck with that. So I'm entitling this the miseducation of an allergy immunology specialist. So when I see people come in with these symptoms, I was taught to allergy test, allergy test, allergy test, and allergy test. Might as well have that coffee cup right on my desk. And what's even more frightening, even though mast cells were identified in the 1800s and NIH came into fruition, they only had 1,000 grants on this growing burden of disease. And 90% of them was on allergen-driven mast cell activation disease. Only 10%. And mind you, prior to the 1950s, the biggest pathogen for humans was parasites. So now you change the environment completely. And now you're trying to tell these mast cells that have been helping your ancestors for millennia upon millennia to learn a new trick. Not gonna happen. So who opened my eyes to my miseducation was this little boy. And his mother wrote this, and I was just formulating the fact that mast cells can misbehave lots of different ways. But she came to me, and this is Sean, and he was down to 6 foods within 4 years of life. He had anaphylaxis, he had asthma exacerbations, he had bone pain, he had fatigue, he had lost his milestones. And so this goes to the early exposures in childhood and how children are much more vulnerable to changes in the environment. And of course, he went to a lot of different doctors and was lucky that the mom wasn't accused of medical child abuse. So this was his odyssey. Everybody said allergy, except for the 10 allergists before me. So the term mast cell activation disease only came into fruition in 2011. Interestingly enough, global consensus too, and if you look at the data there, he has not changed his protocol. And I have to tell you, I looked at that paper, and I actually sent the article into the journal and told them, first of all, 2 of your authors are running mast cell labs with drug intentions, and you didn't declare it. So there's a lot of issues with that paper. Like he's assigned Wolff-Parkinson-White as a mast cell disorder. I'm like, okay, can you pull back a little bit? So this was a paper that actually came out where a lot of the immunologists who were actually defending the fact that mast cell activation disease is a real phenomenon. That just tells me your mast cells are misbehaving. It's not telling me why. And so again, multi-organ system, you have to have at least 2 organ systems that are involved. You have to have medications that target one aspect of mast cell action, right? Because we know mast cells are responsible for lots of other things. And then, do you get better with medications that target that aspect? Like histamine is not going to stop you from having disseminated intravascular coagulation, meaning you can have an anaphylactic event and start bleeding and clotting, and you can use antihistamines all day long, and that's not going to interfere with that. So, first criteria, and literally multiple organ systems, and I agree that global consensus 1 is restricted. They have a tendency to focus on rhinitis, asthma, and by the way, we still arguing among ourselves what anaphylaxis is, right? It's still, I know it when I see it. That's the way it is going now. Skin manifestations, gastrointestinal manifestations, but I've had people have suicidal thoughts on when they've had anaphylaxis. Bladder pain syndrome or interstitial cystitis is also considered a mast cell disease. And we know some individuals who have anaphylaxis actually have joint pain. So literally, those mast cells can misbehave in any part of your body. Now, I understand it's difficult to get a tryptase, not trypsin, tryptase. And my hack actually is I give a script to the patient. Like when they go into the emergency department, I have them give the script to the ED physician. And then if the ED physician still has, I'm like, all right, I hear you. You don't know how to manage this test. Can you just get a red top tube? And then I fax the order directly into the lab. So that's how I get around this systems issue. And then the other markers, here's the problem. They're made by neutrophils, they're made by basophils. So are we looking at a basophil issue? Are we looking at a neutrophil issue? Or are we looking at a mast cell issue? And by the way, mast cells are tissue-based. There are very few that are in the blood. So if you really want to understand what's going on, like, are you going to turn somebody away who's having chest pain and their CKs are normal? No, we need to look further. The third criteria, again, is focusing on histamine blockade. And I have to tell you, the latest criteria that came from the American Academy of Asthma, Allergy, and Immunology has now recognized the fact that same thing for the Cholumskys at VCU. The symptoms of dysautonomia overlap that of mast cell activation syndrome. So with all these symptoms, are we really looking at mast cell dysfunction? Are we looking at nerve dysfunction, or both? And I would argue both. So once you decide that the person has misbehaving mast cells, and to be honest, I use the term mast cell activation disease, so that takes tryptase out of it. Do you have hypersensitivity issues? Let's just stick there. And then the minority of patients, and thank you for showing that paper, I had 980 people come to me saying they had mast cell. So then I got a glass of water, I looked out the window and refocused to listen to the story. And I would have to tell you, 10% of the patients would have a clonal problem. They either have broken mast cells in the form of systemic mastocytosis or hyperalpha-tryptosemia. But the majority of them are mast cells that are having bad orders, whether they developed an autoantibody, whether or not they have cervical spine instability, which will cause dysregulation between the adrenergic and the vagus, whether or not they have a different connective tissue disease. such as Marfans or low EDs, which is a transforming growth factor, beta. And I have to tell you, and I'll talk a little bit later, I've identified at least 4 different immune disorders that present with musculoskeletal hypermobility, right? So maybe renaming HEDS and HSD, I think is going to be important. So where we are then, in 1989, we identified only 3 receptors that were responsible for causing degranulation events. And that was with IgE receptor, the IgG receptors, the antibody receptors, that cause degranulation. You have complement, which we forget about. And complement is actually older than the mast cells. And if I remember correctly, complement antagonists are actually used in cardiac transplant. Right? We're now up to this. We have identified all these receptors. For instance, the reason why you can't take fluoroquinolones, you're going through the MERG-PXR2 receptor. The reason why women may have problems going in or out of their menses is because they have estrogen and testosterone receptors. You have the opioid receptor. So this is why certain pen medications that you're taking when you're getting surgery may be a problem. Or you're getting lidocaine that diffuses out, so you're not going to have any local analgesic effects. You have communication. As a matter of fact, I've identified 26 people that had idiopathic CD4 lymphocytopenia complaining that they had mast cell activation syndrome. So my job mostly has been, I know your mast cells are misbehaving. I need to know why they're misbehaving. And this is what's really concerning. They've identified at least 4 autoantibodies against the mast cells or what the mast cells recognize, leading to chronic spontaneous urticaria, which means your mast cells stay on a higher alert. So it doesn't take much like change in temperature, you smelling something at Bed Bath & Beyond for you to have a reaction. And this is what I think is the most important, in that the identification of somatosensory nerves that was put forth by Nobel Prize winners in 2021, the nerves actually have receptors that can detect dust mites. The nerves have receptors that can detect venom. So here you are sleeping in the cave 100 years ago, you get bit, you don't need to wake up and respond. It's the nerves telling the mast cells, hey, I just got bit by, Jumanji spider, and I need to protect myself. And so I'm going to release chemicals like tryptase, actually will protect honey badgers. If anybody's familiar with honey badgers, they have great protection against venom because they have a super cute amount of enzymes that can chew up the venom and deactivate it, right? Great if you're in the safari, not great if you're living on Fifth Avenue. So we break it down. Once you decide your mast cells are misbehaving, do you have a broken set of mast cells? Do you have mast cells following bad orders? Or I don't know, which is idiopathic. And by the way, this is now being tackled because over 500,000 Americans now have meat allergy. And if you don't ask that particular test, you won't see it. So we now know that idiopathic anaphylaxis is actually associated with alpha-gal. This is the story that was mentioned regarding HAT. This was in 2016 in NIH, NIAD, Dean Metcalf, Josh Milner were saying that, you know what, we're seeing a lot of people running around with a higher level of tryptase compared to everybody else. Interestingly enough, nearly 6 to 7% of the Caucasian population have an increased amount of tryptase running around. But all of them that have it don't have symptomatology. So there's a difference between having the gun and then pulling the trigger. My research has identified, and also the work that's being done at MUSC, it's secondary mast cell activation. Mast cells are getting information from quote unquote profiled allergens, or you have an undiagnosed immunodeficiency. You don't have enough antibodies that recognize strep. You don't have enough T cells, and you almost look like you have HIV, but not. You're just not making enough T cells to keep the mast cells in check. Physical stress, such as having a connective tissue issue because you've had POTS since you were 7. Nobody saw it until you're 12, which I can understand why the ACE would be kind of high, because it's normally 3 to 4 years to get a POTS diagnosis. It's 6 to 12 years to get a diagnosis for immune dysregulation. Because again, a lot of my colleagues have been taught, this is what you look at. It's very myopic, and we need to kind of broaden that view. So, and this is a paper, I felt sorry for the gentleman that was profiled in this. So he actually had anaphylaxis to venom, which is almost pathognomonic for having systemic mastocytosis. but they went ahead and looked to see if he had anything else. And yes, he actually did have systemic mastocytosis. He also had HAT, and he had alpha-gal meat allergy. Poor guy. So he, and he lives down in Arkansas. So when they're barbecuing, he can't be outdoors with his kids when they're playing football. And this is the work that I was just talking about. Over 980 patients. This is a retrospective study. Again, using the term mast cell activation disease. And let me just talk very quickly about the vocabulary surrounding mast cells. Mast cell activation disorder means you have one organ system that's involved. Mast cell activation syndrome means you have at least two organ systems that are involved. You have brain fog and gastrointestinal upset. You have a rash and joint pain. And then I can find tryptase, which is great. But if you have peanut allergy, which is a mast cell disorder, and the tryptase is never elevated in food allergies, does that mean you don't have anaphylaxis or we don't have enough tests? And that's where we are right now. We do not have enough tests to define the different avenues of mast cell activation. This paper, we identified over 19% of the over 900 patients that I saw had evidence of musculoskeletal hypermobility, mast cell activation events, whether it was driven by the nerves or something else, and antibody deficiencies. And 1 out of 1,200 of us has an antibody deficiency. And you don't know until you don't know. So a little intermission. I always like telling a joke. Okay, so let's just move over to EDS. Okay, so it's interesting in honor of Dr. Graham, who we just lost not too long ago. EDS was described, interestingly enough, not by Dr. Ehlers, but not Dr. Danlos, but by a Russian gentleman who I can't pronounce his name, so I'm not even going to go there. But literally, it was hypermobility and stretchy skin. And then the 1960s, we had the Beighton score, which interestingly enough, even though your population was described as Hispanic and non-Hispanic, the Beighton score was actually described about how South Asians and Africans of color were much more likely to be hypermobile. So we're completely underrepresented in understanding the dynamics. And if you look at classic allergic disorders, the severity of classic allergic disorders are much higher in patients of color. So there's a huge unmet need there. That being said, for all the other EDS variants, because we're now up to 13 and probably growing, 1 out of 100,000 to 1 out of 1 million for the more rare forms. But the HEDS, HSD, depending on who you talk to, 1 out of 500 to 1 out of 1,500. That's an epigenetic phenomenon. And as said before, and it's very frustrating, you're hypermobile and you get the genetic testing. For the most part, to get the diagnosis of HEDS and HSD, you can't get any of these other genetic variants were detected. So it's a diagnosis of exclusion. But we do have a clue from one of the EDS variants, and I would argue that periodontal EDS is the first evidence that we have that, a issue in the immune system can cause a global connective tissue issue. So instead of, one of the collagen genes or 10XB, it actually is complement. And if you can't find an immunologist that knows about mast cells, you ain't gonna find an immunologist that knows about complement. That's just the way it is. There's only 2 centers that I know of in the country, but interestingly enough, it's definitely getting the attention of the pharmaceutical industries because there's at least 5 medications that are now available going for complement-driven mast cell activation. So just trying to restrain the mast cells when the mast cells are seeing something they think is dangerous, it's like holding a police officer back who sees a crime being committed. They're not going to stand down if you use antihistamines or leukotriene antagonists, or even cromolyn, which as Mr. Fenner had mentioned, it only goes after degranulation. Mast cells release chemicals lots of different ways. So just to give you an idea what happens with complement-triggered inflammation, in this panel here, see if this works. Hey, intact collagen fibrils, not intact collagen fibrils. This is hypermobile spectrum disorder and hypermobile Ehlers-Danlos syndrome. And complement is responsible for doing that through the mast cell compartment. So my question is is secondary mast cell activation disease a way to identify the basis of individuals that have musculoskeletal hypomobility and the consequences of having long-term musculoskeletal hypomobility issues. And the person who was very instrumental in identifying this in the HEDS population, HSD population, is in this room. Dr. Norris, you hanging around here somewhere? There you go. I think this work, when it comes to phenotyping what's going on in the immune system, will give us a better idea of what's going on with the integrity of the connective tissue. So I'm going to argue that this is a barrier effect, that we've had a huge change in the exposures. Our clothing is no longer cotton and silk. Our foods are no longer locally raised and littered with heaven knows what kind of processed dye or food stabilizer or emulsifier. And that's why I would say a lot of patients who are from the US and then they go to Europe, they tolerated a lot of foods there because guess what Europe has done? Completely banned these foods. So, and by the way, this was mentioned before, I have to argue that mast cells will respond to danger. That is their job. And so we see a lot of serologic negative inflammation, meaning you can have joint pain without ESR and CRP being elevated because the mast cells are doing their job in the tissue that has not crossed over to the blood. And so how do we look for whether or not somebody has the etiology of immune-mediated musculoskeletal disorders? Do you have multi-organ system involvement? But I'm not just going to pin it on the mast cells. I got to look at the integrity of the connective tissue, and I also have to make sure that your nervous system is balanced. Do you have a mediator rise? I don't necessarily rely on the mediators. I actually go into the tissue just to identify that the first cohort for mast cell activation syndrome was actually a joint effort between allergy immunology and gastroenterology. They went into an IBS clinic, which again is like heavily female. They asked these patients, outside of your diarrhea and constipation, do you have rhinitis? Have you been treated for anaphylaxis? Do you have any issues with neuropsychiatric? And interestingly enough, they readily identified 20 people, looked at different mediators as well as the biopsies, and they were able to say, hey, let's get you off the Linzess. Sorry, I don't know the generic name for that right now. Let's put you on to Zantac and Zyrtec, and 100% of the patients showed improvement. But those individuals didn't have other things that are driving the mast cells. So we're going to look for musculoskeletal hypomobility causing, immune dysregulation causing musculoskeletal hypomobility. If you go through the MERG receptor, interestingly enough, for people who get radiology tests, pre-medicating with prednisone will do nothing. These cells, when they see gadolinium, just explode. So the best thing to do is actually prehydrate and pre-medicate 24, 12, and 1 hour before, and I'm happy to talk about this protocol afterwards. If you're having estrogen and androgen issues, I have to tell you, one of the biggest medications that was used prior to the fancy, expensive medications for angioedema was danazol, which is really interesting because danazol for the gynecologists is also used for endometriosis. And so and it's very interesting to see individuals who go on to another medication called TXA for short, which is used for bleeding disorders, also does well for angioedema and swelling issues as well. So there's this idea about repurposing old medications to see if they'll be effective. So, and this is some great work that's coming out of MIT. They took, all right, this is for the basic scientists in here. They took 2 strains of mice, C3H, or we'll just say mice A and mice B. They infected them with the pathogen that causes Lyme disease called Borrelia and just let them go. What was really interesting, all the mice got sick. They got sick differently. So mice A had some joint pain, some gastrointestinal issues, but they were relatively okay. But what was really interesting is the Borrelia wasn't multiplying. It was just growing longer, hijacking the connective tissue, acting as a squatter. So you can throw anti-parasitic agents at those mice all day long. It's not going to help them with their symptoms. What was really interesting in mice B, the females developed musculoskeletal hypermobility. So here's your infections. where you don't have enough of whatever it's needed to contain that pathogen. And that causes chronic activation of the mast cells, releasing these enzymes that Dr. Theoharides, who's my fave too, he calls them meat tenderizers. Really chews up the connective tissue, causing it to be loosey-goosey. And I just wanted to show you, these are the 4 other conditions that have been shown to be affiliated with immune dysregulation causing global musculoskeletal and connective tissue issues. The oldest one, appropriately named Job syndrome. That actually is a variation in STAT3. You have the HAT, hyperalpha-tryptophanemia, where you have a gain of function, which is associated with mast activation disease, musculoskeletal hypomobility, and dysautonomia. You have the periodontal EDS, again, vasculopathy, autonomic dysfunction, and mast cell disease. And interestingly, the last is Loeys Dietz. They all have bad musculoskeletal hypermobility issues. So you being bendy, you're almost like the canary in the coal mine of this society that's been completely transformed in 30 days, in 30 years. So we've had a complete change in our defenses dealing with an environment it doesn't recognize. As I had spoken earlier to someone, it's almost like your immune system is like Captain America coming out of the ice. He doesn't know who to go after, who's bad, who's not. It is a communication with the borders dealing with the environment and the responders. You have a surveillance that's made with the epithelial that is able to release communication to the nerves and the mast cells saying that there's a problem. You have the nerves saying, yes, this is a problem, and I think it's a pathogen, physical trauma, change in temperature. All of those, and by the way, I developed cold-induced urticaria, and I was teasing my daughter. I'm like, you know, I don't understand why I'm having problems with the cold. I walked up and back, uphill in the cold in New York. I never had problems with hives. What happened was when I changed my lifestyle and became a graduate student, and I think a lot of people who were dancers or swimmers or volleyball players, your conditioning changes. That conditioning will actually change the dynamics between the nerves and the mast cells in the connective tissue. So when you think about, a lot of people are able to point to a particular event that caused them to be unwell. You have to look at what was going on with you at that time. Pregnancy, motor vehicle accident, COVID is a big one. So it's an exposure, an environmental exposure that took away what little reserve you had, which my guess is you've been dealing with ever since you were knee-high to a duck. So you had a healthy epithelium with great communication between the epithelium, the somatosensory nerves, and the mast cells. And because our environment so dramatically changed in less than a generation, that which is dealing with exhaust, like if you live within 500 yards of a major highway, you're breathing in those volatile organic compounds that will injure your epithelium in the airways. If you're eating processed foods, you'll injure the mucosal lining. And then detergents, I had one child who had what looked like bad atopic dermatitis. It turns out mom was just soaking the bottles in so much soap, it actually stripped the barrier. And it was how she was cleaning the bottles, not blaming mom. She was trying to do the right thing, but she didn't know that that's something that she shouldn't be doing. So it's what we have done in our environment that's causing us to be so unwell. And it's manifesting with dysautonomia, mast cell activation disease, and modified connective tissue. So ancient threats, good luck going to safari, because right now your immune system is completely confused. These are the offenders right now. It's a complete mismatch between what you've inherited from your ancestors dealing with this modern environment. And there was a major tipping point, I would argue, in the 70s and 80s, when we started seeing such a dramatic change in what we eat, how we spend our time, what we wear, and how we spend our time. The average American in the 1960s maybe spent 60% of their time indoors. Now it's 90 to 92%. We're inside of something that's manufactured. And this is just a graph from several articles showing that the burden of disease, and I think we really need to pay more attention to complement and its interactions with the mast cell compartment to try to help people get better in conjunction with other disciplines. I think physical medicine and rehab needs to be incorporated much more so, and I'm very excited to hear that you have a physical therapist attached to your clinic. We're working on that. Immunology. Unfortunately, I understand because I remember the conversation I had with your team a few years ago. They wouldn't even count rhinitis as a mast cell disorder. I'm like, where did you go to school? All right. And then literally, once you figure out that your mast cells are misbehaving or your nerves are misbehaving, we need to figure out the different ways that can be happening. And that will then confirm to more tailored, personalized medicine based on what you diagnose. Right now, we are identifying individuals with autoinflammatory syndromes, immunodeficiency syndromes, angioedema, and we're doing robust genetic testing in addition to tissue testing, because guess what? Mast cells are not really in the blood. They're in the tissue doing their job. These are the various masqueraders, but I would also say collaborators to the trifecta of issues that most folks are dealing with. So we're really talking about, do you have an antibody deficiency or not enough T cells, like the Tregs that you're talking about, that help keep the mast cells in check? Do you have, autonomic dysfunction? And that just tells me your nerves are misbehaving. Again, doesn't tell me why. Do you have familial, like you have a structural issue with the nerves? Do you have undiagnosed Ehlers-Danlos? Because the time to diagnosis for Ehlers-Danlos is what, 2 decades, right? And immunodeficiency, and interestingly enough, the biggest immunodeficiency I have identified is not the antibodies, it's actually mannose binding lectin. And if you want to talk about immunology, this is part of the complement system. And lastly, the danger signals that come from the epithelial barrier. The ones that most people are familiar with in the health professions is Mediterranean fever. But Yao syndrome or NOD2 actually is probably the more prominent ones. And we actually have targeted medications for this as well. So epithelial barrier doesn't like the world we're living in right now. And we've seen this in a rise in both immediate and delayed hypersensitivity disorders. Yes, it goes through the mast cell, but I would have to argue that the mast cell is, well, it depends on how you see the chicken or the egg. I would argue that it's secondary mast cell activation, but the way you can do it is having a criteria. And by the way, when you mentioned the global consensus one, the 4th criteria wasn't mentioned. They have always leaned into make sure you're not missing any other disorders. And this is where we are right now. We have a neuroimmune decision tree that is awry. In order to help you feel better, we have to go after all 3 legs. You just can't focus on the connective tissue. You just can't focus on the immune system, and you just can't focus on the nervous system. It is a communication that goes on in the body every moment of every hour of every day. We need to get that happening under the roofs of this historical institution here as well as in South Carolina. Because and bless you, because UVA, Brigham didn't want to do this. Stanford didn't want to do this. Columbia didn't want to do this. Mount Sinai didn't want to do this. Mayo, through Dr. Knight and colleagues, but that wasn't the case in the mothership. Understand, it's much easier when you have to do a 3-minute presentation. Most patients have a 3-minute pitch. You're not going to tackle somebody who's been dealing with issues for more than 10 to 20 years. So.
I know there's probably lots of questions, but we have time for just a couple. Yeah. Yeah.
Biomarkers, not looking at blood, looking at what is the advantage for either somebody who is already diagnosed, let's say, supposedly with MCAS, and also some undiagnosed. Getting biomarkers, let's say, from endoscopy or colonoscopy procedure. And the reason why I'm asking is I have a schedule, and the gastroenterologist is using to do the biopsy for mast cell.
So the question is, if this is a tissue diagnosis, how can we better sort out getting the appropriate testing, especially the immunohistology. So I would ask you to come up and see me. I'm happy to give you the paper that's from gastroenterologists from Brigham and Women's, right? And then I would ask if you have an allergy immunology specialist, I gave you that diagnosis, they need to write a letter to that gastroenterologist, because if they don't do the testing, that's actually compromised medical care. So I'm a bit of a New Yorker, I'm sorry. All day long, which also leads me into, so the question is, what is the crosstalk between mast cells and adipose? Which I think, given all the so-called evidence about GLP-1 agonists, I have to tell you, we don't have enough data regarding GLP-1s and mast cell disease. I don't know what microdosing is. I don't know what that means, especially when somebody's had years of issues. We know that the adipose and the mast cells talk to each other all the time, because adipose acts as a major resource for micronutrient support as well. The problem about GLP-1s, especially if you have a connective tissue issue, what if you start compromising your muscular support of the loose ligaments? I've actually had one patient go on GLP-1 and ended up with worse cervical spine instability. So I think everything, again, has to be in context. And so I have a rule of 5 when you go see a new practitioner, and I tell the patients who come see me, please use this with me as well. Do I have an idea about what's going on? And if I don't, Madagascar, smile and wave, get out. 2, what can I give you? Because you've been having these symptoms for quite some time. Because both Dr. Knight and the center here, we both have wait lists, because we're one of the few that are willing to stay on this medical oasis. What can I give you to help you feel better? Whatever I recommend, what are the potential side effects, right? Even if it's exercise or oxygen. I had one patient that was recommended for a PMR to go aquatherapy, but they didn't tell the physical therapist that she had cervical spine issues. So they had her doing planks, which exacerbated her neck pain, right? And then after that, what is the testing that I'm going to get to kind of go after my hypothesis? Because that's what it is. And then when are you going to come back and talk about all of it, right? Forget about Angie's list, right? I think it's really important for you to kind of go in, because if you only have a few minutes, you have to have very focused questions, especially with certain specialists as well.
One last question, sure.
Yeah, is there any, is anybody looking at
Yes. So the question is mast cell cell activation disease been identified in other connective tissue disorders? Yes. The EDS, low EDs, Marfan's, osteogenesis imperfecta. If there's tissue injury, mast cells, their job is to respond to tissue injury. You just hope that they identify it. It's kind of like, calling 911. Well, what's the emergency? You don't want the police pulling out their gun to take the cat out of the tree, right? So it's important that if the mast cell thinks it's venom, when really it's just, a fly flying by, not a tsetse fly in Africa, it just has a local reaction. It shouldn't go systemic. But that's what we're seeing. And I agree that the fight or flight, we're at a higher state of alert. Anxiety is at its highest here in this country. And it really has to pertain to how we live. So, thank you.
Thank you. So we'll get in one more session before lunch. And if you want more of Dr. Maitland, I know we all do. I think I just heard it announced this morning that the recent Bendy Bodies podcast with Dr. Maitland as a guest was just released this morning. So feel free to get more from there. But yes, for this next session, building on now all of that clinical research and discussion about mast cells and mast cell disease, we'll hear from Molly Griggs, also at the Medical University of South Carolina. Molly works with the Norris Lab at MUSC, where she supports research operations and program coordination. Molly's background spans research, public policy, and organizational leadership, contributing to multidisciplinary work in connective tissue disorders. Please join me in welcoming Molly.
Good morning. I'm thrilled and honored to be here to talk about the patient scientist model of research that we're pioneering in Dr. Norris's lab at the Medical University of South Carolina. Maybe? Yeah. Awesome, thanks. So my name is Molly Griggs. I have no disclosures to make about my conflict of interest, but I am the program coordinator at the Norris Lab, and I also am the director of our patient scientist initiatives. I make a note that I have no disclosures and conflicts of interest to make because it is important for you to know that I have a personal interest in this. When I walk in the door in the mornings, I come in as a professional. I am there to do my job. But I am also a patient with HEDS, and I'm the mother of 3 teens who have varying diagnosis of hypermobility disorders. So my work sits right at the intersection of that, and that is really the lens through which I view the work that I do. I'm actually in this position because I am a mom of patients. This is my daughter, Charlotte. Her story is a familiar one. Most of you in the room, whether you are a patient, a parent, someone working in this field, will know this story. When she was 14, she started having unexplained headaches, unexplained fatigue, nausea. She couldn't get out of bed. She struggled in school, started to have surgeries to fix things, and eventually had to leave school. And it was at this point that we really began to lose hope. But someone opened a door for us. Her biology teacher had gotten her master's in Dr. Norris's lab, and when she heard that Charlotte had been diagnosed with HEDS, said, "Oh, let me introduce you to some researchers who are working in this field." And so Charlotte started working in the Norris lab when she was 14. Dr. Norris opened his doors to a child who had not yet finished biology, had never held a pipette, but who was so excited about the research. I was the mom that was driving the 14-year-old to the lab. She could only work for a couple hours at a time because of her health. And so I would drive her down there and then just sit around and wait like parents do. And started outside the building and then in the hallway and just kept getting progressively closer until finally I sat down with Dr. Norris and I said, "I really want to come play. This looks like so much fun." So my 14-year-old taught me how to extract DNA from saliva, and I started working on the DNA registry as a volunteer. All of this happened because someone listened. Her biology teacher listened to her and cared about what she was going through. Dr. Gensimer and Dr. Norris listened to her interests, and Dr. Norris heard that she needed something in her life. She needed a way to be able to contribute meaningfully at a time when she had lost what feels like everything to a 14-year-old. And this idea, listening, is really at the core of what we do in the Norris Lab. We believe that patients have expertise that is important for us to hear. They know their disease history. They live not in an organ system, but in a body where it all happens at the same time. And so they see patterns and symptoms that physicians who are looking at one part may not see. They're experts in navigating the healthcare system, and they understand rare symptomatology that they actually end up being experts in and seeing physicians who don't understand it as well. But these patients also long for community. These are lonely roads that we walk, and it is important for us to be able to walk alongside people who are moving in the same direction we are. And because they've experienced a lot of medical care, a lot of treatments, there's a lot of hopelessness, despair, concern, loneliness that we see day in and day out when we talk with these patients. One of the ways that we used this opportunity to listen to patients was actually in a global survey, and I'll talk about it a couple times during my talk. But one of the things that we started to see was that joint manifestations here is really the hallmark of HEDS. But when we asked patients, what are the 3 most severe symptoms that you live with? They said chronic pain, GI symptoms, and autonomic dysfunction. Only one of those is considered in the diagnostic criteria for this disease. So what we began to see is that there's a mismatch with how we understand HEDS and what patients actually experience. So when you listen to patients, scientists and physicians have been doing that forever. They collect data, they take history, but it's a unidirectional perspective. So patients are subjects and they are providing the information to the scientists and physicians. So what we're working to do is change this model. And in this model, scientists listen to the patients and learn from them. They see the patients as an expert that they can lean on to problem solve when things get tricky. Physicians learn from the patients, and patients learn from the physicians. But more than that, to help patients truly become partners in this, we want to help the patients become those scientists and physicians. So this is the journey you're all familiar with. I'm not going to walk through it. If you've been in this field, you know it. This is also the scientist's journey studying EDS. When you start from an inaccurate assumption that this is based in collagen, that this is a connective tissue disorder, that it's about joints and skin, you're going to be looking in the wrong direction. And so we began to think, what if we bridged these 2 paths? And when we do, we came up with this patient scientist idea, where you take the lived experience and expertise of the patients and you provide them with the scientific training that they need to work on clinically relevant investigations. You bring their passion and our research tools. And in doing so, you can really drive forward the translational research. So this is our patient scientist model. The key part is that patients are the experts of their bodies. They have lived experience that is meaningful. It's not a token, oh, we should listen to the patients. They have real expertise. You embed the patients within the research team with intention, and I'll talk a little bit more about that later. And then you provide the training, structure, and support these patients need to be successful in the field. And when you do so, it creates the conditions for patients to be part of the solution. And I want to stop for just a second and point out these pictures. These are all patient scientists who have come through our lab in one way or another. These are just a handful of them. And so as I talk about this, I want you to know that every part of this is based in the people who are coming through these programs. So what does this model look like in practice in our lab? We have 2 formal programs for patient scientists. The first is our HEDS intern program. We call it HIP. It's a summer intern program, 8 weeks, designed for patients and people with close personal experience with the disease, so family members, friends, who are interested in going into science or medicine and are dedicated to working in the field of EDS. These are primarily undergraduate students. We have some who are high school students, very rarely. We also have some that are graduate and medical students. And they're here in the lab for 8 weeks and work on a portion of the research that we are doing. So our goal with this program is to bring in students and really give them the skills that they need, teach them the techniques, get them exposed to research, and provide them the support that they need to be able to get into the next level of their education. We started this in the summer of 2021. We had 4 interns. One of our interns is here, one of our initial interns from that summer. We had 25 applications for that first summer. That's a pretty big, 25 applications for 4 spots is pretty hard. We're doing year 6 now, and we had 134 applications for our 4 spots. So with the need growing, there were so many patients that we were having to turn away. And so a foundation approached us and said, we want you to grow this bigger. But we are a single lab. We are limited in space and the number of mentors that we have to provide for these students. And so we couldn't bring more interns in during the summer. So we decided to create a new program called the Visiting Scholars Program. And we actually have a few visiting scholars in the room with us today as well. But in this program, you come for a few days, and it's a very immersive program. You shadow the lab, you hear from the patient scientists, you learn about the research that we're doing, and have an opportunity to really begin to see where you could fit in to this field. It's usually 3 days. You would think that's not a super long time for anything important to happen, but I'll talk with you some about the outcomes that we see from this program. You can see our applications here. The first year we had 116. We were able to bring 15 students. We've revamped the way that the program works, and I'll talk about that in a second. And so now we're able to bring, this year we brought 40 students in groups each month. So initially we were hoping to train about 55 patient scientists in the first 6 years. We are on track to have trained 150 by the time we finish with this summer's internship. So the way that we do this, most of our outreach is through social media. We have been fortunate to have a very wide reach on social media. There's a lot of interest in the work that we're doing. And so we promote this there. We hang flyers in physicians' offices. We put it on our website. And we really don't have to do much promotion these days to be able to get the students that are interested in this work. But one of the hardest parts is selecting students. How do you select 4 out of 134 students to be able to come join you for the summer? And our primary focus is on the program impact. Who of these students is going to have the most impact from this program? A lot of these students are going to get into graduate school no matter what. But there are some that need that extra level of support. They need more training. They need an opportunity to be in an accessible lab and gain the confidence to know that they have a place in this field. So our focus is always on how is this program going to help them drive this field forward in the future. During these programs in HIP, they have a wide range of opportunities since it's a longer program. Like I said, they work on the research that we're doing in the lab, but they also have an opportunity to do clinical shadowing with our physicians focused on EDS at MUSC. We have seminars with experts in the field, which is an incredible opportunity to get to sit down and actually talk with physicians and researchers about the work they're doing. And then they get one-on-one mentorship from a student, a graduate student, a research specialist, a clinical coordinator in the lab who can help them troubleshoot their projects, guide their work, and talk about graduate school, medical school, what it is that they are interested in going into. So the outcomes of this, I'll talk a little bit more about in a second, but one of the things that for HIP it does for the students is it allows them to have an opportunity to have data to present themselves. This is one of our interns, Shayna, presenting her summer research at a conference. We also have a wide number of manuscripts who have authors that are interns, and I think primarily interns as authors on the papers. But more than that, what we are seeking to do is build a network of people in this field who are passionate about driving the work forward. We need more scientists who care. We need more physicians who understand the disease. We need more advocates and PTs and OTs out there working, and we need them to know one another so that they can work together. This picture right here, the first year of the program, I said we brought 15. We brought them individually for a couple days at a time. And then one time, these two right here ended up coming at the same time. Someone had to reschedule. And what we found was what I talked about at the beginning, the opportunity to meet another person who is interested in the same work that they were, who lives with the same condition that they do. That community meant as much to them as the opportunity to be in the lab. And so the next year we began to put together groups, and these groups are carefully selected to, they might be high school students 1 month, or professionals, or medical students. We group them so that they begin to network with the people that are going to be their colleagues in the field moving forward. So I want to introduce you to one of our visiting scholars. This is Taylor. She has a bachelor's in American Sign Language. She did have a minor in chemistry and biology, but not a lot of science background. She was working in the medical field as a communications facilitator for deafblind patients. But she came in January of 2025 as one of our visiting scholars. And after 3 days in our lab, she applied to be our clinical coordinator, moved herself from Portland to Charleston, because she spent 3 days getting an opportunity to see the impact that she could make in this field. She is now running our biorepository among all of our clinical collaborations that we have going on at MUSC, and I think Dr. Norris will talk about them later. But she's running our biorepository, which is building an opportunity for us to have patient samples that we are working with in the lab. She also works as a disability advocate and science translator on Instagram. She has a vibrant Instagram account where she's helping our science communicator get that word out to as many patients as we can so that patients are educated about the science that's coming out. She's working with physicians and scientists to ensure that we are working together to move this field forward. And this summer, she's going to get to be a mentor for our interns. One of the things that many of you may wonder is, how do you do this with this patient population? We have patients that are really, really sick who are coming into our lab. And so one of the things that we have to think long and hard about is how to make this an environment in which they can be successful. And this is important because 1 in 4 Americans actually live with a disability. But in 2019, only 4.6% of medical students disclosed that they had a disability and were able to access support services as a result. 10% of all of the disabilities are non-apparent or invisible, and that's a lot of what we live with. The only ways that many of our disabilities become apparent is when we use braces, mobility aids, things that show that we are not feeling good on the inside. And this is the most important piece to me. In 2021, physicians were polled, and only 40% of those physicians felt confident in their ability to provide care to disabled people. We need more people in the medical field who feel confident working with this patient population. And who better than these absolutely brilliant women and men? Mostly women, but we do have some men. This population lives, this is from our global survey again, 99% of the respondents in our global survey who had HEDS reported having signs and symptoms of dysautonomia, orthopedic problems, 96% neurological problems. They are living with not just a single disability, they're living with multiple. And so we need to make sure that they have what they need to be able to succeed in science and medicine. So how do we do this? I'm going to let our interns actually tell you about it. Those accommodations did not happen automatically. We had to work for them. We had to work with the institution to get them implemented. We had to provide funding to get them implemented. But more than that, what Dr. Norris has created in the lab is a culture of flexibility. He understands that there are going to be some days when we can work 14 hours, and there are going to be some days where we can't get out of bed. And he allows us the flexibility to be able to show up in that way. And what we see is that when that happens, patients in particular, when they feel good, they're going to get the work done, and they are going to work harder and faster than a lot of others because they know that it's not always going to be that way. We also have things like a sofa. So if you need to be horizontal, Dr. Norris got tired of us laying on the lab floor. So he finally bought a sofa for us to be able to lay down on for a few minutes. We provide mentorship from full-time patient scientists who are doing this work day in and day out. And so we've figured out the hacks to be able to be at the bench, or how to use a neck brace in a way that allows you to not strain your neck when you're doing things. But the most important part is actually normalizing these invisible disabilities that we live with becoming visible. Normalizing wearing braces, normalizing using mobility aids, normalizing having a heat wrap around your neck and an ice pack on your head and wearing sunglasses inside, because that is what it took that day for you to be able to be in the lab. And by doing so, we're allowing people to show up the way that they are and be more effective and more productive during that time. My daughter once said her favorite thing about the lab is that when she walked in, her illness was the least interesting thing about her. And I think that that's so important, because when you live with this all the time, it kind of consumes you. And so having a place where you can just exist, where nobody's questioning like, oh my gosh, did you get in a car accident? What happened to your shoulder? You're just there with your shoulder brace and your neck brace, getting your work done. So I talked about, we have these two programs that we have, but we also have work that we do outside of the programs. 2/3 of our full-time research team are patients. This includes high school students, undergrads, graduate students, medical students, clinical coordinators, research coordinators. We run the gamut in there. And so because of that, patient representation exists at all levels of the research being done. We provide development, so no matter what age you are or what experience you have coming in, we have supports in place to be able to train you. Dr. Norris always says that there are two things he requires of the people in his lab, and that's passion and creativity. He can teach anything else. And so the patients that we bring in are patients who are passionate and creative, and the rest of it, we teach them. And the big thing is, a lot of times there is token patient voices. There's a panel, there's a consultant that they're working with. We don't want to just make sure the patient voice is included. We want to actually change who is in the room creating the knowledge. One of the ways that we do this is by asking the question, what matters most to patients? This is a glass whiteboard. It sits right next to my desk. It's pretty big. And a couple summers ago, I challenged our interns to write up the questions that they had, because we were working on taking a big research question and like narrowing it down to a testable hypothesis. So I said, write your questions up on the board. I'll be curious to see what you have to say. And I came back the next day and the board was completely full, and we abandoned all hope of hypotheses, and we turned it into an opportunity for these patients to tell us what questions they have. So now, any patient that comes through the lab, whether it is a student or someone coming in on a tour, they have the opportunity to write their questions on the board. And these questions we actually look at, and they've changed the way we think about our work that we're doing. I have talked too much, so I'm gonna have to skip really fast through a few of these. Right now, we're in the process of evaluating this model. Last summer, we had an intern who, for her intern project, took on evaluating our program. We want to see, are we actually achieving what we're setting out to do? And what we're finding is that we are. We have patients who have come from 37 states. The knowledge that they are receiving are going back to those 37 states. We are seeing the knowledge of this disease spread across the country. Of the patient scientists from our programs who have applied to graduate programs or medical school, 100% of them have discussed their work in the Norris Lab as part of their applications. 85% of them were accepted to the programs of their choice. We also find that this is changing the research, and I wish I had more time to talk about this, but I think Dr. Norris will touch on it later. In our global survey, one of the things that came out of it was the question, why is it that 70% of patients report triggering events after which they never get better? Why are the most severe symptoms things that are not necessarily related to their joints? And what we're beginning to find is that while the traditional view has been of structural problems, there is a neuroimmune aspect that we don't yet understand. And much of that has been driven by the patient voice. These are the numbers. In 6 years, we've had 600 plus applications to our programs from all 50 states. GPAs, the average GPA is 3.7. This year alone, we had 134 applications for our program, and we had to turn away 95% of them. We need more programs like this in more institutions because this is powerful, not just for the students that are participating, but for the research itself. It is changing the field. And so I want to leave you with one more story about our interns. This is Victoria. Victoria was a professional dancer. She trained at the Boston Conservatory, danced for 10 years, got diagnosed with EDS, as many dancers do, and decided to go to a post-bac program at Columbia. She applied for our intern program and was accepted in 2022. Her patient science journey is exactly what we hoped for these patients. She brought her lived experience. We gave her the scientific training. She had never held a pipette when she walked into our lab. She was brand new. But she brought passion to her work. She was our first clinical coordinator and built the clinical collaborations that we are now beginning to work off of. She was the author on this global study, and she worked with a panel of patients to come up with the questions that were asked. And the feedback that we got repeatedly when patients took this survey is that they felt for the first time that someone actually understood everything that they were going through. She is now a medical student, and you would think that'd be enough. We got her into med school. She's going to go be a doctor, but she didn't stop there. She created a lunch and learn for all of the students at MUSC across the colleges, because right now HEDS is taught inappropriately to the students. And so we are working to change that. But in the meantime, the lunch and learn, they usually get about 30 to 40 people who come. We had 160 people show up to the lunch and learn to hear from scientists, patients, and physicians about what this disease really is. So patients don't simply have to wait for answers anymore. As patient scientists, they are helping create them. This does not happen alone, and I do want to take a moment. I know Dr. Norris has gotten pointed out a couple times today, and I apologize, but this work exists because of the hard work of many, but it is because he saw what could be possible, and he took a chance on something new. He doesn't just come in and tell us what to do. He has created a space where he brings people in and allows them to grow in their roles. He allows ideas to flourish, and he allows new perspectives to really take root. And in doing so, this field is fundamentally being changed. The Norris Lab is huge. We have a large number of communicators, but for me personally, the patient scientists that I've gotten to work alongside, they are the greatest joy that I have had in my life as a patient, as a mom, and as a professional to be able to work with them. So thank you.
No, we're getting very hungry, but we do have time for a quick question or two if there are. You can sign that everyone's hungry, ready to eat, right? Yeah. Yeah, go ahead.
Yeah. Yep.
One thing I noticed is there's a lack of federal funding of this effort, and I think there should be. I think get office for more when scientists to be trained and then they can work on problems that are needed for that. But aside from that, how did you do this already with them?
Yeah, so the question is, how did we fund this? Did we approach foundations? And the answer is we were very fortunate. This started out of a donation. It was the very first donation Dr. Norris ever got. It was unsolicited, and they said, be creative. And so it was enough to pay for a research specialist for a year or fund a graduate student for a year. But with it, we could fund 5 interns, and we could teach them to then go beyond and be those scientists and those research specialists. So that was how it started. The other foundations have heard about our work from various places and have approached us. There's always a need for more funding. That's a whole talk in and of itself. Thank you.
Thank you, Molly. Okay, yes, we've had a full morning. We need to refill, rejuvenate, but these have been excellent sessions. I love to hear about the programs come together with science and clinical work all in one. So thank you again, Molly. So we are going to go to break to lunch now. Just a couple quick notes from the organizers to try to help facilitate all of this. So lunches are set up upstairs and downstairs. There are different options on each level. Bags have salads in them. Those are gluten-free. And there's water available, and the box lunches have can of soda in them. So grab your lunch, then eat in 2ABC. Then we'll resume at 12:30 with Dr. Chip Norris. Thank you.
I'm going to add one more technical note to that to help you with your wayfinding. This is considered floor 1. So this is downstairs, and then upstairs is floor 2. The lunchroom is upstairs. So you would need to take the stairs up or take the elevator that's at the end of this hallway.
Okay, everybody, we're gonna try to get started soon.
All right. Good to go.
Okay, everybody. All right, I'll put on my loud voice. Okay. All right. Now I'm putting on my mom voice. All right. All right. Thank you. Thank you. Thank you. All right. Don't get me mad. Okay. Thank you all for being here. Welcome, welcome back. And I just want to thank our speakers already for this morning. We've had an amazing morning, haven't we? Yeah. It's been amazing. Yeah. Thanks, everybody. And we have an amazing lineup for this afternoon. So I want to start with introducing our keynote speaker for the afternoon. And I think we've already heard his name maybe once or twice this morning. Coming all the way from MUSC, from the Medical University of South Carolina, we have Dr. Russell Chip Norris here today. So let me just tell you a little bit about Dr. Norris. Dr. Norris is a professor of regenerative medicine and cell biology at MUSC. He has clinical appointments in both neurosurgery and in cardiology. His research basically focuses on genetics and connective tissue diseases, with publications in leading journals such as Science and Nature Genetics. He is internationally recognized for his work in mentorship, and he is paramount in moving the research field forward in patients with Ehlers-Danlos syndrome and other hypermobility disorders. And I just want a little welcome for Dr. Norris, so please welcome him.
All right. Well, what a pleasure to be here. It's tissues. I get a little emotional sometimes, so I apologize in advance. Yeah, it's really a pleasure to be here. This is just an amazing institution. I've known Lori, Dr. McMahon, for many years as our former VPR, and just what they're building here is incredible, and I look forward to working with them for many years to come. So I don't really like my title. In fact, I really don't like titles of talks at all because they always seem corny. So I'm going to move on. This is what really matters. This is my group. It changes a lot because we have a lot of different people come and go. I don't know how many, there's maybe 30 people in here. 16 of them have Ehlers-Danlos. We hypermobile type. We are committed to including these patients into our programs. And as you heard Molly just talk about, it's really an amazing program. And I'll talk about it more a little bit later. I have one slide on what HEDS is, or maybe two slides. It's characterized as and this is like, who doesn't know this? It's characterized as a genetic connective tissue disorder. I would argue that it's not a primary connective tissue disorder, but that's up for debate. Significant healthcare burden. Everybody in this room knows that. Very little is known about the phenotype and the genetics and the biology. And there's obviously challenges because of this in diagnosis and treatment. Phenotypic heterogeneity is the rule. And defining HEDS is really restricted to a clinical diagnosis. These are things that are known. So let's try to figure out things that aren't. What's the problem with physicians? Yeah, sorry, sorry. You know, there's even at MUSC where we have a really we have a lot of physicians that actually understand and recognize this disorder. But unfortunately, this is how it's taught. This is a slide that comes from our own medical school teaching curriculum in the musculoskeletal block. This was 3 years ago. So if you're a medical student learning about Ehlers-Danlos, learning about musculoskeletal conditions, and this is a slide that you're presented with, how do you take this? You take this as, oh, it's rare and it's, you know, they have stretchy skin, they might bruise, and, you know, they certainly don't have a whole lot of other things wrong with them. So if you see these patients and they have a litany of issues, it must all be in their head. And that's what they're taught. And this is a real problem. So this is no wonder why physicians don't care. Physicians in this room do care. That's why they're here. But we need to educate the physicians as a primary care physician in Fargo, North Dakota, that when a patient comes into his clinic, he understands and knows what this condition is. And we have a job and albeit a responsibility to pioneer this. And I think with UVA, I think we have a real chance to accelerate this. And I'm going to talk about some ways that we can. This is what HEDS really is. This really stemmed from Dacre's work as well as a couple of recent papers from us. You'll see I'm not going to go through this. There's a lot of comorbidities and conditions that are wrapped into what HEDS really is. So there's a great disconnect between clinical diagnostic criteria and reality. I think everybody recognizes this now. And we really do need to do better for these patients and their families. And so this is sort of how I view my lab. Basic science research. I'm just a dumb scientist. I'll talk about like why me. I really don't want it to be about me, but I'll talk about how I got started a little bit later. So I'm a basic scientist, so I'm really interested. I got trained in molecular genetics and I'm really interested in genetics and biomarkers and developing models and mechanisms, models that will lead to mechanisms, and then that leads to therapies. Very interested in clinical research, education, and then of course advocacy and awareness. This is what my lab does. I just sit behind a desk and try to think of things to stay creative and passionate. So how do we start? HEDS is a really tough thing to start with because it's, where do we go? What's the first step? And so the first step for us was this: IRBs. I hate IRBs. I'm a scientist. A scientist writing an IRB is just a terrible idea. In fact, my IRB, finally, after I'd done like 35 revisions of my first genetic IRB, said, why not just hire a coordinator to write this? Because you're terrible at it. So I did. I actually got Dan Judge, who's a cardiologist, helped me with it, and then we did it. We got the genetic registry approved. Now we have 18 different IRBs. We span almost every type of, or a number of different specialties, including orthopedics, neurosurgery, GI, autonomic dysfunctions, musculoskeletal, genetics, biomarker studies. So, I mean, we needed these. Now we didn't need all these. We just needed an umbrella one, which is what we're doing now, is just having a big umbrella IRB that's going to take place of all of these other ones. But this was really the starting point. Okay, we need to start with the patients. We need to start collecting clinical samples and see if we can understand anything from the patient, because there weren't any models. There weren't anything to really go for. So what does this allow us to do? It allows us to, collect samples. And now we have, I'm also the director of, the new scientific director of Precision Health at MUSC. It's I'm really happy about that job. But it does allow us to develop these biobanks. And we have an amazing biobank. Now we have over about 7,000 biospecimens from EDS, and it actually is supported through the entire institution. So costs are offset by the medical university, which is an amazing way to do it. So that really allows us to do a lot more than we previously could. So where do we go from here? We first wanted to better define HEDS. Really put numbers to it, really put metrics to it. And that started with the survey. Not dislike the one that Dacre and his people did at Mayo. It's very similar, and very similar results as well, which is great. And so we had, in the end, after we filtered down through all these different criteria, 3,300 in the HEDS group and 546 in the HSD cohort. And this is a problem. This is something that's really continually mentioned, and is a limitation of some of our studies, and really everybody else's studies, is the high percentage of Caucasian females in all of our research. I mean, it's 90. In ours is 95.8% white, and so the people of color, we need to figure out how to do better with them, and hopefully we can develop programs that will actually highlight their individual needs. In our study, we identified this diagnostic timeline. This was known, but we knew it was like long, but it was really profound in our survey. I mean, 22 years. I mean, it's just, how do you live with that? You have to do better. And then the comorbidities, profound, right? You guys know this, and you saw this panel in B earlier from Molly's, but I think what really was interesting to us, and it was something that we kept hearing from the patients, is that it wasn't necessarily so much the joints and you hear collagens everywhere. Yeah, of course it is. But what we were hearing, the major things that were wrong, or that these patients were really were chronic pain, autonomic dysfunction, and GI. Okay, joints was fourth. And that's telling, because when I started this, I was always thinking that this is Ehlers-Danlos. This is a collagenopathy. Primary defect in collagen. who came up with that decision? Just because people are bendy, you assume that they have a primary collagen disorder? Where's the data to tell me that? So it started me thinking, like questioning that as a primary cause, and maybe it is, but maybe it isn't. And I think we need to leave that option open. This was really confusing in the context of a primary collagen condition, although patients with Marfan syndrome and Loeys-Dietz and OI are known to have some triggering events, but 70% of our survey reported a triggering event. And these range from puberty, viral bacteria infection, physical accident. These are all things that engage the immune system. And that's what really started trying to, speaking to me that this may be more complicated than a initial problem with collagen. So the population demographics has really helped provide a better definition to HEDS. And I think that this should be included in any sort of diagnostic criteria that's being developed. Is it really a subtype of Ehlers-Danlos syndrome? That's not for me to decide. Other smarter people will decide that. Trigger events that I just talked about. The pain, GI, and autonomic function and the immune system really made us think about mast cells. I mean, you've heard that now, which is crazy, a few times already this morning. And maybe molecular analyses will help. And so I'm going to tell you about this candidate gene that we identified and maybe hopefully try to clear up some confusion. We had a large family with inherited autosomal dominant HEDS. These are clinically defined by 2017 criteria. We did whole exome sequencing on the two most distant relatives, and that's presented here with the arrows and the arrowhead. And from that, they shared 48,000 variants. We then filter that based on standardized filtering criteria and identified 6 rare and potentially damaging variants. Only one of these variants tracked with the family. So this is the only thing in the coding region in this entire family that tracks. It's pretty good. This is the variant we found is in KLK15. Many of you in the room have probably read this paper. We identified a second family. It's just a trio, and then the population frequency. And here's where some questions come in. CAD score tells you about the severity of the mutation. That's pretty high. The range goes from 0 to 35. 24 is known to be probably pretty deleterious. The minor allele frequency, though, is in NOMAD, it's 0.002. This means 0.2% of the population have this variant. Seems too common. And it is too common to, in my opinion, to by itself cause the condition. But maybe not. But is this a standalone genetic paper? No. In order to confirm pathogenicity, one thing we always do is actually generate animal models. And looking at the mutation itself is a disservice to the study. And we need to recognize the body of work for what it is. And so we made a mouse with the mutation. Now the mouse that has this mutation, that's the only thing changed in this entire animal. So any sort of phenotype that we see is directly caused by that change. So we did mechanical testing. I'm not going to go through this. There's statistically significant values. What this all means is that the mutant mice have increased elasticity in the toe region of the stress strain curves. I'm sure it's like you all know what that means. This is actually this is on an Achilles tendon that was stretched. Okay, and the curves represent the stress strain curve. And in the end, what it means is that the tendon and ligaments are more elastic. Okay, so it's a functional defect. That's good. That's caused by that variant that we put in. Structurally, we looked by transmission electron micrographs. And what you see is collagen fibrils. Those are those little round circles. That's what your collagen fibrils actually look like in your tendon. This is what it looks like in that mouse. same region of the tendon, same analysis. You'll see that there's a lot of little circles in there. They're not supposed to be there. We can quantify that. We've quantified almost 8,000 of those. It's painstakingly is done by 3 independent reviewers, all blinded to genotype. And you see that there's a leftward shift, meaning on average, the fibrils are smaller, and that corresponds to a more elastic tissue. So there's a structural phenotype in these mice. What about functional? And so we did echocardiography. We knew in the family that there was mitral valve prolapse as a common cardiac phenotype. This is a control mouse. Everybody here is, I'm sure, an expert on ultrasound echoes. The mitral valve is located right here. Yeah, everybody can see that clearly. Here it is in a blown up version. And in the KLK15 mutant, you'll see very thick tissues here, and they're actually prolapsing into the left atrium, showing that these mice have mitral valve prolapse. This is shown on higher magnification here. 83% of these mice have valve dysfunction, whereas 0% of the controls did. Okay. Histopathology, you see that they have myxomatous valves. So this really validates the mutation pathogenicity, even in the case of it not being enriched or having a more higher minor low frequency than one would expect. We then did whole exome sequencing on 197 clinically diagnosed HEDS patients. This was, here's a list of, and we wanted to scan KLK genes. By the way, kallikreins are what's in snake venom that actually makes you anaphylactic. So there's something interesting with what Anne was talking about before. You don't want to screw these genes up. It's also involved in blood clotting, which is not surprising, I guess. This is a list of all the KLK mutations. The KLK is a gene cluster of 15 genes. They're all organized together on one chromosome. And this is all the mutations that we find in these patients. There's a lot there. We did TRAP-D analysis, which is just a fancy term for saying, when you take these individual genes and the variants we find in each individual KLK gene, are they enriched in the population? And the answer is, you'll see the asterisks. This is per gene, so not per specific variant. You'll see that there's statistical enrichment of KLK, specific KLK gene mutations or variants in HEDS compared to controls. Be nice to have this, should be pretty easy to validate this. So there is statistical enrichment. However, the KLK15 variant, the one that we actually made the mouse of, is not enriched. And we know that now. So that's a little bit confusing. But when we look in the literature, and this is primary literature that's not older than 5 years old, other conditions that have minor allele frequencies higher than expected and are not enriched in the population, but are known to be pathogenic. This is just a list of probably close to 100 different conditions. Hemochromatosis. So you see the disease over here. You'll see these are all missense changes for the most part. There is sex bias on most of them, and they all involve triggering events. And they all have high CAD scores and relatively benign minor allele frequencies. So, in here are a lot of different autoimmune conditions. And so, I think that that's something that needs to be taken into consideration and not just a blanket not enriched in the population. In some diseases, like autoimmune conditions, this is actually not unusual. It's more the rule. And the reason is because of incomplete penetrance, strong dependence on genetic background, environmental or immune trigger dependence, context-specific molecular effects, protective modifiers, and population stratification or ancestry effects. These are all things that are already well established. And it's interesting that HEDS, what we're finding out about HEDS, it actually fits in these boxes pretty well. So a pathogenic variant may be pathogenic without being enriched in broad case controls cohorts. Regardless, this does not mean that the KLKs are the only cause of HEDS. In fact, they're going to be a minor contributor, and it's likely polygenic. And so how can we test this? We do a genome-wide association study. And it's basically taking a group of EDS patients and a group of controls, doing a genotype study using SNP arrays, and seeing if there are certain SNPs that are more prevalent in one population versus the other. So we did that. This is the design. We did a 3-case control study. There are 2 cases, 860 cases in case control 1 from MUSC, 493 from case 2, and then 462 cases from all of us case in the GWAS case 3. These are case 1 and case 2 are self-report HEDS, and case 3 is EHR confirmed physician entered 2017 criteria. Well, they don't say 2017 criteria, but physician entered HEDS diagnoses. We then go through and identify through a very complex set of experiments that takes a long time to do. We identify whether or not there's actual signals. One of the first things that we did was when we got all the genetic architecture back of these 1,800 EDS patients is to do a genetic correlation between other known conditions where we could have summary statistics. And so we could compare, like, how similar are our genetic findings in HEDS with those that have already been done and published and publicly available. And so what you can see is sort of unsurprising, but nice to validate our study, is ME/CFS has a similar genetic architecture, chronic pain, fibromyalgia, IBS, GI issues, migraine, et cetera. So this was really nice that, support that we were on the right direction. And then the Manhattan plots. These actually tell us the specific SNPs that we see enriched in our population. What you'll notice is that if you look at the GWAS, the first rainbow colored thing, there's only 2 things. There's only 2 SNPs. And this is just a reflection of the disease heterogeneity. Had we not done 1,800 patients, we probably wouldn't have found anything. But we did find these 2. And then we did what's called a GBAT, or a gene-based association test. And instead of using individual SNPs, we said, well, let's use all the SNPs that we identified in the entire gene and see if that's enriched compared to controls. And then that led us to an additional 5 genes that are likely involved. And then we did a TWAS. I know these are really complicated terms. And anyways, we found a few more genetic signals that are likely relevant to the disease presentation. So I'm just going to look at ACKR3. That's a weird slide. That's sort of our lead hit. This up here is our locusome. We have a lot of different SNPs in here that builds the support for this being a true signal and not a false positive. EQTL, meaning the variant is actually expressed, and we see it expressed in tibial nerves, and then also by doing ATAC-seq and single-cell ATAC-seq and looking at the status of the chromatin around that SNP, we see it's an open chromatin region, meaning that it can actually be involved in transcription regulation. The SNP actually changes a binding site for an important transcription factor, which was interesting to me. It goes from not being a transcription factor binding site to one in which a transcription factor called aryl hydrocarbon receptor binds. And we validated that this actually happens through reporter assays. What's interesting about this is that AHR, or aryl hydrocarbon receptor, is stimulated by environmental stimuli. So it can be it can be toxins, pollutants, viral infections. Its activity is increased. And maybe patients with HEDS are more susceptible to responding in a different way to these sort of pathogens, like Dr. Maitland was saying earlier. So what is ACKR3? ACKR3 is a receptor, which is nice because it can be targeted. It is involved in opioid clearance. It's a pain receptor in the brain. which to me is very interesting that maybe we've identified some reason for why patients with HEDS have more pain. It actually sequesters and degrades endogenous occurring opioids in your brain, disallowing the opioids to act on endogenous opioid receptors and giving you analgesia. So we see increased receptor and therefore likely increased clearance of opioids. It does a number of other things. So it does pain and is involved in neuroinflammation. It is highly expressed. In fact, probably one of the highest expressed tissues or cell types are mast cells, which is interesting. We're really looking at doing that. It is looking at furthering those studies. It's involved in connective tissues, GI dysfunction, barrier function, as Dr. Maitland was saying earlier, epithelial repair. Like this thing sits at the center of a lot of things that make sense. Blood pressure regulation, anxiety, depression. This is what it does. It regulates these things. In fact, if you just infect a mouse with ACKR3 receptor, the mouse becomes incredibly anxious. So just that alone is really interesting. So we're now developing in vitro and in vivo models to look at this pathway. It's a pretty cool pathway. But what about changes in the blood? And so we did an unbiased mass spec approach. And we, on 29 different individuals with confirmed 2017 clinically diagnosed HEDS and age match, sex match controls. And what was interesting about this, and this was recently published, was that really out of the 45 genes or 45 proteins that were differentially expressed in EDS patients versus HEDS patients versus control, they really fell into two main categories. Kallikreins, which sort of seemed to make a little bit of sense with our genetic work, as well as the complement cascade, which Dr. Maitland talked about earlier. And then we did, this is just a heat map over here on I think all of the patients, showing that there is a loss of complement protein. This is known as complement consumption. It's activation of the complement program. I'm not going to go through what it is and talked about the complement system a bit. We then validated this using specific ELISAs for individual complement proteins. So now we have really essentially a 2 or 3 tier approach validating our studies on complement, and complement sits at the top, or is one of the top regulators of the immune system, upstream of mast cells. So I think that we did not find any changes. We looked at collagen and fibronectin because it's a connective tissue disease. We thought, well, maybe we'll find some things with collagen and fibronectin. We see fragments of collagen and fibronectin, but there is no difference. We detect no difference either by mass spec, which I'm not showing here, or by Western analysis. And we did the Western analysis 3 different ways to confirm that what we were finding was correct. So for an overview of this summary, we established a large clinical and genetic registries with the goal of better defining HEDS. Some of these studies have been published, so you can, if you're interested, read them. We identified multiple families with that single variant that tracked with disease, and then the in vivo data validated the pathogenicity of that mutation. And then we also did in vitro data that I didn't show you here that's in the paper to show sort of some of the molecular mechanism of how it works. Clearly, it's not responsible for all of HEDS and should not be used currently as a molecular diagnostic. I think this is really important. Don't ask your primary care or your geneticist to use KLKs as a screening tool for defining HEDS. It's not meant to do that right now. Biomarker analysis identified the immune system and complement. This really, all the data that we have collected so far, really starting from the patients, for them telling us about their condition, questions whether or not HEDS is a primary connective tissue disease, or is it rather a disease that's rooted in mast cell neuroimmune dysfunction. And if I had to bet, I'd go that way. maybe it's both. Maybe it is. One thing that's but we're betting that mast cells are really important, and everybody, not everybody, but most people think of mast cells as these little sacks of granules that spit out tryptase and histamines when they get angry, and yeah, it's true, right? They degranulate, and that's a problem, and people try to get on mast cell stabilizers. And so we did the experiment where it's a simple experiment. We took fibroblasts and put them in a dish. They stick to the dish. Then we threw mast cells in. See what happens. In 30 minutes or less, Roman was telling me in like 0 minutes, the mast cells are pulled to the fibroblasts. There's a physical contact made between fibroblasts and mast cells, which is absolutely stunning. And you can see that here. So we have ways of labeling these cells. Green cells are fibroblasts. Non-green cells are mast cells. And you can see the mast cell right here is sitting on top of the fibroblasts. This is an active process. The mast cell needs this, the fibroblast needs this mast cell to come close, and it does so rapidly, which tells me it's doing it for a reason. I don't know what the reason is, but I think it's interesting to look at. And you can see here, we've labeled the mast cell red. It actually goes around the fibroblast, and it has these little spikes. I don't know if you can see these on the screen, but these little spikes that attach, sort of anchor into the fibroblast. So we're very interested in looking at mast cell and any other cell type interaction because it hasn't been really looked at. Mast cell fibroblasts, of course, putting them together and then asking how does their interaction change each other when they're not there. What's their transcriptome? So we can do this. We can actually look at every single cell, every single mast cell and every single fibroblast when they're together and say, when they're together, their entire transcriptional program landscape has changed. What has changed about it? And versus, hey, if we just degranulate some mast cells and throw that degranulation stuff on a fibroblast, how does that change the fibroblast? I bet we're going to find that the connection between these two cells is just as important as if they degranulate and release histamines and tryptase and prostaglandins, whatever else. But that's not known. But we're going to figure that out. And we're going to figure that out when we look at mast cells and macrophages, mast cells and neurons. Hey, that's going to be really cool. Mast cells and endothelial cells, looking at blood vessels. These are tissues where the mast cells are there. So what are they doing? This is in the absence of degranulation. This is a 3D image of this projection. I call it a fiber tentacle. I make up words to try to. We've gone back and forth about a lot of different terms, but it does. These fibroblasts shoot out these almost looks like an octopus shooting out this tentacle with a suction cup, bringing it back, and you can actually see this in real time. This right here is a mast cell has already been brought into the fibroblasts, and it's being encased in different types of proteins, and now it's going after this mast cell. This happens in 30 minutes. This is incredibly quick. So the single cell RNA-seq will help. The functional aspect of this is actually the consequence of this. I don't have time to go through this assay, but the functional consequences, it actually changes. This interaction changes how the extracellular matrix looks. That's really important. How can we do more for these patients, though? So that's the sort of the sciencey aspect of what I'm going to tell you. We need to build EDS research communities. We have 5 pillars: lay public presentations. I have people in my group that do this really well. Engaging Congress and NIH, building larger research communities, modified medical school curriculum, and an intern program, which Molly talked about. I'll talk about the bottom 4 of these. First, yeah, patients are, you know this, patients are the true experts and have unique perspectives and research insights. So engaging Congress. This is actually, Lori was a champion of this. And this is really needed. You need those leadership champions that will go to the leadership at your hospital system and lobby for wording to get into programs that then universities level lobbyists can go to the government and pitch. That's the way, that's a great way to make change. And that's how the voice gets listened to. And this was actually from 2025, I guess. Some of this wording that we proposed, this was, I guess, maybe after Lori had left. Yeah. First, yeah, she was the pioneer. She made this happen, and then we've since made this happen every year since. And it's a call to advocate. It's a call for NIH, for Congress to approve funding to research groups around the country to have money to study this condition. And this is, you can read the wording. I'm also happy to send slides to whoever, and you can read this. It's, you know, so important to have this. And since then, I will say that National Institutes of Arthritis and Musculoskeletal Systems Institute has actually made Ehlers-Danlos a research priority. So this matters. And you can do this here. I hope she will, just to make her. And this needs to happen across the country. So we can't solve this problem alone, clearly. We need to build larger research communities. Our goal is to increase research engagement from scientists and physicians. I don't want to be the only group to do this. I need other people. There are 10,000 scientists and physicians studying connective tissues, but nearly none of them work on EDS. This is a problem, right? I mean, come on, 10,000? We can't solve this problem? Engagement, tools, and money. That's the issue. What if we can remove one of those issues? And so we started a bold vision where we wanted to develop an EDS toolbox. And this is for all the other subtypes, the rarer subtypes. We propose to generate CRISPR knock-in models for every subtype of Ehlers-Danlos syndrome and offer them free to the global research community. We would do this for free with the goal of building those communities and institutions across the country and across the world so that those 10,000 physicians and scientists have a tool to study. And we've completed this, which is incredible. This was recently completed. We've now started sending these model systems out across the country. I will say that one of the first ones we sent out was the cardiac valvular EDS, which is exceedingly rare. The person at Case Western received the mice, worked on the mice for a little bit, and then wrote a grant and got it funded for $400,000. Now his lab is switching from a solely, I mean, he does valve work, so that's why he wanted the cardiac valve disease model, to including other types of rare EDS subtypes. $400,000. That would not have happened without this. And we had over 500 inquiries or web checks to be engaged with other scientists from around the world. That's really cool. Can we do more? This is that slide. Obviously, that's a problem. So last year, after a lot of work, we succeeded in changing the medical school curriculum in South Carolina. That's not an easy thing to do because medical schools teach to the boards. Ehlers-Danlos is not on the boards. Marfan syndrome is, but Ehlers-Danlos is not. Medical schools will not change It's really hard to get them to change their curriculum if it's not on the boards. But if you push AAMC and develop strategic partnerships, they're the ones who actually make the board questions. Get them on board, and you change curriculum across the United States. That's where we need work, because that's where you're training your next level of physicians. Start there. Am I going to change the opinion, regardless of what your diagnostic criteria is? Am I going to change the opinion of a 60-year-old physician working in rheumatology that only wants to see scleroderma? No, I'm not. Not going to do it. But if I get these physicians aware early, they're going to see these patients, and they're going to start thinking about it more. So this was the, feeding on that, like, how do we change the perception of this disease? And Molly really spent, a lot of nice time talking about it. This to me is my most important legacy, I will say. That it was really a brilliant idea, maybe my only good idea I've had. It really was a great idea. And it started with a $50,000 donation that we then turned into a whole program that's trained 150 patient scientists. It's incredible. So that's really, that will be my biggest legacy, regardless of whatever we discover. So let me go here, and then I'll finish with some final thoughts. Nothing of significance happens alone. This journey for me with Ehlers-Danlos started 7 years ago when Courtney walked into my office and changed how I view research. And so there's a lot of people here that need to be thanked. A lot of funding societies. What's not on here is the Connective Tissue Coalition, which has been very, very helpful in our work. Of course, the patients and the passionate donors. Without this, none of this could happen. So I just want to leave you with a few final thoughts. It's really an honor to be here. I don't like the publicity. I don't like people knowing who I am. I don't like it. But it's okay. I don't normally script anything, and my lab gets really worried when I go off script. So so if you see me looking down, I'm reading from my notes, because I think it's important to get this right. It tells you a little bit about me. When I was in high school, I was a good student. I studied hard, but I was a really bad student in biology. I almost failed biology in high school. And in some ways, I was a bit lost. It was a big challenge to me. Biology, I just didn't get it. And yet somehow I went on to major in biology in college. And my parents thought I was insane. Like, I was going to be an engineer, and I didn't want to do that because I thought it was a challenge. I didn't want to be bored in my career. I wanted to be challenged. And then I pursued a PhD, which was even more insane, and then stayed in academic science, which academic science is really hard to get into and really hard to stay in. But over the last 31 years that I've been in academic science, this work that I do has really challenged me, shaped me, and humbled me in a lot of ways. One of the greatest privileges of my career began about 7 years ago, obviously sparked by Courtney, who many of you probably know or follow. And she opened the door to a different way of thinking. One that wasn't rooted in just hypotheses or experiments, but in listening. In listening to patients in listening to their stories, and allowing those encounters to shape the questions we ask. That to me is one of the most important lessons of my scientific life. And it's something that most scientists fail to even acknowledge. Almost every scientist I've talked to has never met a patient, yet they work on clinically relevant conditions. Patient stories do more than just inform us, they connect us. They create moments of real human understanding. They remind us of what matters. And if we're paying attention, they teach us how to ask better, more meaningful questions. So while we may be all in a different place in our lives, in our careers, in our health journeys, we share something essential in this room. We share the opportunity to work in a world of ideas where empathy fuels imagination, imagination fuels passion, and passion fuels discovery and hope. Sometimes we make discoveries and sometimes we make a difference for patients. And if we're really fortunate, sometimes we do that at the same time. But success in this work also comes with responsibility to support each other, to lift others up, to create a space rather than to close it off, to build connections rather than fracture them. I don't care who makes the first discovery for something. What I care about is how that discovery can be applied to the patient who's suffering. I care that there are still far too few people studying these conditions. And when too few voices are engaged, the narrative gets controlled by the loudest few. I don't want to be that. That's why I started the whole thing with the mice, to try to get more science out there. This is not how progress happens. That is not how science should serve people, and that is one of the reasons I care deeply about bringing scientists, more physicians, and more thinkers into this field. Now, I went to an all-male, so during high school, it was an all-male Catholic high school. Sorry, I'm telling you this because people always ask me about my backstory. So I went to an all-male Catholic high school where the motto was "Men for Others." And really, that idea has stayed with me my entire life. It has become a kind of compass for how I live, or how I want to live, how I want to lead, and what I hope my legacy will be. I want to keep the door open for the next lost soul who's failing biology in high school, or is seeking a place to belong for a purpose. That belief sits at the root of who I am. I'm incredibly lucky to do the work that still challenges me, still inspires me, and still feels deeply worth doing. I'm not going away, I don't think, unless I have a major health event, and then, yeah. I don't take it for granted, and I'm continually humbled by the trust that this complex, misunderstood, and too often overlooked patient community has placed in me and my group. I want them to know that our commitment in my group, and the groups that I hopefully will form, have never wavered. Our mission is not driven by money, by popularity. Certainly not. I hate being popular, or by controlling a narrative. It is driven by the desire, the true desire, to help, and by the conviction that patients deserve better answers, better science, and better hope. So thank you, Dr. Knight and Dr. McMahon, for inviting me to speak about this work, which is at its heart the patient's work. Everything you saw was from patients. So cool. Your vision to build an institute here at UVA stands as a real beacon of hope, and I'm genuinely excited about that opportunity to learn from you, work alongside you, and help build something meaningful together now and into the future. Thank you.
That was incredible. Thank you. Thank you so much. I just want to say a real heartfelt thank you, because that message just meant so much to me, and I know to everybody in the audience. So I know there's questions. Maggie, yeah, question. Thanks to an effort that began in 1994, that's how long it's been. But last 3 years, and then as we all know, politics and priorities change, will have to influence. And so the effort that you have made now needs to be continued by all of us in the room, all of us in the audience. Continue to contact your legislators, tell them your personal story, why that research, that level of advocacy, which will get that in.
And I'll like the amount of money. So thank you for that. The amount of funding, since most of you probably don't know what a R01 level NIH grant, what that really means. The standard amount is it's normally 4 or 5 years, depending on the institute, and it's at least $250,000 per year. Nowadays, we actually go for 450 or 500,000 a year for 4 or 5 years. It builds programs. So you're looking at, with indirect costs, you're looking at, it could be a $4 million grant. That's huge. And that can change lives. So that's what we need. We need to have NIH agree to do that, $80, $100 million investment so that multiple groups will make that impact. Oh, sorry.
No, that was great. Yeah, one more question. Yes.
Yeah, I mean, there's the same sample.
Do you want to repeat?
Oh, yeah. So the question was about the differences between our findings with the fibronectin and the collagen fragments between our study and the Ritelli study from Columbia's group. Yeah, I don't know. They're the same samples. They're the exact same samples that we received from the EDS Society. We did the exact same approach. We followed the protocol that they had in their paper. So using all the exact same reagents. I don't know. We'll have to see. I hope somebody else, somebody independent of our two groups, goes forward and tries to do an additional validation as well. Because I think it would be amazing if there was a biomarker that is truly unique to EDS or HSD. I have doubts that it doesn't really even make sense to me biologically, but it would be great if that was the case. So I think other groups should try to do it. Okay. Great.
Any last question? One more question we have time for.
My name's Elizabeth, and I'm actually a nurse practitioner and a patient at UNC. And I actually got asked this week by one of the doctors, why would I care as an OBGYN about public download?
Wow.
And my jaw hit the floor. At this point, I was a little too much for some of my colleagues. I took it good back. But conditions that are out there, I had thinking about how we could make them aware of the clinical implication of how TS affects their organs and how somebody who's giving birth and has perineal laceration, care and delivery, has poor healing, and that we need to be looking at why the anesthesia isn't working during labor and all these factors and how we could end up providing prenatal care. So do you see a role for maybe articles or presentations at national conventions or the Women's Health Nurse Practitioner Association? Because I do see a lot of talk about physicians, but as a nurse practitioner, I'm trained in holistic comprehensive care. And do you think that would be helpful?
Do you have an answer? Do you have an answer? All right. Oh, yeah.
I also have an answer.
Right.
No, we've been talking about this for a long time, and I think one of the most important things that's going to happen from here on out is changing the content specifications for every single subspecialty. Every subspecialist should know in their content specifications how to recognize a patient that may have EDS in their subspecialist, in their subspecialty. So for example, if an ophthalmologist sees someone with severe myopia at the age of 5, that should, ding, ding, ding. Let's do a Baton score. Let's look into, ask a few more questions. Listen a lot more. Listen to the patient. Here's some other issues, because they could be very well missing something. So knowing the content specifications and being tested on it. That's what we talked about because they care about the boards. So there has to be test questions in their boards on it.
CE available free.
That's kind of, okay.
All right.
Thank you so much.
Thank you.
Okay. EDS was a wonderful episode.
Oh yeah, already signed up.
Okay, so just to fix that out, it's really important. And there are other free CEs that are available. Just making sure. Generally speaking, all of us, you call, you ask us to write us to speak. Thank you so much. Thank you so much, Chip. Okay. Well, next, our next speaker, I don't think needs almost any introduction, but I'm going to anyway. So I want to welcome Dr. Claire Francomano. And yeah. Dr. Francomano is professor of medical and molecular genetics at Indiana University. She's a leading authority in the United States on the Ehlers-Danlos syndrome. I think there's no question about that. And her career has been including leadership at the level of the NIH with landmark 20-year study in the natural history of EDS. Dr. Francomano is globally recognized as an expert in connective tissue disorders. She has published extensively. If you don't see her name, go find another article because you're not reading a good one. And she continues to shape research and clinical care in this field. So let's welcome Dr.
Thank you so much. And thanks to Dr. Knight and the organizers here for welcoming me to here today. Thanks to all of you for being here. Well, that was a kind of hard act to follow. I'm going to talk about the genetically defined types of EDS today. There are 13 types of Ehlers-Danlos syndrome, and even though probably 90% of the patients who come through the door have what we currently call hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, those other 12 types are very, very important because part of the diagnostic criteria in thinking about hypermobile Ehlers-Danlos syndrome is that we have excluded all the other types of Ehlers-Danlos syndrome and the other hereditary disorders of connective tissue that present with hypermobility. So I'm going to see if this will work for me. There we go. These are my disclosures, but none of them are relevant to what I'm talking about today. So my objectives for the next half hour is to talk about the understanding the major genetically defined subtypes and primary gene defects, recognize the hallmarks and clinical imaging features for the differential diagnosis, and appreciate the inheritance patterns and implications for genetic testing and counseling. So in connection with the Ehlers-Danlos Society and my colleagues who are involved in the work of taking care of people with hereditary connective tissue disorders, we've undergone a very large literature review looking at what is Ehlers-Danlos syndrome. And you've heard all this already today. It's a heterogeneous group of hereditary connective tissue disorders characterized with the joint hypermobility, skin hyperextensibility, and tissue fragility as the major hallmarks. And the mechanisms underlying these conditions are in collagen synthesis, processing, and structure, and other molecules that are involved in extracellular matrix integrity. And the classification that we're using today was published in 2017 in the American Journal of Medical Genetics, and it grew out of a symposium that was held in New York in 2016. It was the first meeting of the International Consortium on the Ehlers-Danlos syndromes and hypermobility spectrum disorders. And all of the articles that were published in this 2017 publication in the American Journal are available on the Ehlers-Danlos Society website. And they have been used extensively over the last 9 years. They've been some of the most highly cited articles from the American Journal of Medical Genetics. So these are the genetically defined types of Ehlers-Danlos syndrome, the 12 genetically defined types. And I'm going to talk about each one of them in turn. I love this representation of them, which was done by Joanna Amberger and her colleagues at Johns Hopkins in 2018, just with the petals of each flower representing the different types of Ehlers-Danlos syndrome. And in 2018, I really wasn't thinking that we'd be sitting here in 2026 with that unknown word in the petal for hypermobile Ehlers-Danlos syndrome, but here we still are. So I think it's just so exciting what the science is leading us to, and I think you've already heard this morning some very, very compelling evidence that we're starting to understand better the biology that underlies this really complex condition. But these other ones, we've got a really good idea. And we have genetic tests, and we want to make sure that the patients who walk through the door with those rarer types are recognized when they present. So the classic type of Ehlers-Danlos syndrome is probably the most common of the genetically defined types. It's caused by pathogenic variants in the 2 genes that encode type 5 collagen. It's inherited as an autosomal dominant disorder. The major criteria are extreme skin hyperextensibility and atrophic scarring and generalized joint hypermobility. There's a long list of minor criteria. Now, in the interest of time today, I am not going to read all the minor criteria for each of these 12 types of EDS, but they're there. The slides will be available to you. And so you will have them if you wish. To make a clinical diagnosis, we need to have major criterion 1, which is the extreme skin hyperextensibility and atrophic scarring, and major criteria 2, or the skin involvement with extensibility and atrophic scarring, and 3 or more of the minor criteria. The recommendation is for any of these genetically defined types, if there is a strong clinical suspicion, to go ahead and do the genetic testing to try to confirm the diagnosis with molecular testing. Now, the classic-like type of Ehlers-Danlos syndrome presents very, very similarly to the classic type of EDS, which is why it's called classic-like. There is skin hyperextensibility, very major skin hyperextensibility, similar to what we see in the classic type with velvety skin texture. But the difference is these people do not present with atrophic scarring. So that is a way to make a distinction between them. Okay. They have generalized skin hyperextensibility, hypermobility, and very, very easy bruisability and spontaneous bruising. So all 3 major criteria should be present to make a clinical diagnosis. And the big difference with this one is we want a family history compatible with autosomal recessive inheritance, because the classic-like type of EDS is caused by pathogenic variants in the gene called TNXB, and it is inherited as an autosomal recessive. Now, the vascular type of Ehlers-Danlos syndrome is probably next up in terms of the prevalence, just behind the classic type. And this one is probably in the range of between 1 and 3,000 and 1 and 5,000. The classic type more in the 1 and 3,000 range based on published literature right now. Vascular EDS is caused by pathogenic variants in COL3A1 and is inherited as an autosomal dominant. The major criteria are a family history of vascular EDS with a documented causative variant in COL3A1, arterial rupture at a young age, spontaneous rupture of the sigmoid colon in the absence of known diverticular disease or other bowel pathology, uterine rupture, and carotid cavernous sinus fistulas. These are the minor criteria. Now, in 2017, when these papers were published, the people who wrote about vascular Ehlers-Danlos syndrome were outliers. They declined to say that we could make a clinical diagnosis with this number of major criteria and this one minor criteria. And they just said we should consider genetic testing in the presence of any of the major criteria, or if a person has several minor criteria, especially if they're less than 40 years old. So in other words, if you're thinking about, I wonder if this patient might have vascular EDS, you need to do the testing. Now, the kyphoscoliotic form of Ehlers-Danlos syndrome starts to get us into these ultra rare forms of Ehlers-Danlos syndrome. The major criteria for this one are congenital muscle hypotonia and congenital or early onset kyphoscoliosis. So this is a curvature of the spine that's both forward and back and side to side. And then in addition, there's generalized joint hypermobility with dislocations and subluxations, particularly involving the shoulders, hips, and knees. Kyphoscoliotic EDS is caused by pathogenic variants in the PLOD1 gene and the FKBP14. The PLOD1 was the first one to be recognized. That's a gene that encodes the enzyme lysyl hydroxylase. And the lysyl hydroxylase plays a really important role in collagen metabolism. So to make a clinical diagnosis for kyphoscoliotic Ehlers-Danlos syndrome, you need either all three major criteria or the first major criteria, which is the congenital muscle hypotonia, plus, and the second one, the congenital kyphoscoliosis, and 3 or more minor criteria. But here again, we want to do testing if we suspect it. The arthrochalasia type is caused by genes encoding type 1 collagen. So these are called 1A1 and called 1A2, inherited as an autosomal dominant. And here the major criteria are congenital bilateral hip dislocations. They have severe generalized joint hypermobility and instability with multiple dislocations and subluxations and skin that is unusually stretchy. And for this one, the major criteria 1 and 3 are necessary to make a clinical diagnosis, or major criteria 1 and 2, and at least 2 minor criteria. Now, I should say that these are all clinical diagnostic criteria that are based on kind of consensus of experts. There is very little in the way of scientific support behind these clinical criteria. And so it's really, I think it's just very, very important, the work that's being done now with the mouse models and the work that this Road to 2026 committee of the Ehlers-Danlos Society is doing to try to bring more of the science into supporting some of these diagnostic criteria. But these are what we have right now. So the dermatosparaxis type, We have a long list of major criteria here. The major thing about the dermatosparaxis type is the skin fragility. And this really is very striking. If a patient comes in to see you and they have extreme skin fragility with congenital or postnatal skin tears, that is really, it's important to think about the dermatosparaxis type. There are characteristic craniofacial features, and the skin is redundant. It almost looks like cutis laxa. It has excessive skin folds at the wrists and the ankles. And when you look at the palms, there's excessive wrinkling on the palms. They also have severe bruisability, and sometimes there'll be hematomas that develop under the skin with minimal trauma. You may see umbilical hernias. There's postnatal growth retardation. So in general, these folks will be shorter than average, and they have short limbs and hands and feet. And there are quite a few perinatal complications due to connective tissue fragility. So for this one, the clinical diagnostic criteria include the major criteria 1 and 2, and at least one other major criterion, or 1 and 2 of the major criteria, and at least 3 minor criteria. The spondylodysplastic type, there are 3 genes. This is like alphabet soup to me. It's just, I find them very difficult to remember. B4 GAL-T7, B3 GAL-T6, and the SLC 39A13. Okay. These are all genes that are involved in the production of proteoglycans, which, like the collagens, are important structural proteins in the connective tissue. And all 3 genes require 2 copies, so it's an autosomal recessive condition, regardless of which of the 3 genes is causing it. The major criteria are the progressive short stature in childhood, hypotonia, which may be congenital or it may be relatively mild and of later onset, and then there is some bowing of the limbs. So for a clinical diagnosis to be made, we want major criterion 1 and 2, and the characteristic radiographic abnormalities, and at least 2 other minor criteria. Now, with the spondylodysplastic type, there are some gene-specific minor criteria. So the general minor criteria are listed on this slide, and then the next slide shows you the gene-specific minor criteria. And the important ones to remember are that the B4 GAL-T7 has some ocular involvement. The B3 GAL-T6 may present with ascending aortic aneurysm. So this gets you into the, like when you're thinking about the aortopathies, and they have club foot as well in B3 GAL-T6. And then in the SLC 39A13, there's a kind of a characteristic of facial appearance with prominent eyes, blue sclerae, and those finely wrinkled palms of the hands. So we're starting to understand that these are kind of distinct phenotypes based on the underlying gene for the spondylodysplastic type of EDS. The musculocontractural type may be caused by 2 different genes, CHST14 and DSE. And here again, this is an autosomal recessive condition. The major criteria are the multiple congenital contractures. And characteristically, they're contractures of adduction and flexion, and the presence of club foot. So there are characteristic craniofacial features which are evident at birth or in early infancy, and then the skin involvement, with stretchy skin, easy bruising, skin fragility with atrophic scars. And here again, we may see the increased palmar wrinkling. So at birth or early childhood, we want to look for major criteria 1 and 2. If we're thinking about this diagnosis in adolescents or adults, we look for 1 and 3, the cutaneous features and the multiple contractures. The myopathic type is caused by pathogenic variants in COL12A1. And this is the only one of the 13 types of Ehlers-Danlos syndrome that can be inherited as either autosomal dominant or autosomal recessive. And here the presentation in infancy is congenital muscle hypotonia and or muscle atrophy that it tends to improve actually with age. So it's worse when the babies are born. They have proximal joint contractures involving the knees, hips, and elbows, and hypermobility of the distal joints in the hands. Thank you so much. So to make a clinical diagnosis of the myopathic type of Ehlers-Danlos syndrome, you want to see major criterion 1 and at least 1 other major criterion, or major criterion 1 and at least 3 of the minor criteria. Now, you heard a little bit about the periodontal type of Ehlers-Danlos syndrome from Dr. Maitland earlier. The genes that encode this condition are C1s and C1r, which are elements of the complement pathway. The periodontal type is inherited as an autosomal dominant condition. And the severe and intractable periodontitis of early onset is the hallmark of this condition. When you look at the gingiva, they're not attached to the teeth well. And often patients will say they lost all their teeth before they were 30. So whenever I hear that story, immediately we're going to gene testing, you know. There's some skin findings that are typical of the periodontal type, these pretibial plaques that you can see on the upper right-hand side of the slide. And then the other major criterion is the family history of a first-degree relative who meets the clinical diagnostic criteria for periodontal EDS. So to make a clinical diagnosis here, we want to see the major criterion 1 and 2 other major criteria and 1 minor criterion, or major criterion 2 and 2 other major criteria and 1 minor criterion. All right. Now, the brittle cornea syndrome is the only one of these types of Ehlers-Danlos syndrome that isn't called Ehlers-Danlos syndrome. It is the major presentation is really in the ocular globe. The cornea is very thin and it may or may not rupture. So sometimes the cornea actually fracture. It can lead to blindness. So you may have early onset of progressive either keratoconus or keratoglobus. When I was preparing this talk, I had to look up what is the difference between keratoconus and keratoglobus. In keratoconus, the cornea kind of comes out and it makes a cone in the front of the eyeball. Because of the thin nature of that cornea. And in keratoglobus, the whole cornea is kind of enlarged. It's a more global involvement of the cornea than it is with keratoconus. And then we also see blue sclerae in this type of brittle cornea syndrome. You can see on the minor criteria, a lot of these continue in the the ocular phenotype, but there are skeletal aspects to the phenotype as well. So there may be developmental dysplasia of the hip, hypotonia, scoliosis, long thin fingers or arachnodactyly, and hypermobility of the distal joints. So the skeletal system is involved, but really the focus is on the eyes in this condition. For the cardiac valvular type, the gene is called 1A2. Inheritance is autosomal recessive. These people with this condition have a very severe progressive involvement of the cardiac valves. They may be usually the aortic valve or the mitral valve. And the skin involvement is skin hyperextensibility with atrophic scarring, thin skin, and easy bruising. They have joint hypermobility, which may be generalized, or it may just be restricted to the small joints. And to make a clinical diagnosis, we either want major criterion 1, which is the progressive cardiac valvular syndromes, and a family history compatible with autosomal recessive inheritance, and at least one other major criterion, or major criterion 1 and a family history compatible with autosomal recessive inheritance, and at least 2 minor criteria. So that's a quick rundown through all those types of Ehlers-Danlos syndrome. Dr. Alan Hakim has come up with what I think is a truly brilliant mnemonic to remember the things that we have to think about when we're thinking about, are we going to test? And he used the word focused. So I'm going to just run through these very quickly. Family history, organs or internal problems, cardiovascular issues, unexplained sudden death, skeletal abnormalities, skin abnormalities, eye abnormalities, and dental. So for the family history, if there is a family history of a pathogenic genetic variant and confirmed diagnosis of another type of Ehlers-Danlos syndrome or another hereditary disorder of connective tissue, we want to be thinking along those lines in the differential diagnosis of our patient. If there's a personal or family history of recurrent pneumothorax, that might be pointing us to the vascular type of Ehlers-Danlos syndrome or to Marfan syndrome. So, and if there are unexplained tears or ruptures of the heart, such as bowel or uterus, we should be thinking about the vascular type of EDS. The cardiovascular issues, dilated aorta, large arteries, arterial dissections or unexplained severe bleeding. The carotid cavernous fistula is common in the vascular type, any kind of thoracic aortic pathology. These all should be pointing us to genetic testing. If there's a family history of unexplained sudden death at age less than 50 years, we have to think it could have been caused by a vascular problem or organ rupture. So that points us towards testing. The skeletal abnormalities that should raise red flags in your mind: clubfoot, congenital hip dysplasia, joint contractures, the severe kyphoscoliosis, severe pectus carinatum or excavatum, unexplained low trauma fractures, short stature, or mallet finger. Any of these would be more suspicious for a type of Ehlers-Danlos syndrome other than the hypermobile type or hypermobility spectrum disorders. The skin findings that would point us in that direction are extreme hyperextensibility, extreme scarring of the shins with hemosiderotic scars, which is what we typically see in the classic type of EDS, bilateral varicose veins of early onset. A prematurely aged appearance is something that we see sometimes in the vascular type of EDS, and recurrent hernias of the abdominal wall or the groin. The eye abnormalities include lens subluxation or dislocation. That should make us think about Marfan syndrome. Retinal detachments, we think about Stickler syndrome. Vitreal changes and corneal scarring. All of those should point to some other hereditary disorder of connective tissue or other type of EDS than hypermobile. And then the dental abnormalities are the severe periodontal disease and loss of teeth at less than 40 years, and dentinogenesis imperfecta or malformation of the dental enamel. So the presence of any of those focused red flags on the personal or family history should really make us think about doing genetic testing to look for one of the genetically defined types or other hereditary disorders of connective tissue. Thanks very much for your attention.
That was wonderful. All right. Any questions for Dr. Francomano? Yes.
Criteria that don't have the science, like you said that.
Well, I think if you can make the argument that, oh, the question is, how can we convince the insurance companies to pay for the genetic testing if we're going on clinical diagnoses? You can make the argument that there is the presence of, in the personal or family history or on the physical exam, there is a finding or there are findings that are suggestive of a condition that can be diagnosed molecularly. So there you have a reasonable suspicion that there may be a molecularly diagnosed condition in front of you. And we usually don't have a problem getting insurance to pay for the hereditary disorders of connective tissue panel, which is we can do with either Invitae or GeneDx.
Abby.
Yeah, as someone of rare type, there's two kind of questions, I guess, that come forward among the rare type community that we often chat about. One being self-diagnosis of a rare type based on a variant of uncertain significance, and then the other being not having a positive pathogenic variant in your genetic test, but still receiving a clinical diagnosis of one of the monogenic types of EDS. Are those things that you could speak on?
So the question is first about variants of uncertain significance, and the second is, can we make a diagnosis, a clinical diagnosis, in the absence of a pathogenic variant? And so the variants of uncertain significance they're really a big challenge for us as geneticists, because when we get a variant of uncertain significance, it basically says to us that we just don't have enough information about that variant to say whether it could be causing the presentation of the patient in front of us or not. And there are some things that we can do to try to clarify that. Sometimes we can do family studies. If there are multiple people in the family with the same clinical presentation, we can see if that variant travels in the family and is it co-inherited with the phenotype. So if say the person has this hereditary connective tissue disorder, they've clearly inherited it from their mother, and they've inherited that variant of uncertain significance from their father, then it's probably not going to be the causative gene for them. As you heard from Dr. Russell, we don't know a lot still about the genome and about the genes that cause these conditions and about the variants that cause these conditions. So it's very possible that a person can present and meet the clinical criteria for one of these rarer types, but that we will not find a pathogenic variant in the gene for that condition. And that may be because the variant is in a regulatory region of the gene, or it's in deep inside one of the introns, or it's in a place that affects the splicing of the RNA after the RNA is transcribed from the gene. So we just have to be humble about this because there's really so much we still don't know. So if a person, if, you know, they talk about it looks like a duck, walks like a duck, quacks like a duck, it's probably a duck, right? And same thing for the rare types. If they meet a lot of the criteria and they meet those diagnostic criteria for a rare type, I certainly will make that diagnosis, even if the gene testing comes back negative.
Thank you. All right, we don't have any more time for questions. It's time for a break. So we're going to take a 15-minute break and come back in at 2:30. Okay, thank you.
Goes to my church every year. He's like, I remember.
Okay.
Okay, we want to get started. Thank you. We have an amazing afternoon coming. It gets better. Sit on down. Okay. All right, we're going to get started. I am especially honored to welcome our next guest. And I'm sure most of you have all heard or have seen or have thought of our very special next guest, and it's Dr. Laura Bloom. Dr. Laura Bloom is the president and CEO of the Ehlers-Danlos Society and flew all the way here from across the Atlantic just to be here for this event. So, and the plane was delayed and got here late, but still here very smiling. So I'm very happy about that. Dr. Bloom is a globally recognized leader in rare disease advocacy and has been instrumental in advancing awareness, research, and care for the Ehlers-Danlos syndromes and related conditions. She's played a central role in the international efforts to reclassify EDS and to develop global care guidelines, and works extensively with organizations and governments around the world to improve outcomes for patients with these disorders. She brings a uniquely powerful perspective that bridges patients, clinicians, and research, and we are truly honored to have her here with us today. So please welcome Dr. Bloom.
Hello, everyone. It's wonderful to be here. Thank you so much for putting this on. I think it's a testament to see how many people have signed up for this online as well as being in the room, and the speakers that you've got here as well, testament to all the work that's been going on here. So I'm going to talk to you as quickly as I can, because I think I've got 15 minutes, to talk about the Road to 2026, a path towards progress. I have no conflicts to declare. So I'm going to get straight into it. What do we mean by the Road to 2026 and who is involved? So you can see here a list of the members that are in the steering committee of the Road to 2026. The reason these people were compiled was because they are largely the chairs of the working groups that are related to the different types of Ehlers-Danlos syndromes and hypermobility spectrum disorders within the International Consortium of EDS, which is an independent group of scientists, researchers, clinicians, basically every expert that there is geographically and in terms of discipline around the world. And there's almost 200 people now that are part of that consortium group. We also have some people on there with lived experience, and we also have a few members of staff with lived experience that are bringing across the voice of the community to this effort. To give you a little bit of history as to how we got to this point. So it's actually our 10-year anniversary this year, which is just crazy. Don't know where that time has gone. I left EDS UK in 2015, knowing that really we needed to look at things through a global lens to heal things more systemically, because doing things at a national level was really what I call putting a plaster on things. You guys say a Band-Aid, but we really needed to look deeper to try and heal the years, decades of neglect that had come before. And we spent about a year looking at what at the time was going to be called EDS International and what that could look like. And the biggest thing we wanted to do was break down fragmentation. People working in silos, people trying to compete in a space where really all that was needed was support. And there were lots of different efforts going along around the world, but no one was really working together and collaboratively. So the vision for what was then EDS International was to bring everybody together and say, we're all trying to do the same thing here. Let's do it together. It will be much more powerful. And to facilitate that, the International Consortium was set up and established. And that's the kind of history of how we got here. At the time, There was also EDNF, which many people remember, which was the Ehlers-Danlos National Foundation, which was the US organization for these conditions. And we realized that we'd be going after the same doctors, the same donors, the same community. And so EDNF was officially closed down in 2016 and relaunched came the society officially with a new global vision, some of the same volunteers and advocates from previously as well, but really looking at how we could take this on globally. And we said that we would absolutely ensure that there would not be 2 decades before another diagnostic criteria was looked at. All of the doctors from around the world were saying that is what needed to be done. And so that was the first task of the international consortium. And this is where it's really important to understand this difference. The Ehlers-Danlos Society said that we will take on the task of ensuring that there is the funding and the administrative support to allow the experts to do this work. It has never been and will never be the work of the Ehlers-Danlos Society to decide the scientific outcomes. There is a lot of noise that you may see online that claims the society, even me at times, depending on what channel you're reading, decided what the 2017 criteria was. That's absolutely not true. So please do not believe anything you read that claims that. That 2017 criteria was decided on by members of that international consortium. At the time, that was about 87 people that came together for that effort. What we did was make sure they had the funding to meet in person so that, again, we wouldn't have that neglect and that delay, and that the work that was needed to then put those publications out towards the community was done. Now, this is the part where I hold my hands up, because at the time in 2016, when we launched, it was me and one other person part-time. We were tiny. We had almost next to no funding. And we thought, we've just done and helped create what everyone was saying was needed. And that was, here we go. That's it. And we'll now work out what we need to do next. What we didn't realize is how much work needs to be done post the criteria, because that's just one publication. But the impact on people's lives, how that works in everyday life, what that means for access and care. We didn't really appreciate just how much involvement as the international organization we needed to have. But let me tell you, that work takes millions of dollars and a huge capacity. I'm delighted and very proud that 10 years later, we have kept our promise to ensure that that criteria is looked at every decade. And here we are, almost a decade later, with a new criteria coming out. We've raised close to $45 million in funding in the past 6 years. And a lot of that funding as well has gone into the support and the infrastructure that is going in to making sure that this new criteria doesn't end when that publication happens. That is when the work begins. So I'm now going to talk to you a little bit more about the what, the aim, and the how. So as I've said, it's a path and process towards an update of the 2017 classification on EDS. It's aimed to advance the understanding and management of these conditions on a global scale to reduce the time to diagnosis and improving care. And as we've heard, that time to diagnosis can be 20 to 23 years, as what the Norris Lab survey said, and also the recent survey that we have done as well. It's going to involve a thorough examination of what's currently known about these conditions and an assessment of what is needed to improve global access to diagnosis and care. So it's going to be an updated classification, updated diagnostic criteria, a new diagnostic pathway that will also be available in the app, and tools and resources to support this work, and an update on all of the above things. So that's what's going to be published on December the 1st this year in the American Journal of Medical Genetics. There will also be a publication in March in the American Journal of Medical Genetics, which is much more about the care guidelines and the management around HEDS and HSD. So the first part is really much more classification, and the second part is thinking about the care side of things. But what else has been happening in parallel to assist the outcomes and decision making? So firstly, there was the HEDS and HSD criteria study. And that outcome is to determine if HEDS and HSD are in fact the same. This was completed in the middle of last year, and we announced in Toronto at the Scientific Symposium that the data is showing that they are indeed one in the same spectrum. Then there was the HEDGE study, which is really the first work that was looking at potential markers for HEDS and potentially HSD. And that work is now coming to an end, and there's going to be quite a few publications that are coming out from this year and next year. There is also a phase 2 of HEDGE looking at some of the findings that came out of phase 1, which I can't go into too much detail about, but we will be announcing post-publication. There's been multiple proteomic studies, some of which we've heard about, and I'm going to touch on some of them soon, and epigenetic studies as well. None of this happened in 2017, none of it. So in 2017, what really came out is the best that could have been done at that time. It was actually more of a research criteria. And for whatever it's worth, whether you love it or you hate it, it did pave the way for progression. Because that 2017 criteria allowed a scientifically rigorous enough criteria to be able to do the HEDGE study. The HEDGE study was really the first push of that domino effect of really trying to find out what the cause is. Pretty much any study that's been done since have used the HEDGE samples. So it really did pave the way. And without it, I don't think we would be where we are now. But everyone admitted at the time it was the best that could be done at the time. And it wasn't good enough. So again, we agree. As someone living with this condition, I agree. I feel it. But that was what was done. That was the best that could be done. And there has been 3 years of work to make sure that what comes out is being much more rigorous and thought out, and lots of surrounding publications to support what comes out. And there's some big questions. Are HEDS and HSD the same? Well, I think we've answered that. Yes. Should HEDS be renamed? Does HEDS stay part of the EDS group? Once determined if HEDS stays in the EDS group, what are the monogenic types called? What happens if between even now and December the 1st, markers are published related to HEDS and HSD? How do these outcomes work practically in different geographical areas, and how do we tackle those as an organization once this work is published? We know, for example, right now, if you live in parts of Europe, you're not getting any care if you've got a diagnosis of HSD. But we also know that there's doctors that absolutely refuse to give a diagnosis of HEDS. There are problems with both in every country across the world, and they're all different, which makes our job super fun. Should the comorbidities now be included in the hypermobility criteria? What types stay out of the monogenic types? Do any go? What materials and resources are needed to support the patients to accept and understand the changes? That's a big one. That's something we definitely learned from 2017. Educational and dissemination plans for healthcare professionals and professional bodies to understand how to use that new criteria and pathways so people aren't waiting 20-something years for that diagnosis. The Baton score. Who loves the Baton score? Is it sufficient? If not, why not? And many other smaller questions along the way. As I said, this is 3 years of work. This is hundreds of experts that have come together. This is scientific rigor. And that is what is going to make this stand the test of time, I believe, in the way that the 2017 criteria did not. This isn't just about HEDS and HSD, though. We're also looking at the rare types, monogenic types, whichever way you want to call them. But there are all of these other types of Ehlers-Danlos syndrome. And we've triangulated 3 areas of research and audit: a review of the literature. What is EDS? When we say that, what do we mean? We refer to Dr. Ehlers, Dr. Danlos, all these, years and years of papers that have been published. But do we still mean today in 2026 what was meant then when we say what is EDS? And then cases and cohorts in the rarer types groups in clinical practice. This is the current 2017 criteria. And there was that 14th type that was published in 2018. So depending on who you ask, where you look, there's 13, 14 types of the monogenic types of EDS. And there's this hypermobile type, which we still know, we do not know the causation behind. And this was what was published. And as Claire alluded to, it was one of the most cited and downloaded papers that have ever come out in this condition. So despite some people not liking it, many people not liking it, it raised awareness and it progressed diagnosis more than ever before. So we did get somewhere that 1997 criteria didn't get us. Then we think of heads and HSD, and there's these 5 areas of research. There's been a thorough review of the literature, and there's been a lot published recently, which is wonderful. Again, a Delphi study looking at what is EDS. DICE and CORE. So DICE is our global registry. CORE is our clinical practice network of researchers and people caring for people living with this condition. There's been the criteria review study, and HEDGE and many other biowork studies that have been done looking at genetics, epigenetics, proteomics, and metabolomics that have really all come together to form what will be coming out in December. And there's been this Delphi study, and you can see we've had a really healthy amount of people taking part in that. In the monogenic types, remembering how rare these are, we had 107 people that took part in that, healthcare professionals, and some patient experts as well in that, and academics as well. And heads and the comorbidities, we had 415, and HSD and the comorbidities, 363. There are going to be further rounds of the Delphi study, and that's just to show you how live this is. That is happening as we speak. So as much as people think we're sitting on the answers, they have not yet reached consensus, and we still do not know what the final outcome is going to be. We can hypothesize on what that will look like, but until December the 1st comes round, we're going to know a few months beforehand, obviously, because we are helping with this work and the dissemination of it, but really it's not known at this time what the final outcome will be. And the most important thing to me as a professor in patient engagement, incorporating lived experience was so important to me, because without that, what's the point? It's all very well and good thinking about the science, but what about the everyday life of living with these conditions? What about the people that are trying to access care? If these terms and these names of these conditions are not working for people, what do we do about that? If people are worried about insurance coverage, long-term care, what does it all mean? I can absolutely assure you, as someone that's traveled around the world, listening to people living with these conditions and many other rare and chronic conditions, our healthcare systems are set up for the acute and not the chronic, and they are failing us at every single turn. And the whole world is now on a war footing, and health, and especially rare and chronic, is being pushed even further back than where it became before the pandemic. We are in a really terrible state, and it's a really scary time to live with one of these conditions. And I wish I could give people more hope, but that is the stark reality. So it was very important to us that we thought about that in real time in 2026. What does this mean? And how will people be impacted? So we did an initial feedback survey. Your voice matters. What are people thinking? What are people scared of? What are people experiencing on the ground? And then we did a formal study that's going to be published with these additions in December. And 25% of the consortium have lived experience, and 20% of the steering committee also have lived experience. But there's more and more challenges and barriers than that. And that was alluded to when Chip was speaking as well, that we're talking about a complete lack of federal funding, issues with ICD-10 and 11 codes, issues with Medicaid coding and insurance, issues with pathways and models of care and accessing care and diagnosis. People are worried what's going to happen to the current diagnosis they have. Lack of funding for the monogenic types. We've raised 45 million in 5 years. A tiny, tiny fraction of that was for the monogenic types. And 100% of it was raised by parents of kids with these conditions. No grants, no foundations, no government funding whatsoever. So we need to also understand the current barriers and challenges with HCP education and uptake. And we also need to think about what they're being taught, because it's out of date and it's not appropriate. And people have felt like, well, why haven't the society done more about this? We haven't done more until this point because we knew change was coming. We didn't want to get federal funding for conditions that are going to be renamed. We didn't want to change textbooks with conditions that are going to potentially be renamed. We didn't want to get in front of people that we've been desperately trying to get in front of for decades to say next year it's all different. But I can assure you, behind the scenes, we have been working incredibly hard on every single one of these challenges and these barriers. Going to give you all a sneak peek now, but we're not formally announcing it until May, that for the first time, we're going to be doing a formal event on the Hill, on Capitol Hill next May, We're going to be inviting advocates from all the states in the US to come down to a 2 to 3 day event in DC, helping all the advocates to really ensure that the messages of those living with this is taken through to the right people. We're working with an external organization to help with that. And that's the kind of thing that needs to happen, as has been mentioned before. There's been efforts to do that, but it hasn't actually led to what is really systemically needed to change. Serious money, serious funding. And we intentionally waited until the new criteria will be out so that we actually are going to them with the right wording and the right messaging. So look out for that in May. So sign up to that, be part of that effort. It's really, really exciting. We also are going to be announcing in the next few months some strategic partnerships to help with all of this work. We know that this is a global change event. It's going to affect research, clinical care, policy, and the patient community. And we need to make sure it has real world impact. So we've partnered with some specialized organizations. And one of them we actually announced a couple of weeks ago with Harvard Medical School. And that is to look at models of care. And I think it was interesting, some of the comments that we got online with frustrations that they may have had accessing care at these places. It's exactly why we need to develop this model of care. And how wonderful that they are willing to be part of that effort. This is going to be huge. This really does get us out there to places that have not been listening before. And it's going to first look at the US, UK, and Canada, and then hope to be replicated in other countries as well. It's an initial 2-year body of work, and we're going to be announcing over the next few weeks more and more of what this actually looks like, and how it's going to impact people in real time. So keep tuned for that. We're also going to be adding to our ECHO program. We're also launching next year something called MOOCs, which is massive open online courses, which is accredited online courses for people in these conditions. Again, with all that new criteria, so it will be the most up-to-date, accurate information. We're also going to be working with our core network to encourage fellowships, internships, mentorships across the country, across the world. We now have one of our core networks in Kuwait, which is just unbelievable how the geographical diversity is really growing and that reach is changing. We're going to be working with people to ensure that there aren't barriers in getting insurance coverage or coding issues. And we're going to be looking at finally, systemically, country by country, changing the literature out there that is taught to medical students, because right now it's a paragraph and it contains the wrong information. I'm going to skip through these because I know I've seen in my peripheral a red thing that's been raised a few times. I've talked about the criteria study and what's come out of that, but this is now looking at this model. I think that there has been acknowledged an absence of the comorbidities in the current criteria, but this is looking at what has been coming up in this study and this work: joint hypermobility, dislocation, skin pathology, other tissue fragility, family history, craniofacial features, and selected comorbidities, in the absence of another cause for presentation. But this is now being modeled and tested, so it will be scientifically rigorous when it is published, and that is really exciting, and that is the first time ever that that has happened for a diagnostic criteria for these conditions. Not every sign or symptom can or should be in a diagnostic criteria, but every concern should be addressed at different stages of an individual's clinical assessment, and that is essential for people to remember. Biomarker studies, so we've talked about HEDGE. There were 1,000 people with HEDS, 45 with HSD. At the moment, the HEDGE data is not finding a connection between HEDS and the KLK15 or MTHFR genes. There were certain rare Tenexin B variants found in 3 to 5 times more people in HEDS, but only in 1% of the participants. So we're now studying the rarer genetic variants and exploring how specific genetic patterns relate to the symptoms. So like I said, phase 2 of HEDGE is going to be announced soon. But for now, diagnosis remains clinical. There's still no diagnostic tests for HEDS and HSD. Then there is a selection here of lots of exciting studies that have been done looking at the proteomics and other markers. Someone asked earlier about the protein fragmentation in plasma, the Ratelli publication. There has been an effort to replicate that in various labs, and unfortunately at this time we have not been able to replicate that work. The efforts into that will be published soon. It was very exciting, but again, it didn't yield any outcomes that have changed this from being still a clinical diagnosis. There's also very, very exciting work coming that we have funded in all of the immune areas. We've funded work in the viral determinants of disease, severity and hypermobility syndromes, leveraging genomics tools to unravel the autoimmune nexus, biomarkers and drug targets for heads, and biomarker identification. So all of this is funded, not yet published. We are doing a lot of work to try and explore more and more as to what the immune component is of these conditions, because this, I think, is the most exciting discovery that there has been. So if we take a really wide-angled view of what we know now from research, recent research and clinical opinion, is that the HEADS and HSD is one in the same, a multisystemic disorder. They share many similar complications beyond those described in the current 2017 criteria, and there are likely similar pathophysiological mechanisms for disease. So there's been a ton of work that was never done before that has been able to be done in parallel to make what's coming out in December really something that people should be hopeful for, that it will be a way forward. Change is always a scary time. As someone that also lives with this, I also am thinking what that will mean for me in terms of care. All I can assure you is that so much work and thought and care has gone into ensuring that anyone impacted by this is given the support that they need once these changes come out. I would like to please remind people how the scientific process of these things happen. The society did not decide what is coming out in December the 1st. I will keep saying it because there is so much misinformation out there, and I did not decide what is coming out on December the 1st. So I will leave you with that. Please reach out with any questions that you have. We're here to help, we're here to support, and we want to do our very best to improve all of the quality of life for everyone impacted by these conditions. Thank you.
We're running a little behind, but we have time for one question. If anybody has a question for Dr. Bloom. I think what she said was so just like explicit and amazing. So I don't know if there's any questions. So, okay. There's one question, I'm sorry.
Hi, Catherine.
And still nobody wants us. Nobody wants to diagnose it. And we'll come back.
Yeah.
We'll ask questions. We'll need constant medical care. They just don't want. So I feel like within all of this, these kind of patient advocacy and patient, and a lot of us are managing our own care. You know,
absolutely.
How do we do that? What's our checkup? Cardiologist, we need it. You know, check your heart curves. You know, what can we do to get, you know, or maybe even patient rights?
So that's kind of what I alluded to, that the publication is step one, because then what do you do with that? And how does that actually translate into everyday life? And that's what the society are working on now, to produce tools translated into multiple different languages to give to all of our alliance members, clinicians, so they know how to diagnose it. And that is the key problem here. Rheumatologists don't want this group. Geneticists don't want this group. So we are focusing on primary care, because that's where people enter the system. And we need people identifying what these conditions are and what to do with them, what tests to order. And you have to dance with this for the rest of your life. So we need to beg for a system that will support us for the rest of our life. I know. So we're providing tools that you only need 1 to 2 minutes for. All of these things are coming out. We've tried to think of everything. We're not going to solve all the world's issues with this overnight, but we're trying. Give it time, and I'll be very real with you that it will probably take a decade to fix the decades of neglect that have come before this.
Okay. Well, I want to introduce our next speaker, and this is Dr. Jane Schubert. Dr. Schubert is an associate professor at Penn State College of Medicine, and her research focuses on the health outcomes after surgery, with a particular interest and emphasis on complex care and complex chronic illnesses. Since 2015, her work has included extensive research in heterobial disorders of connective tissue, including Ehlers-Danlos syndromes, and she draws data from a major study from the National Institute of Aging cohort study. So please help me welcome Dr. Schubert. Thank you.
First, I'd like to thank Dr. Knight for inviting me. I went to school here. I lived here for 20 years. So I just think there's a lot of hope right here at the University of Virginia. So I'm really proud to come back and visit. It's kind of bittersweet. So I work, I'm an outcomes researcher, and I work in the Department of Surgery. We're a very large department with lots of divisions. We do not include orthopedic surgery, so I thought I'd talk about orthopedic surgery, okay? Because I think I know a little bit more about orthopedics than I know about other things. I've been working with the Ehlers-Danlos population, I guess 11, 12 years. It all started when I met Dr. Frank Camano and Susan Mills, who's here with me and has been from the beginning, and went to one of the big society conferences and met lots and lots of patients. And really right from the beginning, I was hearing stories about the number of orthopedic surgeries that patients have, and patients have, I know lots and lots of patients over the years, and I may speak about a few of them. So I just want to start with one paper that I found interesting. This was a retrospective analysis of 350 patients, of which over a third had EDS at one institution. It included a comparison group, but I think what struck me with this is the conclusion that patients with hypermobility had more surgeries. The relative risk, that's the RR, was 3.5 times that of the comparison group. And, they had multiple joint sites. They would have multiple surgeries on the same joint, surgeries on different joints, and at a younger age. And I really wanted to understand, I was hoping I could understand why, what was going on exactly. Whoops. Back up. So then the second paper, there are a number of good background papers out there, but the second one that I wanted just to point out was done, this is the Yonko paper from 2021. The senior author on this is Kathy Raggio, who chairs the Orthopedic Working Group for the International Consortium. She's at the Hospital for Special Surgery in New York City, and they did a retrospective chart review of 150 patients and found, as you'll see, a 91% complication rate. That is not a typo, 91%. And their infection rate was more than 18 times the baseline infection rate. And HSS has one of the lowest, if not the lowest, infection rate in the country. So I found that striking. So anyway, I was motivated to dig into the literature. So we did, ideally, I'd like to do a meta-analysis where you kind of pool all these good studies together. And so you have a great big sample size and we can do meta-analysis and those kind of techniques, because that's something I like to do. But you're going to see what we found in the literature, what's published. Scott Rodeo is at HSS. He is a shoulder and knee surgeon, and he kind of kept this train on the track for me, so I didn't say anything too foolish. And anyway, we did kind of the standard big database lit review from the beginning of these databases through February of 2024. And this is how we organize it. So for a paper to be included in the study, we were looking at, obviously, Ehlers-Danlos syndromes, but any age or sex. They had to be studying orthopedic surgery of shoulders, knees, hips, the spine. You can see that, elbows. What we left out, we excluded neurosurgery procedures that involve the brainstem. Why did we do that? Well, I think what we were trying to do was big enough. And the neurosurgery, that just seemed to be different, and it was just the way I did it. So that's my justification. Now, the studies did not have to have a comparison group. If they did, we recorded it, but they did not have to have that to be included. But they did have to have some type of outcome, whether short-term or long-term. So this is the most important slide for this part of my talk. We ended up with 71 citations that we were able to include, published through 2023. And this is what's important. Look at the type of studies. 38 were single case studies, like one patient, okay? 14 were small case series, several patients. 19 were retrospective, looking back in time cohort. No randomized clinical studies. There were some database studies, no systematic reviews. So not a whole lot out there, right? I couldn't do that meta-analysis I had hoped to do. But there were, and some of the other limitations were that most of these studies lacked standard validated measures when they were looking at the outcomes. The criteria, in fact, used for the diagnosis was not even stated. They just were patients who had EDS. We don't know what type, and we don't know how that was assessed. And the follow-up periods varied both between the studies and even within studies. So in a case series, maybe some patients were studied for 3 months, for 6 months, for a year. It was all over. It was just all over the place. The key findings, we did not find convincing evidence to support the long-term success of orthopedic surgery in EDS. Now, let me say that again. We didn't find the evidence. That doesn't mean it's not there. We just didn't find it in the published literature. Now, again, most were case studies, and I don't want to discount case studies at all because I think they're really important. So if you're doing that kind of work, if you're a clinician, write about it. Get it out in the literature, even one patient, if it's interesting and different. But most of those papers tended to focus on surgical techniques or challenges that might be specific to EDS. Again, very important. So in summary, I guess this high level summary were, high rates of subluxations and dislocations, pain that may require surgery. If non-surgical interventions fail, surgery was considered to be, a last resort because management, as you know, is challenging. And as we know, these patients often have multiple unsuccessful surgeries. And again, the literature is sparse, so I'm hoping more orthopedic surgeons will be inspired to do this. Okay, I'm going to shift gears because I like data, and this is something I did a couple of years ago with a big database called MarketScan. At the time, it was owned by a company called Truven. It has since sold and is now Meredith. This is a very large commercial claims database with over 230 million patients. Now, also, all databases and studies have disadvantages. This one, it includes patients, this is employer-based health insurance, their spouses and dependents, okay? So we're leaving out a lot of people. I did not look at Medicare, I did not look at Medicaid, the self-pay. This is an insured population, but it's very rich in that it has inpatient, outpatient. The drug detailed pharmaceutical claims are terrific, and I've done a number of patients, of course, never by myself, but with my colleagues using this database. So I looked at this one a little differently, and usually when I use big databases, my first thing is sort of to code and to collect all the EDS patients. That's my big pool. Then we dig into that and we begin to do our studies. But with this one, I went after all the surgeries that I was interested in. Okay, so, and I used the CPT procedure codes or diagnosis codes. And so that was the time frame 2005 to 2019. And you can see I looked at a whole lot of things. I'm going to just talk about the first bullet, the orthopedic, but I have the data for all of this. And I never published this. So, and I've never presented it. It's, I'm not sure why it's in a pile. But, in MarketScan, the patients had to be enrolled. They had kind of a washout period prior to their surgery, and then for at least 6 months after surgery, because I want to look at outcomes, right? And you can see I looked at a lot of different diagnoses. After we had our big pool of the surgeries, then I looked at EDS and Marfan and skeletal dysplasia and all kinds of things. Because if you're going to get all this data, you may as well code it all. I did do all the comorbidities. I'm not going to talk about that because there's been a lot of discussion about comorbidities. I'm going to tell you the results in terms of complications, but I'm just going to show this busy slide real quick because I code everything. I use, we're going way back in time. So we have some that are ICD-10 codes, and then we use the current, ICD-9 codes, and then we use the current ICD-10 codes to code complications. And then I look at outcomes. That's what I care about. So in Market Scan, we can look at readmissions, inpatient readmissions. That's for any reason. I never know why a patient was readmitted. So again, here's a downside to using this large database, but the advantage is it's really big. I look at emergency department visits, repeat surgeries within the same categories, or second surgeries that are not the same classification. And then we look at 30, 90, and 180 days after the index surgery. So for EDS, there were 1,280 patients. If I add in HSD, I usually about more than double the sample size. So I'll just make a quick comment. I typically look at both, but I've coded. There is not a diagnosis code for HSD. There's never been that. Okay, so that's a big problem for me. I use a proxy. I use M35.7, which is hypermobility spectrum, but that can include all kinds of things. So we never really know. So if I combine it, I always analyze them separately. Now, from here forward, I'm just going to talk about EDS because I just feel like that's clean. Because we have such a huge database, we can match one-to-one, that's good, on age, sex, and an index date. And this is the last slide on this. I just want to point out some of the results that we found, which I thought were pretty interesting. You can see the control group. Now we match, so I have controls. What are controls? I don't know if they're healthy people or not. I just know they don't have EDS. Okay, that's the way we define that. Compared to EDS, and then whether they were statistically significant in terms of the differences using, this is chi-square. So the ones I think are the most interesting are down a little towards the end. The emergency department visits, we're more than double on a lot of these things between EDS and controls. So maybe there's kind of something there, but I don't really know why they went back to the ED, why they went to the ED. I don't know. Maybe that's why I didn't publish it. So let me just move on from that unpublished study. I want to tell you about Penn State, okay? Because and I'm going to let the data tell the story of what we are doing at Penn State Health in terms of EDS. Okay, this is the data talking to you, me telling you what it says. So first of all, a high level view of Penn State Health, kind of your standard stuff there at the top. The flagship hospital is in Hershey, 631 beds. That's where I work, in Hershey. We have a large catchment area in central Pennsylvania. We've been buying hospitals, so we have multiple hospitals, but Hershey is the main place. We serve a core of about 6 counties. And then but we really have a large catchment of 15 and even more for cancer. So we're serving a large area between Pittsburgh and Philadelphia. Okay. So I pulled this data. Now this is coming from our our system data. I get the IT people, I get them to convince them to help me. So we were able to we have Cerner, by the way. We're switching to Epic soon, and I'm told I won't get this kind of data, but they gave me 25 years of data looking at the EDS patients that we had seen. Now, I'm going to restrict this to just patients that I coded as having orthopedic or neurosurgery procedures. So this is a subset, but you can see the trend line there. We're seeing more every year. So since 2022, because I'm going to kind of lop that off and look at what's really going on now, 638 active patients. And if we keep going at the rate we're going, and I just sort of project that out, we will see 580 unique patients this year. And that isn't even everybody. I know we've got PT here. I'm not able to capture our physical therapy. I won't get into that, but just we're kind of different organizationally, so I don't have access to that. But the top 10% is accounting for 10 to 36 visits each, kind of reflecting people that are requiring frequent procedural interventions. So I was trying to get a sense from the data, who are kind of the one-time people we see? Who are we seeing repeatedly? Have a lot of data I could wade through and look at that. I also said, well, what are we doing? Like, who's doing what? And we do all kinds of things: spinal surgeries, infusions, diagnostics, injections, some surgery, hip replacements, and so on and so forth. And well, I'll keep going with that. Length of stay, though, this is kind of interesting, right? A 9.8, almost a 10-day length of stay. That's very high. That's not where we want to be. But and for a standard orthopedic joint replacement, I mean, honestly, some of them are like, hey, you got a new hip? See ya. And it's same day, truly same day surgery. But 2 to 4 would be a standard for somebody a little more complicated. So this 10-day is reflecting the complexity of some of the outlier type patients. This is a little bit, but wound rates of wounds and other complications are the reasons, in some of the cases, for the extended stay. But our top procedures are mostly injections, and that clinic and that same day surgery are representing the vast majority. Physical medicine and rehab has by far the highest volume. And the way I'm going to characterize is, are we a center of excellence? Not in the sense of an organizational infrastructure. There's not been that organizational initiative. We're kind of, we're like a stealth center. And we are rapidly expanding. And I feel like why? Because patient demand for surgery, the patient demand, the patients are coming. And most important, we have a core of just dedicated, fabulous, wonderful people who are willing to see people with EDS. And the word gets out and they come. And that's what's going on. What hasn't happened yet is the organizational infrastructure to support that. And what do we need? We need money for that. But if you call and try to schedule and say, now, just you call who sees EDS? They can't tell you. They can't tell you. It's not that they won't, they can't. Well, I mean, I suppose they could. So we got a long way to go. So the other thing I'm going to switch, kind of wind up with this part, thinking about perspectives of orthopedic surgery. And the thing I think about is, how do we measure success or failure? It's a complex thing to measure, but I think it's really important. So is success a decrease in symptoms or an absence of symptoms postoperatively? For somebody like me who likes to look at data and decide, where do we go from here? How are we doing? Success is going to be important. And I feel like there are different ways we can capture that. And one is the patient's perception, and then also the surgeon, and then both is what we need. So, okay. This is ongoing. I'm going to call it a pilot, but I have put this out, and I think, Dr. Knight, you've sent it out to your team. Let's push it out again. We're in the early stages here. I'm just going to show you 2 screens. This is an online survey. I'm really asking physicians who, they don't have to be surgeons, but orthopedic physicians. So maybe they're doing injections or whatever. But I'm really interested in, what are they concerned about when they evaluate somebody with EDS? I ask a lot of questions, about the kind of practice and how many they see and so on and so forth. But what are they most concerned about? And what has their experience been? And does perception match reality? And I'll tell you one real quick, one thing that kind of drove me to this. I heard from a patient, it's been some time back, who actually went to our own orthopedic department and was turned away. And by an orthopedic surgeon, it was like, don't do EDS, can't help you, don't do EDS. And you don't like hearing that, and kind of angry on the one hand, but also, why? Like, why? I mean, maybe there's a good reason, right? We need to understand why what's going on here. So this is sort of maybe my attempt to find out. Now, surveys. I don't know. Has anybody done survey research? Good. Okay. So we've done Susan's terrific at this, and we did some surveys, a number of them, but we did one fairly recently with patients. Now I asked these patients. This was an economic survey, very difficult. I asked them to go back. They had to stop. They had to go get their records. How much money had they spent? Get out your tax returns. Get out, and then answer all these questions. And how much did you spend on this and this and this and this? And it probably took quite a bit of time. And we didn't really have to push too hard. I got 1,003 responses, right? That's published if you're interested in it. This, so far, I have 17. I was warned. I was warned. Jane, you're not going to get surgeons and physicians to fill in survey. And I totally get it. I totally get it. We're all overwhelmed with surveys and it's difficult, right? But we're going to keep pushing, right, Dr. Knight? But I will give you a little, I'm going to like a little, just one teeny bit. This may bias anybody who takes it, but the one thing, this is looking at patients, and then I ask, is it different with EDS? But what are the most important things to consider in their recovery? And coming through really strong is that 13D, the expectations of the surgery, expectations for recovery, expectations of what. So I found that kind of interesting. We'll see what it looks like when we get more responses. Okay, I did one more study and it's one patient. I thought I have lots of people I could talk to. I want to kind of wind up with this because I want to come back to the patient and the patient perspective on this because that's really where it started. So I have a lot of patients, a lot of people, and I thought, maybe I could get some patients, maybe even one to kind of talk to me. And I truly randomly just picked somebody. I wasn't even sure that she had had surgery. But she had, and she was willing to talk to me. She talked to me for an hour. Female, age 50. She actually has classical type. Typical story, I guess, if there is a typical, but you've heard the story. So very athletic person. I think she played softball and lots of sports. But along the way, had lots of sprains and so forth and so on, like we've heard today. And then she had a car accident, very serious car accident. Maybe that was that event, Dr. Frankenman, right? That precipitating event, because from there, a long recovery, very difficult recovery. And she was diagnosed 2 years after that at the age of 34. But the reason that she was diagnosed was luck, because she had a neurologist taking care of her as the result of some of this injury who had just happened to read about EDS and took an interest in it. She had, and then over time, she had both ankles. She had surgery on both ankles, braces to tighten things up, a revision on an ankle due to an accident. She fell. She had a knee done, both hips for frayed labrum, both elbows have been done, and a whole bunch of other procedures and things for various other orthopedic conditions. So she's had a whole lot done, a lot of things done. I don't know how typical that is or not because I haven't, done that. Maybe somebody else could do that. So my final thing in asking her, I said, do you consider your surgeries a success? And she said, without hesitation, yes. She'd had one wound complication on the ankle that was treated at home with a wound kit. She had a successful revision. The fall was due to having POTS. She got dizzy and fell. And then I asked her about other thoughts. What else should I say? What else is really important? And she said post-surgery that she said, tell everybody the post-op visits are simply not sufficient for EDS because the healing process is longer. And to recommend additional visits, with the physician assistant and also tailored protocols for EDS, even by week. What should I be doing each week? And you need a longer time frame, and you need more visits. And her other point was that not all symptoms are due to EDS. Okay, because she had some experience where you know, she had pain and some symptoms that should have prompted imaging. Physician sees the EDS diagnosis and says, it's your EDS and don't worry about it. And it wasn't. So in conclusion, the outcome studies are very important, I think, to ensure both surgeon and patient expectations and help guide shared decisions. And then, as we've heard, you know, education and expertise. So I think, you know, I think we need to get the word out to our surgeons as well. I did some time back, so my work has been, you know, had some support. It's I'm grateful for any and all support, and it's honestly never enough to do all that we want to do. But let's get the word out to our surgeons.
Getting a little agita. So I've referred patients for surgery.
Okay.
And had the surgeon say, EDS, I don't want to touch it, right? And for reasons that are not entirely clear, the question is to help that. But one thing is the economics of it. If the payers bundle the payment, we're gonna, you know, for every joint replacement, we give you X amount of dollars, which is what most of the payers do. If EDS patients have a longer recovery time, greater complication rate, et cetera, institutions might actually lose money on those procedures. So we haven't really talked about working through the CMS. And, you know, all the payers tend to follow what the CMS says. But if the CMS says, we're going to pay you more money to do procedures on EDS patients because they cost more money to do those procedures because they have more complications, et cetera. So that might turn that around. But so do you have a sense yet? Is the problem ignorance? They don't know what the problems are? And then you seem to be suggesting that maybe they're smarter than we think. They know that there's more complications. And then what do we do with the payers?
You know, that's an excellent question. So why, I guess the question, you know, why are surgeons reluctant to see EDS patients? Is it because of complexity, ignorance, or because of bundled payments and that the institution could lose money on it? That was, I'm trying to paraphrase your question. You know, I don't think it's economics, not yet. I don't get that sense, not where I am. I think it may be they just don't know that much about it, and its complexity, and they're time consuming, but they don't want a bad outcome. Nobody wants it, you get dinged, right? You get dinged on bad outcomes, so don't want a bad outcome. I gave a number of years ago, it's been quite a while, in my department, we have to take turns giving, you know, what grand rounds is. So that's like where you stand like this in a much bigger, and it's kind of a hostile group in the Department of Surgery. I mean, it really kind of is. Nobody's laughing or smiling. You know, you don't get that feedback like you guys are great. So I did talk about surgical outcomes in general surgery, and thankfully I didn't realize at the time what my audience, but I was told I was really, really brave to talk about EDS to a group of surgeons. That's been a long time ago. I don't know that I would do it again. Maybe I would. Anyway, was there
any more questions? Yes.
It's been going on for decades. And so my physical therapist, who fortunately is somebody who specializes in EDS because his wife has it, his question has to do with the poor outcome of ankle surgery. He showed me an article, the outcomes after surgical management of large joint manifestations, Ehlers-Danlos syndrome, and
not,
Jan, can you repeat?
okay, so she's asking, the question is about ankle surgery, and a physician that has questioned whether the outcomes are good enough in using standard ankle kind of surgery procedures. Is there any work to do, more specific, different types of procedures for ankles? Some of I don't know specifically about ankles that have been published, but I do think that like some of the mechanisms, the hardware that will, that will anchor things, because what's going on in EDS, it's typically these ligaments are stretching. Okay, it's not like the bones so much as it is the stretching of the ligaments. And so that can like be tightened up, but then what happens is it stretches out again and it goes back. So it's not as successful. But I think that there are not the studies, which I had hoped to find, to look at, do standard procedures for other patients work in EDS? Or are there modifications that are needed specifically for EDS? I mean, with some things like, some of the other complications like sutures don't stay. So yeah, right. So suturing techniques, they may be more difficult, but they're certainly doable. But the surgeon needs to be aware of that. Even in my department, I mean, we have, people with EDS have all the other same kind of stuff, right? Coming in for surgery where sutures are a problem, wound healing needs special care. Hardware may be rejected or kind of move around. That's another thing. Hardware failure is a big thing. And that's a pretty bad outcome because, you have to take it out, redo it. So no, there needs to be more work to understand this.
All right, thank you, thank you. I just want to say to Jane that Dr. Knight and I are meeting with the entire Department of Orthopedics next month, and we're going to bring that survey, make sure they fill it out while we're there.
Thank you.
All right. Thank you, Dr. Schubert. Okay, as we continue on the afternoon, we're kind of shifting gears a little bit here, and we're going to shift our focus basically to explore the area of the intersection of research, clinical understanding, and patient experience, particularly as it relates to overlapping in some unrecognized conditions. So that's what we're talking about next. I am pleased to actually introduce two of my colleagues. One is Dr. Rochelle Crescenzi, and the other one is Casey Grosinger. Dr. Crescenzi is a translational imaging scientist and director of the SALT lab here at UVA, where her NIH-funded research focuses on advancing non-invasive MRI techniques to better understand lymphatic function, sodium storage, and vascular disease pathways in conditions such as lipedema. And Casey brings more than 2 decades of experience in project management and communications, along with a deeply personal perspective as a patient living with lipedema and its related condition, and is a strong advocate for increasing awareness of these overlapping diagnoses. She's also a very active member in our patient advisory group here that we've put together. And together they're going to bring some of the perspectives across translational research and patient advocacy as we explore the relationship between lipedema and the Ehlers-Danlos syndromes. So Casey and Michelle, thank you.
Thank you so much. We've done this before. Okay, thank you so much. I hope I'm going to invite you today to wonder with me, is there a connection between lipedema and EDS? But I'm not going to answer that question today. I hope we wonder about it for a time together at this symposium and after this meeting. I'm really, really thankful to Ina and Dacre for inviting me. It's been a pleasure to meet them over the past year. I'm also new to UVA, so my story with lipedema started in 2016, so I'll start my research, results will start there. I just want to disclose I work with the Lipedema Foundation closely as a scientific advisor, thankful to be on that committee, and our funding is from the National Heart, Lung, and Blood Institute and the Lipedema Foundation. The data that I'll present to you from our research results isn't meant to inform an individual's medical care, so just making that disclosure ahead of time. I hope to share with you today the challenges of lipedema, and I see a lot of themes and similarities with the story of EDS, so I'm curious what you all will see in our story. I will present our SALT MRI approach to understanding lipedema and invite us to translate together where we find some connections. So in 2016, I was awarded a postdoctoral fellowship to apply imaging to lipedema. And at a meeting with clinicians, this was at Vanderbilt University Medical Center, one of the physicians asked me, where are you going to find patients with lipedema? And I said, I thought that was what you were here to do. And I didn't know after that. So we went to the patient conferences and heard about their stories and what symptoms mattered to them. And we developed a brief survey and I sent it out on social media after IRB approval. And I got 400 responses in 2 weeks. And I thought, this is a really engaged patient community. And I've been engaged ever since. That was an incredible response. And in this community, we're still seeing those kind of responses. A few years later, we built that up into a partly diagnosed cohort, and we developed a survey from 707 participants. And those results initially showed us that the most common symptom that troubled patients was pain, and that on average between 0 and 100, patients are reporting daily pain levels of 53, so over 5. When asked, according to patients, where they experienced their pain, they responded with disproportionate experiences throughout their body, which mainly focused on the lower extremities. So the primary pain was experienced from the hips down, but sparing the feet in relation to the rest of the legs, some in the upper arms. If you asked about other symptoms in lipedema patients, such as fat deposits or swelling that bothered them across the body, those symptoms were also focused on the lower extremities, a slight prevalence in the upper arms, and in the calves, and is where we're going to image. So across the calves, all these symptoms were noted. So we are going to focus there on imaging. But one story we were hearing is that the feet are spared in lipedema, and that may be true of the feet, but of the fat tissue. But this data showed us that swelling and pain symptoms are experienced in the feet of people with lipedema. And so overall, what we learned from the patient surveys is that this disease is one characterized by disproportionate fat, disproportionate swelling, and disproportionate pain. According to physicians at the time, this is the standard of care for lipedema in the United States, put together by a group of experts led by Dr. Karen Herbst, who's an incredible mentor and educator in the field and taught many of us about this disease, lipedema. These are her examples from the clinic that are published here across what's called stages of lipedema. And one of the primary criteria is that it is a distinct distribution of pathologic tissue that differs from non-lipedema obesity, and that is according to physicians. Here's a case example by photos of what this might look like when a patient presents to a clinic. On the left is a patient with lipedema, and on the right is someone with obesity determined by their BMI. And the lower extremities may appear different in these two cases because this is quite a characteristic case of lipedema. Compared to irregular obesity, lipedema has a gynoid fat distribution, has ankle cuffing, which you may see in this example, has a leg girth that's resistant to metabolic treatments, including bariatric surgery. The fat is typically painful. It exhibits easy bruising and has a lower prevalence of metabolic disease despite high BMI. Yes, you get the connection I'm hearing. So this is compared to common obesity. There's other symptoms that are more troubling to diagnose in the clinic as well. There was a term called lipolymphedema that was used at the time. And this is when lipedema has progressed to clinically identifiable lymphedema or insufficiency of return of the fluid in the lower extremities by the end of the day. And this was seen in increased stages of lipedema, according to physicians. And so in a clinic, this is what it might look like. We have a patient with lipedema and a patient with cancer-related lymphedema, where you know the cause of lymphatic insufficiency. In the person's affected extremity with cancer-related lymphedema, it looks an awful lot like lipedema as well. It's larger than the other. It has a texture to it when you palpate it. There's even an ankle cuff on that person's leg. So when someone doesn't have an identified cause of lymphedema, they're usually called lymphedema in the clinics. It could also be lipedema. We're trying to help differentiate these two. So this represents a challenge in the field. Compared to lymphedema, in a clinical setting, lipedema can be characterized with an ankle cuff, a bilateral leg swelling presentation, feet that are often spared, and lymphatic insufficiency symptoms that are suspected but may not be confirmed. Those were demonstrated. And these are the challenges, are to distinguish lipedema from obesity or lymphedema in a clinical setting. The etiology remains unknown, and we need to understand that. And this is a similar story we're hearing. The symptoms may have onset at times of puberty or pregnancy or changes in hormonal events in patients. That may be on an average age of 10 to 19 years of age where symptoms are onsetting for lipedema. But the average age of differential diagnosis, according to a US population survey and a UK survey, is not until 44 to 48 years of age, which is a 20-year gap in diagnosis. And that's a benchmark that we need to use as something to improve. And I think we really can. What we need are objective tools, though, to help differentiate lipedema from obesity, to study disease mechanisms, and to evaluate therapies. So I'm going to share with you some evidence from the first, or speaking towards the first aspect of this, using our imaging approach. So I'm an imaging scientist and love magnetic resonance imaging because it's non-invasive. And so this is our tools. We use an MRI scanner, which you may or may not have seen before, but it's a large bore scanner and it has a detector for the anatomy of interest. And I work together in a great team. So this is our current team from 2025. Okay, our approach is called SALT MRI. If we have time, and you're welcome to ask me, why sodium? But suffice it to say, we're interested in where sodium is in the body, and we can image it with MRI non-invasively. We also think it's interesting to study it alongside the adipose tissue distribution and the lymphatic function in the body. So we're seeking to do this in a non-invasive approach. So next I'm going to show you some results from individual case studies in these, using these techniques, and group level results, and then move to translation. So starting with our first type of imaging, this is a fat-weighted MRI or adipose tissue-weighted MRI in a whole body approach. I'm showing two case examples. On the left is a healthy female with a BMI of 24. And on the right is a patient with stage 1 lipedema and a BMI of 25. And these participants have similar BMI in this case. We performed whole body MRIs because we didn't know exactly where to start with lipedema. We thought the lower extremities might be the most interesting, but what if that wasn't the case? And we wanted to study the distribution. So we wanted to know what upper body fat distribution was compared to lower body. But if you would just observe the bright areas of the image, that's where the adipose tissue is located. You can compare between the waist level here, and if you scan down all the way through the legs, you might notice that the participant with lipedema has a thicker amount of subcutaneous adipose tissue that starts about the hips and continues throughout the legs. Then the examples on the right are looking at just the level of the calf. A transverse image shows the fat-weighted tissue on the top and the water-weighted tissue on the bottom. And if you take the volume of those bright pixels in each of those two images, so the amount of fat tissue volume or the water-weighted volume, which is essentially the muscle, and you take the ratio of those two, the participant with lipedema has 3 times as much fat to water ratio as the healthy participant with a similar BMI. So we thought that was interesting, and analyzed across the legs in a small cohort, but a pilot cohort of people with lipedema and people without. We found that in every decade or every 10% of the leg height, there is a higher level of subcutaneous adipose tissue volume in people with lipedema compared to a cohort with similar age, BMI, sex, and race. And we found that in the upper thighs is the most distinctive region to look when you observe with this biomarker. That was published by an excellent graduate student in the lab and was a lot of fun to do this study as an imaging scientist and find a potential distinguishing marker of lipedema. We moved on to look at tissue sodium in an upper and lower body approach. So again, in the upper body, I'm showing in the middle column here what forearms looked like in people with lipedema, and on the right, images from the calf. In this case example, we're comparing a patient with stage 3 lipedema compared to a healthy female. They're within a decade of life, and they're within 5 points of BMI of each other. You can observe that in the forearms, there's a similar amount of adipose tissue distribution in the forearm, and there's a similar amount of tissue sodium as well in the colorized image. If we look at the calf, however, there's a thicker amount of subcutaneous adipose tissue where that arrow is pointing, and there's higher levels of sodium throughout the leg. This is a colorized image that's quantified into the physiologic range of tissue sodium between 10 and 40 millimole per liter. And the red and yellow parts of the image show higher deposition or storage of tissue sodium. And that's occurring in this patient throughout their skin, their subcutaneous adipose tissue, and their muscle. That's a case example, and here is a pilot study looking at those effects as a group. We're comparing here controls with similar age, BMI, sex, and race compared to a group with lipedema. And we found that in the calf, in the skin and the muscle, there were distinct amounts of tissue sodium storage, and that was not true in the arms. So here we're looking at a distribution of sodium throughout the upper and lower body, pointing to the lower extremities being more affected by storing more sodium. Our third technique that we were interested in piloting was a non-invasive approach to look at lymphangiography or tissue edema throughout the lower extremities. And we think this relates to where sodium and where adipose tissue is going to develop for a lot of reasons. And we're interested in understanding this across the spectrum of lymphatic diseases. We did some early work in simulating and developing this technique in true lymphedema, where a known cause of lymphatic insufficiency is occurring. And then we applied it to lipedema. I'm just going to orient you on what the image shows here. On the left is the adipose tissue weighted imaging that we've been looking at, where white means a lot of adipose tissue. The image to the right of it, the bright parts of the image now relate to tissue edema or fluid that's moving slowly. And you'll see that fluid is in the bladder, it's in the synovial joints, in the knee, but it's also throughout the tissue in this participant. You can also see in this 3D view that it has tubes and channels, and they traverse into the lymph node territories where we might expect a lymphangiography to show. So we're working actively still to develop more quantitative and whole leg approaches to analyzing those hyperintensities or those bright parts of the image, because we think they show us important parts of where the lymphatic system is accessing. To do that, we really need better tools to segment or analyze our images in the legs. I will say, as an imaging scientist, there's a ton of development in brain neuroimaging doing segmentation, and there's a lack of development in the extremities. I have no idea why. I think the majority of people I ask in my family, they have issues in orthopedic areas, not necessarily in the brain. And so I don't know, I just find it really interesting that there's a lot of focus on brain image segmentation. Maybe it's that the legs are harder. I don't understand it really. So this to me is a circle, a lot like the brain. If anyone's interested in helping, we'd love more help in this area, right? It doesn't seem that difficult, but I will say there's not great tools. So AI has really made a lot of development and help with image analysis, because it's inherently, images are inherently matrices, just like these networks are training on. Anyway, it's exciting. We could go into this more, but I'm really thankful for some help and collaboration here between radiologist Klaus Hegspiel, Nick Tussison in radiology at UVA, and a fantastic graduate student, Zola Bizdek, in physics. And together over just the last year, they've helped develop an automated tool to segment our images and apply them to the lymphangiography. Sorry, thank you all for listening to this part. I think it will make a difference though, because there's a lot of misunderstanding about edema and whether lipedema is an edema or a lymphatic disease. People are maybe more willing to understand lymphedema because it has the lymph in it. And so we're looking across different case examples here and what imaging can help us understand about these conditions. So in a control participant without a known lymphatic insufficiency, in lymphedema where there's a cancer-related cause to their edema, in a patient with lipedema where there's no otherwise cause of edema, and in a person with lipedema and symptoms of lymphedema where they have unresolved swelling by the end of the day. And on the lymphangiography image to the far right on the gray level scale, you might observe those hyperintensities are more intense in the lymphedema case and lipedema with lymphedema. So now we start to see positive controls coming out in the data set qualitatively. And our lipedema case, not yet with full-blown lymphedema, has hyperintensities as well. And it's throughout their subcutaneous adipose tissue. And we want to understand where that's developing and how it's characterized differently. So to do that in a quantitative way, after we see it with our eyes, can we measure it with a number? And that is what something called texture analysis does. And so these are some typical texture features of images called energy, entropy, or homogeneity. And we're going to get excited about these in the lab soon. So I share this with you. It's unpublished new data, and we're really excited to keep pursuing this together with radiology and understand how to characterize edema in lipedema. And I really am curious what the EDS community will see in this. But here's the start of a larger scale diagnostic model study. This is funded, started with the Lipedema Foundation Pilot Award and was funded for 5 years by the NHLBI. And some of our initial results of that study are here. We gathered 65 people with diagnosed lipedema compared to 33 controls. And we took an MRI approach and a bedside approach to objectively quantifying characteristics of disease and seeing if we could help develop a model that would aid a clinical diagnosis based on just objective tools. And if you use MRI, what we showed is an area under the curve of 0.82. And if we use a bedside approach, we can achieve an area under the curve of 0.77. So we're a little bit more sensitive on the MRI side, but we can get by with a bedside approach that might be more appropriate for a physical therapy setting, for instance. And I can explain more about these tools and metrics and would love to talk with folks who are interested in that in other disease models. But we're really excited to be pioneering biomarkers that can help aid diagnosis objectively for lipedema, and we hope it makes a difference. I want to just end with a call to translate together My work really sits in the T1 and T2 levels of translation, where it's first in human or first in patient applications. And I'm excited to work together at UVA with basic science researchers and those in public health and in practice to really translate our findings to make an impact across healthcare systems. And so this is just a slide to present and acknowledge our team here. I work with a slew of imaging scientists and radiologists, but together with us today is Sarah Algoodban. She's a basic science researcher in adipose tissue biology, working in the plastic surgery department here at UVA. We're excited to have her too. She's a long timer in lipedema, which is like for 10 years. And so excited to work together with Sarah at UVA. We also work closely with Allison Scott, who's a public health scientist in the lab and is developing quality of life. Well, I'm going to show you what they're developing. So we will hold on that. Okay, first of all, in basic sciences, Sarah's pioneering characterizing the tissue, looking particularly at microvascular disease mechanisms of sodium storage. And this is developed with our plastic surgery partners. And in the public health realm, Allison Scott is pursuing ways to identify clinical staging and quality of life, and also barriers to treatment and the medical syndemics of lipedema. If you'd like to participate or help her survey, she needs people with and without lipedema to respond. And this is really related to the WHO Quality of Life Validated Survey Questionnaire across 6 domains of health. And one connection that I see in a way that we could translate together in the EDS community is, I just want to share initial observations that there seems to be an overlapping criteria or an overlap in symptoms between people with lipedema and those with EDS or HEDS or HSD. And so in some of our survey studies, we found that women were 12 times more likely to have joint hypermobility in the lipedema cohort compared to controls. And then some involvement in the international consensus work that I've been helping with across different medical professions, patients, and researchers. This was our Lipedema World Alliance Delphi study, and we found in statement 26 that there was 75.8% agreement that there is an association between lipedema and hypermobility spectrum disorders. There's also a hypothesis put forward to call this a subtype of lipedema when hypermobility of the joints is present. It's called a really fancy Latin word called rusticanus moncor type. And I really enjoy hearing that from the physician community. And so I would love to hear more feedback on this subtype of lipedema that has hypermobility of the joints and what kind of criteria work we can develop together. Can we be asking the same questions of our patients and developing good diagnostic tools together? I just want to throw out there that as I look at the lipedema library, this is curated by the Lipedema Foundation, and it's my favorite library tool to look at. There are 2 published studies that show up when you search for EDS, and one is by Dr. Francomano, who was just here. And so I'm highlighting their work that we're speaking the same language. She's got radiology in their report. They took an ultrasound approach to look at subcutaneous tissue, and there's a lot we could do better with imaging tools to understand these diseases. So I would love to do that together. I just want to share that we're piloting ongoing research into objective biomarkers. This is in partnership with the Lipedema Foundation and NHLBI. There's 2 ongoing studies at UVA to apply imaging tools to study lipedema and lymphedema. These are going to then develop into a longer study that we hope to continue for a long time here. So email us, take the survey if you want to enroll if you're local. And I'm going to pass it off to Casey Grosvenor, who's going to share with you her personal story as a good friend of ours and mentor in the field.
Thank you so much. Which button? Is it this button? Yes. All right, fantastic. Thank you all so much for being here this afternoon. I can't tell you how validating it is as a patient to sit and look at all of this and to realize how many people are working on conditions that impact me, my children, my sisters, my whole family, and millions of people. So I am going to put on 2 hats today. My first hat, I'm just going to talk about my personal journey, and I'm going to just address the elephant in the room. I don't have a hypermobility diagnosis yet, but I want you to think about that as I'm walking through this. And then my second hat will be talking a little bit more about the Lipedema Foundation. So I do not have any disclosures other than the fact that I am a patient. So I want to bring you to some of the dots that needed to be connected and weren't connected as we talk through a patient journey. And I'm going to start with a little picture of 3-year-old me. Y'all can all, if you want, all. This is my first heart monitor when I passed out the first time at 3 years old. And my family had no idea what to do with me or why it happened. And guess what? None of the doctors also knew what to do with me at 3 years old when this happened. And this pattern continued of fainting just all the time, pretty much for my entire childhood. I had a number of other symptoms, headaches, easy bruising, stomach pain, sprains, dislocations, dizziness, and nausea, literally always, every day of my life, nosebleeds, and then the infamous growing pains. That seemed to be the diagnosis that my doctors most appreciated bestowing on me. And this continued over a pattern of many years, so decades actually. So the first time that somebody did something about me passing out was when I was 20 and I passed out in a concert, and the venue had no choice but to send me to an emergency room. It was part of their insurance protocol. That was the first time that a test was done in a hospital that said, you have neurocardiogenic syncope. Oh, and your heart stops when you pass out. So that's fine, you know. So that was the beginning of a diagnosis. I can. So I'm not even going to try to cover all of the items on this slide, but over the next many years, there was just a number of different symptoms that were happening without a unifying diagnosis. So you'll see a couple of a bee sting that happened in the top middle, and then the skin pattern that happened around that. You'll see poor wound healing, things that just didn't heal the proper way. I lost my voice for 2 years, and I went through so many types of medical tests and scopes and things like that. I had a severe disability, and it was very challenging for working and existing and raising kids. It was when my children were young, and I would have my child run across a parking lot, and I would try to yell out for them not to run in the street, and my voice would fail me. It was terrifying. And eventually, I was diagnosed with a vocal cord disorder, which now I think was probably not even the right diagnosis. Again, the dots were not connected. I could go on and on with examples. I probably could have put 100 pictures on this slide if I chose to. One that I did not put on the slide that I'm specifically going to reference because of the question that came up about why should OBGYNs care about this? In my 30s, when I went to deliver my second child via C-section, before they got to my child, they could see her face. They ended the they obviously did the C-section. My daughter was born healthy. She's amazing. And after that, I continued to have some issues, and they found that my uterus never healed. And I was told, if you ever get pregnant again, your uterus will rupture, and it will be a devastating problem for a child and for you. We have to take your uterus. I would not have chosen to have a hysterectomy in my mid-30s. Again, nobody connected the dots. So finally, there was a turning point. My issues that I was having were not specific to me within my family. We had so many overlapping symptoms, and my oldest sister had really been researching very deeply and found that there might be mast cell involvement. And she got into a study with the NIH. This was a study, I believe, that John Lyons was probably involved in. But after she finished that, she involved the rest of the family, and several of us were diagnosed with hereditary alpha tryptophanemia, which you've already heard referenced today. That was the beginning of a diagnosis that I'm going to talk to you about today. So you'll see some images of me growing up. There's actually very few images of my legs growing up because I couldn't stand them, and I really avoided photos of my legs. But my sister went to a mast cell conference, and there was a pamphlet. That pamphlet's up there on the table if you'd like to look at that. And when we looked at that, we realized this is lipedema. And so I was diagnosed 5 years ago. with lipedema. I have undergone 5 lipedema reduction surgeries, and I practice conservative therapies several hours a day and have consistently for 5 years. So it is possible to help. Now, I'm not cured. The lipedema is still there. I still deal with it every day of my life. But that's where another dot got connected. I started participating in research, and the doctor, Karen Herbst, who Dr. Krasinski already referenced, said, "Did anyone ever tell you you're hypermobile?" And absolutely not. I'm stiff. I can't move. Like, my body doesn't move. And I think maybe the same medical school slide that was on the screen a couple times earlier was all I knew about it. I was like, no, I'm not hypermobile. Well, the systems start to show a different picture. You've seen many graphs just like this today. So I only put just a few of the symptoms related to hypermobility. These are just a few of the things that are connected that I have found are impacting my body. And so, yes, I do not have a diagnosis, but ironically, I'm on the waiting list right now at UVA. UVA's hypermobility clinic. So one day I will have a diagnosis. Maybe it's not hypermobility, but maybe it is. And to the point that Dr. Krasinski made, I am not making a statement that it is connected or it isn't connected, but it feels connected to me. I will try to move very quickly here, but a couple of areas where patients can really help their own health here. I absolutely participate in research every chance I get. I've contributed to Lipedema Foundation's Biobank and to Ehlers-Danlos Society's Biobank, participated with the NIH. And as you referenced earlier, I am part of the patient advisory group here at UVA. And I really just want to say, patients shouldn't have to spend decades connecting the dots. We can't connect them alone on our own, but we do need professionals to help us walk through these things and connect them. So that reaches the end. I did have a few more slides, but I think we are out of time. All right, thank you so much.
Thank you so much, both Shelley and Casey. Thank you. Any questions for Shelley and Casey? Yes, Sarah.
Absolutely. That would have been the second half of the presentation. I'm so sorry that we did not have. Yeah, I'll come to the microphone. I'm so sorry we did not have time to go through all of that. Yes, we have a lot of tools and resources on lipedema.org that you can access. We have a couple left on the table, although I think the majority of the supply has been taken, but we do have a lot of resources for managing.
We have slides.
Yes, we will have these slides. We will have these slides. We can give copies. Yes, one more question.
And with pots, we're supposed to, consume as much salt as.
Yeah.
So I'm curious, don't have any input on that.
That's a great question. The question was whether there's a association between POTS and lipedema, especially with the phenotype or the outcome of tissue sodium storage that we've been imaging in lipedema. I had the privilege of imaging 4 patients with POTS in the past. One of them had POTS and lipedema, and it is true that I think the clinical prescription is to eat more sodium to help people not pass out with POTS or regulate their blood pressure better. And that's why I'm interested in this relationship between sodium and adipose tissue levels. In the 4 people I studied, the person with lipedema had high salt and high fat. The other 3 had high salt and low fat in their legs compared to other people I had studied with this protocol for a long time. And so I think there's this somehow development of adipose tissue that's protective in the subcutaneous space and may help with things like blood pressure or stability. And it goes along with or has a similar, deposition of sodium to it. And so I think that relationship is really interesting. And I would love to study it more in a POTS cohort and really whether that dietary sodium is helping or not. So thanks.
Thank you both so much.
Thank you.
Okay, so as we come to kind of the close for the day, we have one more very special talk, and I really want to turn this over directly to the, the patient experience. And then that's really what we've been talking about all day. This is really about the patients, obviously. And our final speaker today is Abby Phillipson. Abby is the founder of the Collagen Advocacy Network and head strength and conditioning coach at Adaptive Sports and Fitness at the University of Michigan. Through her work, Abby has become a leading advocate for individuals living with rare and often under-recognized and undiagnosed connective tissue disorders, helping to raise awareness, build community, and push for greater recognition and care. She brings an essential patient voice to the rare types of hypermobility syndromes into this whole conversation, and we are just really honored to have her here today. So thank you, Abby.
Used to be our goal. Look familiar.
While we're waiting, I wonder how many people are wondering why I'm using a headset. Am I about to give a musical performance? I'm not. I just didn't know if my head would be seen over this computer. Don't meet your heroes. They're shorter than what you saw on the internet. I could. Hi, everyone. If you are new to me, well, maybe you've seen me on Instagram, but I hope I've got some good stuff in store for you. So super excited to be chatting today, and I'm extremely thankful for the opportunity. But first, I want to say, what the heck? Because it was only 4 months ago that I started speaking out into what I thought was the abyss. But this room, you people, this is most certainly not the abyss. If you don't know me, and I wouldn't expect that you do unless maybe you've seen me stretch my skin on the internet, it's real. Ta-da! My name is Abby Phillipson, and I am the founder of the Collagen Advocacy Network, which, as we like to call it, is a home for people with and parents of children with rare and ultra-rare forms of Ehlers-Danlos syndrome. We aim to provide community, advocacy, and resources for people living with monogenic forms of the condition. And while I know that may sound really professional, I am not an expert in anything, really. At least not anything that pertains to why you're all here today. I, unlike virtually everyone you've heard from and will hear from, I don't have a doctorate. I don't have patients. You won't find me as an author on any genetic studies, although maybe the subject of one. I can't teach you any groundbreaking science today because I don't have it. But what I can do is bring real behind the word rare. And now the clinicians in this room have read about me and my friends. You've seen prevalence figures in textbooks. You can probably name the genes at play in our truly rare conditions. You can define some of the visible features. After all, you see 13 types on that EDS chart all the time. You know that we exist. But to be honest with you, you could dedicate your entire career to Ehlers-Danlos syndromes, and most of those 13 types you won't ever meet. Some of us are so rare, it's almost as if we aren't real. You may never get to know all that is Ehlers-Danlos syndromes unless you really, really tried. But recently, I really, really tried. I brought real to the word rare. And today I'd like to share our side of the story. We are real. We are lawyers, firefighters, kindergartners, Paralympians, aspiring astronauts, grandpas, veterans, princesses. These are voices you've never heard, faces you've never seen in a moment, probably perspectives you've never considered. We now have over 100 members, 129 as of this morning, across 6 continents, 13 countries, ages 18 months to 67 years old, all rare types represented. And I've recently been asked, how did you gather these people together in such a short amount of time? But to be honest with you, when we make up such a small percentage of the EDS patient community, there aren't many chances to speak up and be heard. And at College and Advocacy Network, we have 2 types of meetings. We have social meetings, and we have advocacy meetings. I've seen maybe 30 of 100 members at social meetings, compared to more than double that at advocacy meetings. You see, for us, the primary need wasn't community. It was a seat at the table, a microphone. I gave them a microphone. And with that, I developed a survey with my research colleague at the University of Michigan to ask our community the hard questions. Do you find that practitioners are familiar with HEDS, but not about your type? 97% answered yes. Have you ever received improper medical guidance due to the presumption that you had HEDS? 80% answered yes. Do you feel that current social media awareness of EDS has been harmful to people with rare types? 92% answered yes. Do you feel part of the EDS community? 5% answered yes. In your experience, have you found it to be more difficult to access resources pertaining to your type of EDS in the last 5 years? 80% answered yes. Are you satisfied with current research and education efforts toward rare types? 0% answered yes. And to be honest with you, as somebody with a rare type, I wasn't really surprised by these statistics. But what happened when we shared these statistics with the greater EDS community online? People were shocked. People questioned why and how we could possibly feel this way. But all that discourse did for me was prove that we really aren't listening closely enough to the rare community. Because the second you turn in, hand them that microphone, this perspective becomes loud. And not only loud, frankly, quite angry. And I think maybe rightfully so. And if I drove all the way here to have this once in a lifetime opportunity to have a microphone in my hand, I'll be damned if I don't make sure my community's voice is represented in every word that I say today. So let's do it. Let's have a hard conversation. Let's talk about why this perspective is so prominent, but why, even so, you've probably never heard it. Now, there's a statistic that I'm not putting up there because I don't want to lose you, and I need you. I need you here with us. If you've grown to like me over the last 5 minutes, I'm probably going to ruin it right now, but just sit tight. I might be able to bring it around in the end. We asked, do you feel that hypermobile EDS and the rare and ultra-rare types should continue to exist under the umbrella label Ehlers-Danlos syndrome? 90% answered no. And I know that sounds scary and foreign and uncharted. It absolutely is. I want to invite you, especially my hypermobile friends in this room, to sit in that discomfort with me. I promise it's not comfortable for us either. Now, before I talk about why people with rare types want separation, I'm going to tell you what it's absolutely not about. What it's absolutely not about is hierarchy, suffering Olympics saying one type is more valid than another. It is painfully clear that anybody with any type of EDS diagnosis is going through hell and back. I can't tell you whose hell is worse. I don't think we will ever be able to measure suffering. And if you need confirmation that's truly how I feel, just know that I know for a fact that I do not suffer the most in this room. My goal in speaking about separation is to make sure that nobody is lost in assumptions and overgeneralizations, and that we all have our needs and biology seen more clearly. Maybe we need separation not to divide us for the sake of hierarchy, but to improve everyone's pathways to proper care. I agree with the sentiment that we are stronger together. But being together so far has meant voices like mine are drowned out. So hear us today when we say that a diagnosis is supposed to protect a patient. It's supposed to define a lived experience, define pathways to proper care. But for folks with rare types, the name EDS has become a barrier to proper care because that label no longer means me and my friends. We asked our group to define the most troublesome features of their experience with their Ehlers-Danlos syndrome. And here's what we got. Number one, by a landslide, was severe skin tearing, scarring, bruising, and wound healing. Then we've got life-threatening vascular fragility or vascular event. I want to make an adjustment on 3 here. It's spinal deformity, not congenital. My apologies for the mistake on the slide there. Number 4, congenital skeletal deformity. And for number 5, tied was congenital hypotonia and severe dental fragility. So overwhelmingly to us, this is what EDS means. Here's what it didn't mean. Only 4 respondents selected POTS. Only 2 selected mast cell activation syndrome. Only 4 selected subluxations. And only 1 selected chronic fatigue syndrome. And now this isn't to say that people with rare types don't experience these comorbidities and symptoms. They can, and they absolutely do oftentimes, but it was not selected largely as one of their defining features of their experience. And now comparatively, a couple folks at College and Advocacy Network did a comprehensive EDS resource search, and here's what we got. The top EDS products: compression garments, salt packets and electrolytes, splints, heart rate and migraine trackers, pillows. We found over 50 EDS podcasts, over 950 episodes. 12 were about rare types, all lumped together in one episode about 13 types of us. The top 3 EDS infographics of 2025 was the POTS EDS MCAS triad, the top EDS comorbidities wheel, and things you didn't know were EDS chart, which we didn't either. We didn't know they were EDS either because we didn't have them. EDS clinics offered hypermobility-centered care, first and foremost, POTS-focused care, mast cell activation syndrome assessment and care, virtual diagnostic assessments, and GI-related referrals and support. And outside of hospital settings, independent clinics offered services that were oftentimes proved to be dangerous for people with rare and ultra-rare types: chiropractics, massage therapy, yoga, acupuncture. Average number of sessions outside of EDS Society sessions that are about EDS, conferences, seminars, 15 to 20 sessions. Average number of sessions about rare types, 1. PubMed estimates over 1,800 research studies that mention hypermobile EDS compared to less than 10 for 7 of the rare types. And I want to stay here for a second to draw an analogy, because up until painfully recently, women were not required to be included as part of research publications, and we are still cleaning up after that mess. The problem being, if you want to learn about the human population, but 90+% of your participants are men, did you learn about the human population or did you learn about men? I imagine a future, maybe a present, where the same is true for EDS. If we're trying to learn about EDS, but 90+% of the participants have HEDS, and most of the other types aren't included at all, did we learn about EDS or did we learn about HEDS? And I think it's important to pause here and say that College and Advocacy Network, all of us wholeheartedly believe that these resources are amazing for people with HEDS. This is what we've been fighting for increase awareness, advocacy, education, research, resources. But we'd be lying if we said it wasn't disheartening to see how many people are willing to band together in pursuit for better for HEDS, while the loudest advocates for us has been us. We all exist under the label EDS. So it seemingly looks like EDS is getting proper attention and resources, but that couldn't be farther from the truth for us. Functionally, words, labels are used to represent something, to elicit meaning. But we're seeing that the label EDS no longer serves to mean me, to define rare and ultra-rare experiences. Being together in this way is causing harm. College and Advocacy Network's biggest pushback has been stop trying to divide the community. We are better together. But are we? We are seeing what happens when we're together. If we're together, then clinics will continue to not provide meaningful resources for people with rare and ultra-rare types. If we're together, then communities will continue to have an entirely dominated HEDS perspective, leaving folks with rare types to feel even more isolated in their own community. If we're together, then every infographic that drops that little H will have more reposts than there are total people living with a rare type. What if separating benefits everybody? And if, as we've heard a lot these past couple of days, there is a biological mechanistic difference between HEDS and the monogenic types, we all, as patients, have a big problem on our hands. If I go to receive medical care and I'm treated as though I have a neuroimmune disorder or a mast cell activation disorder, I will receive improper care. But at the same time, someone with hypermobile EDS goes to receive medical care and they're treated as though they have a congenital collagen structural malformation, they will receive improper care. The strength of a patient's ability to advocate for themselves becomes largely a product of being able to understand the biological mechanism behind your own condition. So, what should we be together on? We can come together toward change. There are not enough of us with rare types, and definitely not enough of us in positions of influence and decision-making to wake up and effectively decide that change needs to happen. We need to be together on this. We don't have power in numbers. Change is coming. But this time, it has to be the right change. We have folks with life-threatening manifestations who are going to become collateral damage to not making moves that provide true, firm structural change. So many of us, HEDS, rare, ultra-rare types, we don't have time to waste. So assuming I have you with me again, what can you all do today to support us? You can take the apprehension and discomfort that you may be feeling right now and turn it into questions, into productive conversation, into curiosity. You can call attention to the terrifyingly limited patient representation for rare types in the spaces where these changes are happening. You can be louder in standing up to misinformation that leads to the further erasure of rare types. You can keep offering us a seat at the table. And what I think, best of all, you can keep handing us the microphone. Thank you.
You're amazing.
Thank you.
Having sat on more NIH study sections than I can remember, you're going to fund 8%, 10% of the grant applications that come. If you say this is a rare disease, you will not get funded. So, not to poke the skunk at all, but using the term rare disease, does that benefit you? And how do I convince my study section to invest taxpayers' money in your diseases without saying they're rare diseases? What is the benefit to investing in these? I don't want to say it only affects a small number of people. I want to say there's a larger gain in investing in studying rare.
Yeah, absolutely. And to be honest with you, I wish I had a better answer for you than what I'm about to give you. But my background is in linguistics. So where you probably sensed a lot of this conversation came from is that labels are very strong. They're very powerful. Words, definitions are supposed to elicit meaning, right? And I think we're seeing right now, and as we've heard from Laura Bloom's talk as well, is we really have nothing to lose, right? We're not getting funds. We have donors, there's donors supporting hypermobile EDS. That's not coming to us. Being attached to something that is getting proper attention and resources also isn't helping. So I hope that kind of answers where we're coming from, as maybe there's nothing to lose, right? Maybe it looks like we're getting support right now. We're at ground zero, versus rip the Band-Aid off. We are at ground zero. And I hope you see us and we're an orphaned, perhaps somewhat of an orphaned condition. I don't have the background you have. I have no idea how funding NIH-wise comes, how that comes. So anybody who has a better answer than I do for that, but.
I've served on NIH studies like 15 years. Well, we funded rare through NIH. I mean, Marfan syndrome, plenty of money has gone, about $80 million, $80 to $100 million just for Marfan. There are other rare diseases. I don't think you need to hide behind a label. I don't think you need to name it something else. I think there are funding opportunities for NIH for rare work through all the different regulatory. So I don't, yes, most of the grants that come through NIH are not dealing with rare conditions, but it's not true that they aren't getting funded. They are getting funded. And it's too much of, Marfan is the perfect example, as well as Louis Disease. They're getting funded at very high rates. Now nobody's bidding grants on rare subtypes of EDS. So it's hard to know how they would do. But I mean, I'll be submitting a grant on a rare subtype. So, I guess we'll see how that goes. So I just said that, rare conditions are being funded through NIH.
We have time for one more, Laura.
Yeah, Abby, great talk. We have got to speak a few times, and at the society.
I can't.
I'll speak.
Where's the mic?
No. Well,
I can repeat it as well.
See the mic.
Here we go. So at the society, we are the Ehlers-Danlos Society after all. We're desperately trying to be a home for all types of EDS and HSD, and it's been really hard. And we've spoken about that. We've done summer camps just for the people with the monogenic types. We've done in-person events. We've done virtual events. We held a summer camp. We had close to 80 people register, and we flew speakers out there and 2 people turned up. And we spent almost 50,000 trying to make that happen. So we have been trying. Now, I know we've spoken about the fact that many of the 120-something people that have tapped into you aren't on social media. So we have body system pages for every type of EDS. We have resources. Everything that is published out there on these types is on our site. And yet I know we're still not doing enough. I know that because of the work you're having to do. So I'm asking you, what can we do more? And how do we reach those people so that when we do get the very rare amount of funding that we do have, that people turn up, that people come, that, if social media isn't the way to connect these people, what is? We've spoken before, the VEDS movement is there under Marfan. There's quite an active VEDS group, Annabelle's Challenge in the UK, and we work closely with them. The other monogenic types, other than classical, are so rare, there's a small handful. But where are the people with classical EDS like you? Like, they're not in the Marfan group, they're not with the society. So where are they, and why aren't they coming to us? And I'm really grateful you've established that, because it's a bridge to those people. But I would love to find out more of what we can be doing, because we're not the HEADS Society. We are the EDS Society, and we want to be doing whatever we can. And just very quickly to touch on the rare,
there's the Orphan Drug Act that does support funding for rare. I think it's really important, the rare, is it rare, is it not type. The amount of misinformation I've put out there, I've seen it put out there, I have definitely not put out there, that say EDS isn't rare, and it's just awful. And it literally is one of the most frustrating things that is ever put out there, because it's so inaccurate. HEADS and HSD are not rare, the other types are. And I think with this new criteria update, if there is, you know, some kind of update on where they live, and if it is part of EDS, that conversation as to what's rare and what's not, I think will serve both communities much better, because we're talking about a condition that is actually probably one of the most missed and underdiagnosed conditions of our time. And the amount of potential funding and system support that could be there for that is huge. But we're also talking about a condition that could be, you know, ultra rare and rare, that can benefit from discrete funding like Orphan Drug Act and like NIH funding that is there for rare. Let's apply to the appropriate people for the appropriate funding to get everyone what they need.
Yeah, so I guess I'll share just a touch of a personal story here. So when we talk about why larger organizations aren't able to create this community that we've been able to build for the HEDS and the HSD community, which I think is such an amazing community. When we talk about why that is, I think we might be asking the wrong question, or maybe looking at it from a backwards position. I remember getting my diagnosis as a child and trying to find community. And guess who I didn't meet? Anybody like me. Okay, so I do feel that the same topic that we're just talking about there, where we have, just by way of the numbers, of the prevalence figures, period, end of story, we have a very common condition lumped with sometimes very, very, very rare. You accept very early on, especially because you're born with this condition, that you're not going to have community. I've met one singular person with pathogenic classical type, and they found me, right? So I don't think it's a question of, oh, we're trying to create community and nobody's coming. I feel like we sensed that the community wasn't really for us from a very young age. I remember being in a community group at 10 years old and telling my mom, I'm like, I don't have any of this. Like, are we sure I have this? I asked my mom, are we sure I have this? Because the experiences are not what I've lived with. And so to my point, for us at this point, because it's been a lifetime of, well, there is no community for me. I'm so dang rare. There's no community for me. That's not really what we're seeking. What we're seeking is, I said, hey, we're going to have a meeting and we're going to talk about the issues with Adam TS2 gene specifically. And then guess who all flocked? All the folks with dermatosparaxis EDS. I've got parents of young children with it. I think it's 11 folks confirmed total. We have 7 of them in our group. People came flocking when they heard something very, very specific to them. If I said we're going to a summer camp, I don't think anyone would show up. But if I said, let's chat about what we've all been feeling for years, that we haven't had a place to say this, or at least a place where it's heard, people came. From 13 different countries, people came across all types. We're 8 weeks old.
Incredible. Can I just say, you're an incredible gift to this community.
Thank you.
And an incredible voice, and they're lucky to have you speaking on their behalf. And I look forward to working with you much closer to give your community what you deserve.
Thank you so much. Thank you. Thank you.
Yeah. I know you have one thing. We have to wrap up, but hurry up, Sarah. I
Yes,
want
the
to Sarah.
gift question. So what I'd like to know on behalf of Courtney Gensimer texting me, what can the greater HEDS community, especially online, do to help support the rare genetically defined conditions?
Absolutely. I think first and foremost, just try to understand us. I know that it sounds like, hey, wait, we're all in this together. It hasn't felt like that to us, right? We don't have that same like, rah, rah, let's fight together, because being together has harmed us, right? So that's not to say it's anybody with hypermobile EDS fault. Take yourself out of it. It has nothing to do with you or your diagnosis. I believe you. I hear you. Nothing to do with it. We are working in a system just by way of the prevalence, again, where your friends with rare types have not felt a part of the community. So try to take yourself and your diagnosis out of it and just hold our hand. Just listen to what we have to say. I think hopefully we had a lot more in common with what I just shared than what you may see online when it seems like two sides against each other. We are all cogs on the same broken axle. So just hold our hands and listen. That's all.
And thank you so much, Abby. I can't. And just by the way, this was a wonderful day, but we have a whole day tomorrow. Abby is also going to be speaking a little bit tomorrow too. So more questions there if you have,
will
this
hang
is
out
just
for a bit.
continuing tomorrow. So I just want to take this moment to thank everybody here, all my colleagues, all the speakers, all the patients. This is huge. Dr. Knight, everybody online. And we are starting at 8 a.m. tomorrow morning here in Penn Hall, breakout rooms, and virtual as well. So have a good night. Thank you.